To the scrutiny meeting today. There's a bit of housekeeping before we start. So welcome to the Mental Health Select Committee. Before we start these proceedings, may I bring your attention to some housekeeping matters. There is no expected fire alarm today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the Council House. This select review will be broadcast live to the internet and will be capable of subsequent repeated viewing. By entering the Warspite room, committee members are consenting to being filmed throughout the meeting and to the use of those recordings for webcasting. Please, can I ask that you speak clearly and directly into your microphone when addressing the meeting so that the online participants and the public can hear, and that it is switched off when you are not using it, and that your mobile devices are turned to silent. Now, hardest task of the day, to appoint a chair and vice chair for this particular select committee. So, can I have nominations for chair? Jemima.
May I nominate you for chair, Mary?
Is there a seconder for that? Yeah, thank you very much, Sue. Vice chair, I'd like to propose Natalie Harrison. Can I have a seconder, please? Thank you, Kathy. Great stuff. Would you like to come on over, Natalie? That would be great. So, apologies. Have we had any apologies, please?
Just Councillor excuse me.
Mr. Murphy?
Councillor Murphy, Chair. Thank you.
Thank you. We'll note that. So, in regards to today's agenda, any declarations of interest? Lauren.
Thank you, Chair. I am a listening volunteer with Samaritans, just in case they're referenced during today's discussion.
Thanks very much. And I must admit, I'm being very cheeky and calling you all by your first names, but unfortunately, I'm not good with remembering surnames. That's my excuse. So I hope you're all happy with that. But if anybody would be offended if I call them by their first name, please tell me now. Councillor Harrison.
Thank you, Chair. It hasn't been named, but just in case it comes up, I think because of the topic on mental health, I'd like to declare a personal interest. My employer is community builders, so therefore that may come up in the conversation.
Okay,
thank you.
Certainly. Thank you very much. Councillor Noble.
I'd like to declare an interest. I work for Plymouth Hospital's NHS Trust, although not in a medical.
Thank you. No, we will note that. Thanks very much. Right, I'm going to go back to normal and start calling you by your first names again. Okay, thanks very much indeed. Chair's urgent business. I haven't got any as far as I'm aware, so it can't be that urgent. Okay, so item 5, there's the outline of the purpose and scope of this review, which hopefully you're all aware of. And we will then move on now to the main body of the meeting. We have a fair number of officers here. Some of you will know some of them, some of you won't. So I'm going to get the officers to introduce themselves as they start their piece. But I would like to say that we've got Councillor Mahoney, the Cabinet member, here with us. And Tony, I think some of you will have known. Tony is from Health Watch. And then I'll leave the officers to introduce themselves as they go. So, handing over to Sarah and Kamal, please.
Thank you, Chair. Hello, everyone. I'm Kamal Patel. I'm a Public Health Registrar with the Public Health team at Plymouth City Council.
And I'm Sarah Lees. I'm one of the Public Health Consultants.
And we're just going to start the proceedings today with a bit of kind of background, a bit of overview, looking at the mental health and the impact of the pandemic on mental health, and then looking at some data on self-harm and suicide. So I thought it would be useful to start today with just a definition of mental health, and I think it means and well-being. It means different things to different people, but I've put here kind of a positive definition in terms of it's more than just the absence of mental disorders, and it's about people being able to realise their own abilities, be able to cope with the stresses of life, be productive, contribute to communities. and and one way of conceptualizing mental health and some of the work we do in public mental health is thinking about the challenges that someone faces and the resources that they have to meet those challenges, and being able to have those resources, which can be physical, psychological, social, financial, is really where someone's well-being can be maintained. So in June 2021, I presented a mental health needs assessment to the Health and Wellbeing Board, and this was looking at the impact of the COVID-19 pandemic on health and wellbeing, appreciating that we were still in quite a significant part of the pandemic at the time, but it was very important to look forward and proactively review mental health. And many of those themes are being realised as time has passed, and we're going to present the findings from that need assessment with some additional context in terms of the current, more current local context. So nationally, it was found that population mental health and wellbeing worsened at the start of the pandemic in spring 2022 across the whole population of England. And then what followed were many ups and downs in population mental health, and generally that coincided with the periods of lockdown. But it's important also to say that much of the data shows that recoveries in population mental health during the easing of lockdowns were generally not to the baseline of of previously. And that really talks about the whole population, but as we all know, there are many population groups that were more greatly affected by the pandemic, and I've listed a number of those groups that were found nationally to have a more severe impact of the pandemic on their own mental health. And I think I won't go through the list, but I think most people recognise many of these groups are people who are at risk before the pandemic of having potentially poor mental health. And so, really, one of the key themes in the need assessment was the widening or potential widening of inequalities and health inequalities, especially in mental health, as a result of the COVID-19 pandemic. And so I think we are, speaking to providers, and you'll hear a lot more about this during the rest of this proceedings, but we are seeing the impact of increased demand in mental health through the system. But it's also important to note that we may not be seeing the full extent of that so far, because of the wider environmental, socioeconomic impacts that continue to impact on mental health. And then there are also, as we all know, other national and global factors, such as the cost of living crisis and global conflict, that have kind of become much more significant in terms of their impact on mental health. And in a way, as the pandemic has waned and its impact on us has waned in terms of our mental health, some of these other factors have almost picked up where the pandemic left off in terms of affecting population level mental health. So in the needs assessment, I presented this forecast from the Centre for Mental Health, which again was in 2021, and it showed that there'll be a really significant rise in mental health need in England, predicting that about 20% of people will need new or additional mental health support, and the majority of that would be in people who have existing mental health conditions. And again, as I say, you'll hear a lot more from providers, but it does feel like we're seeing that increased need throughout the system. So here is some data, and I'll just talk through it briefly. So on the left, I have some of the key indicators of mental health. The first column says pre-pandemic, shows the figure for that indicator before the pandemic, so the most recent figure before the pandemic. And then on the right of the table shows the most recent figure that we have related to that. So I think the key things to show here are that the prevalence of common mental disorder, and this is for Plymouth specifically, sorry to say, so the prevalence of common mental disorder in Plymouth before the pandemic was significantly greater than the England average. So highlighted red means that it is significantly greater than the England average. and amber means it's not significantly different to the England average. And the other indicator for Plymouth that's worse than the national average would be emergency hospital admissions for intentional self-harm. The context there being that across the southwest generally, those two indicators are worse than the national average, and so Plymouth, although being out of line with England, is in line with our kind of regional neighbours on those. But for the other indicators, so general well-being scores, those low life satisfaction, low worthwhile score, low happiness, high anxiety, and then also the suicide rate in Plymouth are generally in line with the England average before the pandemic. And then moving to after the pandemic, or not after, but during, most recent figures show, a very minor change. Some have gone up, some have gone down. And so I think that really speaks to it being quite early to see the change. Lots of these figures are from 21, 22. And also this is population level. And so that often hides inequalities. And I think that's one of the key kind of outcomes of the needs assessment.
Joanna?
I wondered how you wanted to do questions, because I just wanted to ask something about that table. I don't know if you want me to wait to the end or...
Are you happy to take questions now with that, Joanna?
Okay. It's just about how it's collated, especially with the scores that that's obviously something that people who've presented with mental health issue answer, is it? Is that how it works?
So we're talking about the scores, the sort of second to fifth thing there. So those are from an ONS national surveys. So that's population level. It's not just people who have been in contact with mental health services. It's a population value, and it's measured annually through the ONS sample survey.
Thank you. So that's I'm interested to know how they do that then, because I've never been asked to do that. I just wonder how is it some random where they ring people?
They've got random allocated people that will respond to the ONS surveys. They do that across the whole country. A number of people from Plymouth population, a cross-sectional population, will be routinely answering those questions.
Okay, thank you.
Can I just ask, this is a different presentation to what we've got in our packs, so could I ask for the new slides to come to us, please? Thanks, Sarah.
So when we talk about mental health and the impact of wider factors on mental health, we often refer to risk factors and protective factors that influence mental health. And one of the key themes of the need assessment was that the pandemic and now the cost of living crisis is likely to have an adverse impact on many of these factors, especially for people in certain population groups who already had higher risk of poor mental health outcomes, and also for people with severe and enduring mental illness. And so part of the approach of public mental health is to strengthen those protective factors and minimise the risk factors in order for people to be able to meet the challenges of their lives. And I've just put a few of the risk factors on the left and protective factors on the left. Obviously, there'll be a lot more and it'll be different for different people, but here are some of the kind of key ones. And as you see, that they relate to much wider factors than just your health. It's about the conditions that you live, grow, work, and your community. As part of the needs assessment, I talked to local providers, and again, you'll hear a lot more from them directly, so I won't go into it too much, but many providers talked about an increase in the complexity of the needs of people presenting to their services in the pandemic compared to before. They talked about a change in delivery, a prompt change in delivery to online offers and then blended face-to-face and online, and new services being provided in order to meet those needs. So the recommendations from the needs assessment was that the it sought a commitment from the system to embed a more preventative approach throughout the whole mental health system in order to reduce demand on health services. And this approach was based on the principles of the Prevention Concordat for Better Mental Health, which is a national what was then Public Health England initiative. And it really looks at focusing on the wider determinants of health, protective and risk factors, and involving people with lived experience in service design and everything we do, really. Sarah. Hand over to Sarah.
Okay, thanks, Kamal. So I'm just going to pick out a couple of things really around self-harm and around suicide and suicide prevention, which I think is helpful in scene setting for you. So I suppose of relevance to us is the Southwest has always been in the a claims frame we're not really happy with. Is the top two, if you like, in terms of the rate of self-harm in the country. So we've always been an outlier, along with the Northeast, strangely, as the two regions which have always had well above average rates of self-harm. That's a long-standing position, as I've said, and there has been some regional work, and that work is ongoing, looking at potential reasons for that. There are various hypotheses that are being looked at by Department of Health and OHID, now our Office of Health in Improvement and Disparities. But there's some thought that maybe some of the coding, there might be some coding issues in that, which actually make it maybe worse than it is. But I think it's of relevance for us to know that that's a long-standing position for the region, the whole of the region. One of the things we're doing in response to that for more locally is with Devon and Torbay councils and with our colleagues in the ICB, in the integrated care or system really, we're now currently undertaking an all-age self-harm needs assessment for the whole population of the ICB, so including all of Plymouth, all age, and that piece of work is a funded piece of work which is going on, which will be completed this year, to really do a deep dive, if you like, into the needs of that, including some really good research that's already started and will be published with people with lived experience, and that's being focused in Torbay currently, so that will inform that. So we'll be have a much better picture this year, later this year, of actual of local needs, which I think is important that you know in terms of that. So just some brief ideas, really, I suppose, of where we sit on that. So this is Plymouth data for emergency hospital admissions for intentional self-harm in Plymouth. And we're the blue line and the red and yellow dots there. And the black line is the England rate. So you will see this goes back to 2010 on the bottom of the graph. It might be a bit small for you to see there, and goes up to 2020, 2021, which is the last full year of data. So basically what you'll see there is that our rate of emergency hospital admissions for intentional self-harm are above the England average and have remained so pretty much. And that difference is statistically significant. So that's what that shows us. I think it's always helpful for us to see, in the context particularly of our region, bearing in mind that the Southwest region is second highest, where our rates sit on that. So you will see the different local authorities on the left-hand side there, and we're about 2/3 of the way down there, and our rate. And you'll see we're relatively at the lower end of our region, of local authorities in the region, but we're still showing red because our rates are still significantly higher than the national average. And you'll see most of the local authorities are, apart from Cornwall, which is below, and Gloucestershire, which is in line. Okay, so whilst we're in a region of high, excess, if you like, above national average, we're not, we're relatively at the lower end of that. I think that's, and I think it's important to look at those hospital admissions for self-harm as well for younger people. So those aged 10 to 24 years, we do collect data on that as well and have the trend for that. So again, what you will see there, it's the same time period, 2010 up to 2020-21, is again we are above national average. There was only one point when we were kind of in line, but we remain above national average for that age range as well. And again, I've provided that in the context of our region. So again, if we look at that, you'll see similarly, the whole of the region actually is either above or in line, just one, Cornwall in line with national average for younger people and self-harm. But again, we're at the lower end of those other authorities in the region. So I thought it was important just to put that bit of context for you around self-harm. I'm going to try and do the same now for deaths by suicide and deaths of undetermined intent. I think it's really important when we talk about and think about these that there is if you like, a legal and taken definition, which is that the suicide death or a death from intentional self-harm is of those aged 10 years and over, and that's deaths caused by injury, poisoning, where the intent was, and it also includes undetermined intent. So where the intent is not determined and is not determined for those aged 15 and over. Okay. A suicide death is only a suicide when a coroner has at inquest made that judgment and that they've concluded that that person intentionally took their own life. And in 2018, the standard of proof that the coronial process for suicide looked at changed. And this is important when we look at trends in data. Before 2018, if you like, the burden of proof to make that decision or that by the coroner was a criminal level of proof, and this is very historical. So beyond all reasonable doubt, the coroner had to believe beyond all reasonable doubt this person intended to take their life. And in mid-2018, that changed to what we call the civil level of proof, which is on the balance of probabilities. So 51%, or more, did this person mean to take their own life? And I think that you'll understand why that's important in terms of numbers and things going forward. And undetermined intent tends to be what you might recognise as being called open or narrative verdicts from a coroner, and those are counted. And we monitor these very carefully, and we look at the data over a 3-year rolling average. And that's because the numbers are small, and so year on year you might have differences which might look very big, but actually because the numbers are very small anyway, it's safest to make a judgment in terms of trend by looking at a 3-year rolling average, and that, if you like, smooths out some of those annual differences that can happen for maybe no necessary reason, and enables us to have a rate that we can compare with other areas and with the national average. So that's why we look at a 3-year rolling number. And the one thing I want to say as well is it's important for us to know that obviously the pandemic had a serious impact on the coronial process. So, coroners' courts did not sit for a long period of time in the pandemic, which meant that there's a whole period of time where decisions weren't made. And so, if you like, we've stacked up the need for inquests and those decisions to be made. So there's a longer time lag now between when maybe a death may have occurred, and there's a catch-up process, which, if you like, will put a delay in the system. So if you can imagine we didn't have any decisions for about 8 months, then those are all being pushed back. And so maybe, and through the process of trying to catch up, there's a reason why we will have maybe small numbers in one year and larger numbers in another. That may just be due to that coronial process challenge. So this graph shows the trend in mortality from suicide and undetermined intent in England and in Plymouth. So if you see that the green line in the middle there, the solid line is people in Plymouth who have, that's the rate per 100,000 who've died by suicide. And we've got lots of data. So this data goes all the way back to 2001 to 2003, where we've been monitoring this. And the green dash line, if you can see that, I'm not sure how clear that is for you, but that is the England rate. Okay, so the blue line is for men, and the green line, the red line is for women. So you will see from that, over the last 10 years, more or less, we've been closer to being in line and pretty much in line with England average in terms of rate. For a period of about 10 years before that, we were significantly above. And the period, you know, in the early 2000s, again, we were more in line with that if you look at our population. The other things of note, I would say, is for women, we more closely follow the national average. And for men, we are, as you say, we will see there, we have a period where it's more significantly above, but again, pretty much in line currently. And again, I've just, for purposes of showing that really, so this is the rate for the last 3-year period for the data that we have, shows where we're at in terms of our regional colleagues. So you'll see Plymouth there, we're towards the bottom third in terms of our rate. So the last measured rate in that 3-year rate is 10.7 per 100,000, which is not statistically significantly different from the England average. And I think it's just what we're looking at is, and what I think the papers you've been provided with is the last summary for the last full 3-year data that we have. And this shows in red the female deaths by suicide and undetermined intent, and in blue the male, and then the age breakdown there. So you will see that nationally and locally, most commonly suicide deaths are in, if you like, in middle age, but we have seen a shift in the last 6 years, particularly in terms of more deaths in younger people, and that's a national trend that we've been seeing as well. So you'll see that that's been happening there. So that's what that is showing us. These are small numbers, as you will see there, so the numbers of deaths along the bottom there, but not insignificant. Obviously, every death is one we want to try and prevent. And then I put up a deaths by suicide in the last 3 years map here on our wards. And this is not, I just want to be really clear what this shows. My reason for showing you this is that over the last 3 years, every ward in our city has been impacted by suicide, by deaths by suicide. It is a issue across our population and for all of our city. The red dots don't show clusters. I'm just going to say that tonight. These are not clusters of deaths. These are just the postcode of residents of people who've died. But I think the most important thing for us to know is that it is something that impacts the whole of our city, because each death will impact, on average, between 60 and 80 people through families, colleagues, community. And so it is truly a citywide issue for us. Okay. So hopefully, what I hope Kamal and I have delivered there for you is a little bit of background in terms of the mental health challenges and needs that we face as a city. So before the pandemic, we know that in terms of our needs for mental health and the challenges, the risk factors that we face as a population are higher than national average. That was being represented before the pandemic in higher levels of need being expressed and demand into our system. The impact of the pandemic and of the cost of living crisis and general conflict and stuff have, as Kamal has outlined, increased the challenges that our population face, and to some extent maybe even reduce some of their resources to meet those challenges. And so that's very important, I think, to recognise in terms of how we support our population to meet those challenges. We are seeing now the predicted increased demand through and need being presented into our system, and throughout the next 2 days I'm sure our providers will talk to you about that, and you can speak to them about what they are seeing. The last few years have been an absolute challenge in terms of inequalities. We know that from the pandemic, both in terms of physical health, but as we're focusing on today, in terms of mental health and well-being in our population. So we are seeing those impacts, although it is still early in the process to be seeing that, and we're likely to see more. So we have a challenge system, and in public health, obviously, we're encouraging and supporting that very strong preventative approach, and we'll go a bit more into that at our next session in terms of trying to maintain people's well-being and to reduce that demand going into our services. So hopefully that's a good introduction for you, and we'll happily take any other questions. Thank you.
Thank you, Sarah and Kamal. Any other questions you wanted to clarify? Jemima?
It's not a clarification, really. The thing I find interesting about the pandemic is that it's something that we all went through, and because we all went through it, I don't know if some people recognise that actually their individual experience of it could have been traumatic and affected their mental health, but because it was something that we all, I don't know if I'm making sense, but because it was a universal experience, some people had a better pandemic than others. I know that. Whether they feel that they are able to access help because it's something we all went through. Does that make sense? And I just wonder how that is going to pan out over the next few years, that people don't actually recognise that one of the reasons possibly that they're feeling like they're feeling is because of the pandemic, and that their individual experience of it is valid, and they are entitled to access support. Do you know what I mean? I feel because we all went through it that maybe some people don't feel able to say, actually, this has really affected me.
Yeah, so I think, so my take on that is, and I'm sure you'll hear a lot about it in the next few days, there's still a massive amount of stigma attached to mental health and wellbeing and talking about that. And we know, thankfully, in the public domain now, there's a lot more openness around talking and approaching about that. I think in terms of the pandemic, you're quite right, people went through it. It almost gave us, for some people who may have been afraid of that stigma, a reason to talk about how you were feeling in the pandemic, to share that with your family, friends, neighbour, whoever you were, your support circle were. But equally, some people were even more isolated than they were before and didn't have that to share their experience and feeling with. And I think the whole reason why we're saying it's still very early to see the full impacts of the pandemic are what we've seen before in things like economic shocks, global economic shocks. It's normally kind of 2, 3, 4 years later where you start to see what you think is the real true effect. So, I mean, I think we're speculating rather than talking evidence, but I absolutely understand what you're saying. I think there is undoubtedly some people will still maybe not be computing that. And I think the risk for us really is, the cost of living crisis we've now got on top of that. If you're not aware of how you're being challenged, and then there are further challenges coming, then it is difficult, yeah.
Jemima?
Just I was going back to the suicide statistics and the self-harm statistics, and where you told us that we're the second highest, the Southwest is the second highest and has been for a long time. And I just wondered what has been done to look into why that is. What are some of the factors that are causing that?
So one of the key things that the Department of Health is looking at is how our hospital data, because most of this comes from hospital, how they're using the coding. There is a hypothesis that maybe some of the, and this isn't a blame, but some of the hospitals or the hospitals in the Southwest region code differently and maybe are more risk averse in terms of how they code certain things, but also how do you code self-harm through alcohol abuse? How do you code that? So there's quite a big project at regional level and national looking at some of that coding and how how that's doing. So there's been a little bit of work done on that and kind of doing that. I think that might account for some of it. Is my gut feeling it might be that we're a bit of an anomaly from doing that. So that's kind of going on. And as I said, at a Devon level, what we've decided to do is to do this in-depth needs assessment and this piece of research with people with lived experience and find out, well, whatever our numbers are, to be honest, let's park that and say, what are we seeing in terms of needs of people and how are those people experiencing our system and the offers that are there to support them, and what can we learn from that to make our system as good as it can be. So I think to a certain extent we have to note that in the context of our rates are higher than national average and statistically higher, but we're not the worst in our region and our region is an outlier. So there's something around understanding that That's not to say we're not worried or concerned about it. We absolutely are. And I think the all-age needs assessment will really help us know more going forward. And so that's really what I'd say on that. I think in terms of the suicide, we've got a lot of data over time now to monitor that, and we haven't seen any significant change in the rate, at the moment through the pandemic. But again, as we know that, it's still early days.
Thank you. I've got Lauren and then Sue.
Thank you, and thank you both for that introduction. It was really thorough and helpful. In terms of the self-harm audit, can you give us any kind of preliminary data understanding of which groups are more prone to coming to us with those issues, just so we can help understand where we might need to, where support is greatest, essentially?
So I suppose with self-harm, it obviously tends to start to manifest itself in young people in teenage years. So we know we particularly do that, but we also know that those people most at risk from their self-harm are those that self-harm for extended periods of their life. Many people, if they're self-harming in younger age, will find different ways of coping with the stress that is leading them to self-harm as they mature, gain more life experience, and sort of do that. But some people will, because of that trauma, will self-harm lifelong. We don't really, we do know that more young women self-harm than young men, but part of our needs assessment locally is really to unpick some of that around our local populations. So we're doing this as across Devon, Torbay and Plymouth, but also those populations very much individually as well. So I think we can do that and look at that. So I think it's, I would say we're not an outlier in any context nationally in terms of groups impacted. And also we should probably just say that in terms of self-harm, much self-harm is not presented into the health system, and we always need to be aware of that as well. So I think the research that's going on with people with lived experience is really going to be valuable as well to help us understand.
Thank you. Sue.
Thank you, Chair. Has any work been done? I mean, obviously this whole entire focus is on health, but has anything been done about matching the economic situation in Plymouth to how people live or go without? I just wondered about, I guess you sum it up as poverty, and I wondered if anything work had been done on that, because you're not going to eat that well if you haven't got the money. You're not going to have a holiday if you haven't got the money. I mean, I live in a place where loads of people can't afford stuff, and well, I mean, there's affluent bits cheap by jar, but it marks out the poorer people quite markedly when you live like that. So I just wondered if the economics of poverty, the economics of deprivation, had actually been matched to, as you do, pure health.
So, absolutely correct. We know that in Plymouth, 30% of our population live in the 20% most deprived neighbourhoods of England. So we have a higher proportion of deprived communities measured by the index of multiple deprivation, which takes into account communities, crime, health, employment, housing, kind of the measures that, those wider determinants. So we are absolutely more affected by that, and that does show out in our local data and nationally in terms of adverse health outcomes and mental health outcomes for people who feel financially insecure. That's an anxiety, a stress that's with you all the time. If sense of community, sense of safety, these factors really do have an impact, especially if you've grown up with that. You have a different state of well-being than if you haven't, I think, and that goes back to those challenges being higher, and so you need more resources to meet those, and often you don't have those as much because of your deprivation. So that's not to say it's true for everybody, but in general, that's the pattern that we might see. So absolutely, we do see high level of need, and that's across mental health needs and physical health, cardiovascular disease, across our more deprived communities in Plymouth. Yeah.
Thank you. taking Kathy, and then we're going to move on to the next item. All right, Kathy.
Yeah. My question is regarding drug use. Has there been any, what studies have been carried out about drug use on mental health? And in fact, whether drug use is caused by poor mental health, and what the effect is on the statistics of suicide and self-harm?
Okay, gosh, there's a lot in that for me to answer as briefly and succinctly as I can. So many people who have a substance misuse issue also have a mental health issue. That is well recorded, well known. And so in our Plymouth Alliance for Complex Lives, people with complex lives, we very much try and have no wrong front door, so that anybody who presents, whether with a mental health challenge or issue or a drug challenge, gets the service they want, and very much those services working together. So there is commonality, but it's not the totality of that. And so, you know, somebody with a substance misuse problem and a mental health problem can receive services and support to help with both of those. They're not, one doesn't necessarily drive the other, and sometimes having a mental health issue might lead to substance misuse, sometimes the other way around. So they're very interlinked, and causation is very hard to show, especially if you put something like homelessness in the mix there as well, which is often very much as well. There's a, if you like, that whole triangle, and that's what our system tries to look at, is to support people in all of those situations. So it's not a kind of necessarily an easy causation. One, it's a very complex issue to unpick that as to what is the, you know, what is the, what, and in fact you have to address all of that. It is what it tells us, which is what we try and do through the Plymouth Alliance for Complex Needs on that. In terms of suicide and self-harm, then obviously, as I said, one of the challenges is if you are drinking to a level that's unhelpful, is what is the purpose of that? And as we've said, there's this kind of thought around coding. Is that because I'm trying to harm myself? Or is that not in my frame of mind, but I've got an addiction and I'm struggling to cope with that? And we don't, you know, that again is so complex to unpick and sort of report. But it is, you know, certainly alcohol is an impact. In terms of suicide deaths, as a local public health team, we very much look at alcohol-related deaths, drug-related deaths and suicide deaths, all of which may be determined and maybe a verdict from the coroner of unexpected or unexplained deaths where an inquest is held. And so as well as monitoring suicide, we do monitor things like alcohol-related and drug-related deaths. And we refer to that as kind of avoidable deaths, where we'd like to do that. And we do that, one, to see what the impacts are, and two, what is the learning for us to put back into the system to try and reduce those numbers of deaths. And so I suppose most noticeably, I suppose, in the last kind of most recent years, is we have nationally and locally seen an increase in drug-related deaths.
Thank you. We can pull, you know, develop that as we go on, but okay, we're over time now, so I'm going to move on. Okay, because we've got the whole 2 days to unpick. Thank you. Thanks very much for that, Sarah and Kamal. I appreciate that. And we're going to move to Tony now. Thank you very much for sending your mental health services report, and we look forward to hearing from you. Thank you.
Thank you, Chair. Whilst I just get to grips with the technology. Okay, so hopefully you've had a chance to read the report that we presented to committee around patient experience, and I just want to summarise some of that in a quick PowerPoint presentation. So looking at the actual data first, the period that this feedback covers is from January 2021 through to the end of January this year, so just over 2 years. But I think the important thing is it covers when we were in lockdown, moving out of lockdown, moving back into lockdown, vaccination, and then coming out the other end. And I think for me, although the numbers over the 2 years appear low, it's actually the feedback that people are saying it has been relatively consistent throughout that 2 year period. So in terms of breakdown of that feedback against services, I've kind of summarised that into this table there for you. It was predominantly around adult mental health, with children's and adult mental health service coming in below that. In terms of sentiment, the majority of the sentiment has been of a negative context, and the themes that have come out of that have been mainly access to services. So what we're talking about really is waiting times for a referral, waiting times for treatment, and even within that, when under treatment, is the length of time between calls and contact. Treatment and care has also had a bit of a context with it, in terms that people feel that the treatment and care being received, because some of it is being done remotely, actually isn't suitable for them, and they feel unheard. Continuity and integration of care has also come up, and really that sort of continuity between GP and mental health services. And then finally, communication, and the communication kind of hits in several ways. Ooh, that doesn't look good. All right. I'll tell you what happened on internet connectivity.
I'm just going to share it for you.
Okay, thanks. So hopefully we're up to yeah, if you can move to the next slide, please. So I thought what I would try and do is summarise some of those points in feedback that we've received. So what people are telling us effectively. Can you go back up one, please, Elliot? I think we've gone one too far. Yeah, that's fine, thanks. So individuals have been telling us that they wait long times for initial appointments from a referrer, and find out they don't meet service criteria. And I think that is quite true with some of the low-level talking therapy services. And at this point, I would like to say that, we receive feedback across Devon, Plymouth and Torbay, and whilst we're presenting the feedback for Plymouth, it's not dissimilar for Devon and Torbay as well. So, which kind of bears out some of Sarah's points around the southwest region in a way. I think what we get from some of the feedback is that people wait, and they wait, and they're in a little bit of difficulty, and probably a little bit emotionally unwell, only to get through to an assessment and then told that the service isn't suitable for them. If you move on to the next slide, please. Quality of care, staff attitudes, waiting times, and treatment or support following assessment were all rated poor as well. And respondents have suggested that there's confusion, again feeling unheard, and the system is too complex. And I think what they mean by that is that if you're moving between various parts of the system, there's different processes and they don't naturally join together, and that makes it more difficult for the patient flow through that. And I guess, again, communications kind of comes in again. The GP will still have a vested view in the patient, and maybe the communication isn't always coming through to the GP to support as well. Next slide, please. Equally, individuals felt the treatments are impersonal. They are sometimes delivered by telephone or online in groups, which they felt was inappropriate for their condition. There's been a lack of consistency with the, if you like, clinical staff that they're seeing, and that is leading to different views in a way that for their treatment pathway. It should be noted also that in terms of mental health services, along with other health and social care services, recruitment to positions has been challenging, certainly since the pandemic, and that continues to be the case, and that is probably adding to some of these issues. We've equally heard a little bit of feedback around people with autism or learning disabilities or ADHD, and their needs not being met as well, and part of that, they are saying, is understanding of their condition. Next slide, please. Looking at children's services, then access to services, particularly CAMS, has been long, and parents are saying that because of that, they feel there's been a lack of support for them on the process to getting an assessment and then once in treatment. And I think, again, that has been down to staffing issues predominantly, although from meetings that I've attended recently, I believe the CAMS picture is starting to improve. However, in amongst all the negativity, there was some positive comments, and I think where it's really worked is where the individual has been put in the centre of everything that's going around. So it's person-centred care, it's consistent support to those individuals, and they're very clear on their situation, the treatment that's being offered, and the pathway that they're on and where that's leading to. So, you know, there are some shining lights in there where it does go well. But unfortunately, I think that's where we need to get to for the majority of care that goes on in not only mental health, but in some parts of the health and social care service as well. Next slide, please, Annie. Thanks. So our observations over this is that waiting times are long, treatments feel impersonal, especially those delivered either by telephone or online in groups. Poor care has been associated with pathways to care being overwhelming, complex issues, resulting in individuals being referred to many different authorities and various different services and given up due to a complex system. Good care is associated with individuals and places that have offered person-centred care, consistent support to individuals. And from the commentary we have received, there appears to be a gap provision between talking therapies and specialist services, and that people that don't fit the criteria for either of those are kind of left in a grey area of where they can go for support and what support is on offer. Next slide, please. And rounding up, I just want to draw the committee's attention to some other reports that have been produced. So last year, Health Watch Plymouth produced a report based on the pandemic around access to children's and young people services. The key findings on that were long waiting times for appointments and for follow-up appointments, poor or lack of communication, and the COVID pandemic exacerbated already long waiting times. We're not really seeing that any different today as we've come out, apart from the fact that the CAMS service, the waiting time is actually on an improving trajectory. And next one, please, Elliot. And then I find this is an interesting report from Health Watch England. So back in the late summer, Health Watch England decided to do a tracker poll nationally that would be representative of the population of England. Their plan was to do surveys in October, December, late January and March of 2,000 people. They produced some initial findings following the October and January report, and it's the second and third bullet point there, I think, that is the interesting one, because it kind of tallies in with some of Sarah and Kamal's comments. Over a third of people said the cost of living crisis had affected their mental health, and women are disproportionately affected by the spiralling costs, with 35% compared to 26% of men saying their mental health has got worse. And then the final one from that initial look was the number of appointments that were not being taken up because the travel costs had doubled between October and November. Health Watch England are due to publish their findings in April, and I will make sure the committee get a copy of the report of that. And next slide. And I'm happy to take any questions.
Tony, thank you again, and thank you to your team that have done the survey. It's always useful and for this committee to read these reports. Elliot, if we can have the slide deck as well, sort of sent out to all of us, I think that would be quite useful as well, because it summarises it nicely, and then we can consider it later. But it's amazing how this last few years have affected Plymouth as a whole, isn't it? And I don't think, when you think about it individually, you just don't think, oh, well, not too much of a problem, or has been a problem, whatever. But you don't, once you put it all together, it makes quite a little pot that's bubbling along there, isn't it, really? And the fact that things haven't got back to normal as far as some GP practices are concerned is another stress on the population, no two ways about it. So thank you, Tony, for that. Any questions for Tony? Natalie?
Thank you, Tony. Very comprehensive. Unfortunately, we didn't get it before the meeting, so only literally as we came in. So it would be lovely to get these in advance so we could really look at it. They were on the table. They weren't. We didn't have them before. My question is initially about CAMS. You say the picture is improving and that the waiting times are reducing. Have you any idea on what the waiting times are now? And or is it what else is improving within CAMS?
So from NHS Devon meetings I've been in, and catch-up meetings with managers of the service, the picture is improving from what was a quite extensive long wait, and I think it's down to weeks rather than months now. Although I can't give you an exact average at the moment.
In fact, they're here this afternoon, Cam, so we can make sure that we find that out. Okay. Will, and then Lauren.
It's quite interesting. You've got sort of the qualitative comments from people. Have these comments? You mentioned this more positive comment. I suppose people are going to give feedback of experiences they think need improvement. But the positive comments you said were the services around the person, but have any models of service quality been looked at as, you know, sorting these things like the gap model of service quality, so between, you know, somebody's expectations of a service and what they perceive they receive, differences between the provider's expectation of what the provider thinks they're providing and what the you know, customer or the patient thinks they're receiving. Um, it's a model used in business and business in services, rating services in business. How are models like that being used to sort of sort and identify those gaps?
So I guess the short answer from a Health Watch point of view to this point is no. However, we have recently finished what we call phase one of access to low-level mental health services. So we're looking predominantly at sort of counselling and talking therapies. We're currently analysing that feedback at the moment with a view to having a report out at the end of the month. But that will lead on to further work that we're hoping to engage with Live Well with, but not only them, but also Devon Partnership Trust in Devon, because the survey was conducted across the whole county. So moving forward, that is certainly an element what we can look at in terms of identifying that sort of provider expectation, patient expectation, and what is there the gap in that.
Thank you. So I've had several friends try to access mental health services in Plymouth, and the main issue that they're reporting to me is that when they're offered services, they're taking place during the day, so during working hours, which they then can't attend due to working commitments. I'm just wondering if that's something that's been captured in your kind of data here, and whether there is provision for like out of hours care or like growing that service at all.
No, again, I think when the public contact us, invariably, irrespective of which health or social care service they want to talk about, it's because they just want to talk about their experience. And sometimes it comes up, depending on the service that's being talked about, around access times and that. But in this particular feedback we've got here, I can't recall anything in the commentary at all that said I couldn't access because of X, Y, or Z.
Let's keep that question in your mind for when we have them here tomorrow. Okay, that'd be great. Jemima.
Thank you. Thanks, Tony. It's a really good report. I mean, I think that top bit of the table, adult mental health services, the feedback about that is quite shocking. And, you know, I'm sure there's a bias around if you've had a negative experience, you're more likely to want to share that and all the rest of it. But even so, it's pretty stark. And I just wondered what your thoughts are on why we're in this place. Are we talking about resources? Are we talking about staffing? What are we talking about? If we suddenly had a whole load of money, what could we do that would impact on these experiences? And also, you know, the positive experiences are really positive. So there is good things happening. And what can we do to kind of take that and make that more people's experience of experiencing these and accessing these services?
So I think, yes, in terms of resources, then I think staffing is going to be one of the main things, and I think that's is certainly a Devon-wide situation in terms of mental health. For me, the community mental health framework is just about to be fully hitting the streets. We've seen supportive roles put into primary care networks with mental health specialists to ease some of the workload for GPs, to make the referrals more succinct into the right service, but equally to join up some of that continuity of care, that has really only just taken off. So I think that'll be a while before we see how that's performing and the benefits it's hoped to perceive. I think the integrated care system is a step in the right direction in terms of Live Well and Devon Partnership Trust trying to provide services that are consistent across the whole of Devon. And they talk about putting the person in the centre of all that. And I think for me, everything should be around the person. You get the person-centred care right, irrespective of what condition we're looking at, whether it's health, whether it's mental well-being, whether it's to do with social care, and then the outcomes should naturally flow from that and be more positive.
It's kind of a follow-up. It's a double one, actually. The other thing that really jumped out to me was when you talked about how people are wait to get an assessment and then told they don't meet the threshold, and so they're having this really long wait, and then to be told, well, actually, we can't help you or whatever. And I think, I don't know what a recommendation might be around that, but I just think that seems really problematic. And if we could do something to speed that up for people, because that must be such a dispiriting, disheartening process. And I wondered how these responses are shared with providers. How do they hear this stuff, good and bad?
So to pick up the first point around assessments, people can self-refer into talking therapies, and I think they have an expectation because they've referred in that they will be seen and treated, and I'm not convinced that the information that's available for them to make that self-referral is probably managing expectations enough. And that's potentially one area. And I think also with a GP referral in, there's a knowledge there for the GP of what the services provide. And I think that's a little bit inconsistent, but hopefully the additional role that's put into primary care networks will alleviate some of that from the GP perspective. In terms of our feedback, we do talk to providers and we do give them the information. In terms of Live Well, I have regular catch-ups around children's mental health, and I also have regular catch-ups with Sarah Mitchell as well, where we can explore some of these pieces of feedback. If something that comes into us that is that really needs actioning before that, then we generally work with the customer services team, or up in Derriford it would be the PALS team, so that sort of level to push that feedback in with the individual's consent.
And likewise, Jemima, keep that in mind as well for tomorrow when Sarah comes along. That would be really useful. Tony, as usual, thank you very much indeed, and thank you to the team that do the research with you in Health Watch. You know, the volunteers that work with you are worth their weight in gold, so we do appreciate that. And we will look forward to hearing the fuller report as it becomes available, so thank you very much. We're now going to have 2 seconds while we do a quick shuffle around. And welcome to the Youth Parliament team. It'll be great to hear from you. Okay. before we move on with this session, can I just remind people that they need to keep thinking about in their storing any recommendations. But if there's something that's really burning, let us know. I don't want you to forget it by the end of the day. I appreciate it's a long day. So if there is something that you think about, do sort of tell us at the end of the session, and then even if it's just a couple of words or a phrase, and then we can flesh it out later. Okay, is that all right, folks? Okay, so welcome. I'm going to let you introduce yourselves because that's a lot easier. Obviously, I know one of you a little bit better than the other, well, in fact, two of you a little bit better than the other two. So it'd be nice to hear from you. So Jenny, do you want to start? Because you're the person that tries to get this organised, and we do appreciate how much effort it takes into running the Youth Parliament. So thank you.
Thank you. My name's Jenny Way, and I am the lead worker for Youth Parliament for Plymouth.
Hi, I'm Sunny Davies. I'm one of the deputy members of Youth Parliament for Plymouth. And yeah.
Hi, I'm Lydia, and I'm a member of Plymouth Youth Cabinet.
I'm Sophia, and I'm also a deputy elected member for Youth Parliament.
You've kindly given us a report. Have you got a presentation, or do we want to speak to the report? You're going to need to keep, if you speak, you're going to need to press the mic so that we can hear you, okay? And obviously all the people out there as well. So bring them a bit closer to you. That's great. Thank you. The floor is yours.
Okay, so we're members of Plymouth Youth Parliament, and last year we ran some focus groups with young people of Plymouth surrounding health and wellbeing. So we basically just wanted to share the process and the findings on such an important matter.
Before that, we were just going to talk through a little bit about Youth Parliament and what we are for those who might not have a full understanding. So last year there were 4 elected members that got elected, 2 of which being me and Sunny. You get lots of opportunities to work on your campaigns throughout the year and go to places like London, Bristol, Hull, Exeter. So yeah, it's really cool.
Yeah, so 4 campaigns were chosen last year. 2 were surrounding violence against women and young girls and kind of issues on that. 1 was on school uniform and the accessibility of school uniform. And finally, the last one was on climate change and environmental issues. Yeah.
So I'm a member of Plymouth Youth Cabinet, which is a citywide council made up of young people aged 11 to 19 who just want to make a difference in the local area. So I work closely with the elected members on their individual campaigns, but also on their national campaign, which this year was health and wellbeing. So like Sunny said, we do trips and things which builds our confidence and helps us work together as a team.
Yeah, so in the cabinet and the wider group, weekly on average we get about 20 to 30 young people, and we represent all views of Plymouth, so it's really important for us to have that interface with our constituents and communities, and that's why instead of just doing online surveys and things like that, we also do kind of sit down kind of surgeries, you could say, and that's what we've done for this report.
So we work really closely with a group called the British Youth Council, so they help us kind of build campaigns, and a lot of the trips and work that we do is linked with them, and that's why Lydia was saying about the national campaign, because that's where that comes from, is the British Youth Council, and that campaign this year was on health and wellbeing.
So yeah, as Sophia was saying, it's on health and wellbeing this year. So in February 2022, we had over 430,000 11 to 18-year-olds voting as part of a national Make Your Mark election in schools and colleges across the UK.
Yeah, and then like moving more closer, in Plymouth, I believe we get around 15,000 votes, or is that a bit over?
It was 10 last year.
10 last year, and hopefully goes up this year. Health and wellbeing was voted on a national level as being one of the most important issues young people face. And that basically means that nationally, all youth parliaments in all the kind of constituencies have to work on that alongside their local campaigns.
So in Plymouth last year, we found that social media was the top issue. Young people told us that it had a direct impact on their mental health and the well-being of themselves and their peers. They highlighted that they felt quite overwhelmed by social media, and some of them told us that they thought that they were developing or had developed a social media addiction.
So our focus group discussed how detrimental social media is to their mental health and well-being. So we discussed unrealistic body images, often portrayed by celebrities and influencers, who we're meant to look up to and idolise. And they promote the perfect lifestyle, but often that's very much edited and filtered with really unrealistic touch-ups, which promotes that negative body image. And young people feel a real need to try and match up with that. And that can create issues such as eating disorders amongst the younger generation.
And we also found that social media can be another kind of vessel for peer pressure. And with everybody using technology more, peer pressure kind of moved away from the personal sphere and into the kind of social media sphere. And it made it more easier for bullies and social groups to hide behind the kind of screens and the protections of social media rather than having it face to face.
So this isn't the only issue. Unfortunately, the effects of mental health issues is very much widespread. So another issue that we came across was school exams and stress within school. So schools and exams have a real direct impact on young people's health and well-being, especially since COVID and the aftermath of that. So schools often fail to tackle bullying concerns and often don't always prioritise mental health support, and access to counsellors in schools is really challenging with long waiting lists. And because of the growth of these and those people affected by it, we can't always afford to wait on these waiting lists.
Another issue that came up was the lack of funding. Now, obviously, we are in a cost of living crisis and budget cuts are apparent in every single sector, but young people are being directly impacted when it's not their fault and they don't have control over who they can vote for and who they choose to be elected. So we think it's really important that the local council and government look at the issues that are raised by young people, because it's their responsibility to look after those who don't have a voice.
Our fourth issue was the education around mental health and how young people were kind of educated to look after their mental health, what techniques they could use to improve it, and how to kind of spot the signs of a negative or downward trending mental health. So we thought that it would be useful if there was better signposting, leaflets, and then again, with issue 2 and 3, kind of funding and access to internal school counsellors, we think would be a much more better system.
Yeah, so the last issue was around drugs, alcohol and vaping. Young people thought that they needed a better education and to stop the kind of approach from telling us to not do it into a more like informational approach to express why, especially around vaping, because I feel like the consequences for that nobody really knows quite yet because it's quite a new issue. So yeah, I think young people wanted to know more about the consequences to help their peers to overcome drug, alcohol and vaping addictions.
So before we talk in depth about the results of our focus groups, we thought we'd just run you through the processes of those focus groups and how we communicated with the young people.
Yeah, so me and Lydia did a focus group together. We did a few of them. So what we did was we bought some A3 sheets with the questions on. We do have the questions here, so when you are asking us questions later, we have the results and questions that we asked. But yeah, we bought them in on A3 sheets with like sticky notes, and we stuck the questions to the walls and then chatted a bit first and then got stuck into the questions.
One of our main aims was to make young people feel really safe in that environment, as it's obviously a very vulnerable thing to talk about. So we brought snacks, like we had a chat before, made them feel like we were approachable people to talk to. And by using things like sticky notes, it made it anonymous. So we thought it made the results very valid and also very eye-opening.
We then wrote all of that information up into a report and made these stats and recommendations for you guys.
Yeah, so I'll just quickly run through the stats. Obviously, they're right in front of you, but we had 65% said there was a lack of funding, 50% of the focus groups did not think that services were accessible, and 60% said social media is detrimental. And this is kind of how we led into our kind of issues with this data. And then, yeah, the data is in front of you, so I'll leave you to that. And then we had verbal feedback from the people, which had to be recorded as well. So we found that 50% of young people are unaware that support facilities are available, and that they could seek help from their GP. On wait lists, we found that 76% of parents believe their child's mental health deteriorated while waiting for the support. And we found that over 70% of focus groups discussed the idea that people in power didn't really look out for their mental health and well-being, and they thought there was a kind of disconnect in their representation. Yeah.
Young people also felt that adults and people in power were too quick to judge when trying to understand the problems that they're facing, and they also thought that adults in school settings and like GP settings and mental health services needed more education and more training on issues like sexual assault, body dysmorphia, social media and transphobia, because they're quite difficult topics to talk about. Also, 70% of groups discussed the impact of drugs, alcohol and vaping, like we said before. They asked for more education for themselves and their peers, like I said, on vaping because it is so unknown. And they also thought that this would help to reduce more health issues later on in life. So, yeah.
So 60% of the groups highlighted that having a designated mental health worker within the schools would be really beneficial for young people, and those who already had access to the worker, it gave them some stability and help when needed, especially in order not to need more serious intervention and create strains on the system and services like CAMS. So one of the biggest issues was waiting lists for accessing specialist services. So CAMS waiting lists is at an all-time high, and young people can't get the right help and support when needed, which makes it very inaccessible for young people, which is obviously a major issue. So it's the people in this room that have the power to make these changes, and as young people in Plymouth, we want to reach out and start the conversation. So the young people have spoken, and we just need local and national leaders to listen.
So if there is anybody in this room that would like to come and talk to Youth Parliament about health and wellbeing or anything else, so yeah, if it's resonated with you, like Sunny said before, we do have around like 15 to 20 members every week that are really, really passionate about this topic and do have really good ideas if anyone is struggling with how to, breach the gap between adults and young people.
And then just to kind of close up as we move on to questions, we had online surveys as well, which we had around 355 completed surveys. And then in person, we managed to calculate that around 245 young people were involved in the focus groups. And that ranged from going into schools, into youth groups, and things like that. And then I think we'll move on to questions if anybody has any.
Thank you very much indeed, and it's always useful to know when we're invited to Youth Parliament meetings. And I know not everybody can manage to get to them, but it's always welcome. So Jenny, do you want to update us on that?
Yeah, just to say, Youth Parliament meets every Wednesday evening except during school holidays. So we don't, obviously young people know it's every week, and it's just an open offer. So if you're in the council house and you want to pop up, you're more than welcome to pop in. You don't need to drop me a message and say you come in. It's 5 till 6:30 every Wednesday night, but I just have it as open access for councillors because it's easier that way, like, unless it's a special event where, like tomorrow's results evening, where we ask people to obviously let us know they're attending, stuff like that. But normal sessions, it's open access. And just to say, when the young people did the focus groups, they didn't just go to the, like, do local, like our groups, because obviously within the participation team we run young safeguarders and children in care groups. They actually went out to the SEND group, they went out to Kiam youth group, they went to Honicknoll youth group. So they went out to access other groups that we, usually don't. They made sure that they represented the wider community. So we wrote to as many people as possible to see if we could come in as well. So.
Thank you. And Sarah, I'm just wondering whether it's worthwhile Dan getting in touch with them, because there's been a new report out about vaping, hasn't there?
I've just written down, Mary.
Yeah.
Back to Jenny and these lovely
Great
people,
minds
and
think
we'll
alike there.
volunteer to come along and
Excellent. Hot off the press, isn't it? That's brilliant. That's reaction. I've seen Zoe first, then Lauren, and then Natalie.
Thanks for coming. Just proves how responsibility in this room, really, for young people who have so much to say about it. So I am a governor at a school which is in quite a deprived area of Plymouth. And on a visit there, I noticed a young boy walking around. Just keep walking around. Everywhere we went, every now and again, he'd come past us again. And I asked, like, what happens here? And he said, well, we're waiting for his mum to come because we don't have anyone to deal with him. And I just think that one-to-one thing that you're talking about is so vital, even if it's just for 5 minutes. Because this lad is his dad's coming to pick him up because he has no one at school that can actually help him with this situation that he's in. He gets himself really upset and then he can't deal with anyone. Not only does that affect him, that affects the people around him, that affects the other students in the school as well. And I just wanted to kind of say that, we have very low paid carers. The caring profession is a low paid job, so we have a high turnover of these people, and it's really taxing for them. And I also just wanted to say that I'm always talking about the gap between 16 to 18-year-olds and working in schools, knowing that 16 to 18-year-olds are probably, and I don't know if you found this, the most invisible or feel the most invisible because they're not a child and they're not yet an adult. And I think, and I know from personal experience that CAMS, you can drop off at this point, but you're not quite old enough to go into the bigger gap. So I think, the one-to-one support thing is a really good idea, and I just wanted to say thank you for coming.
And I think, Zoe, the same for you. To add that question about 16 to 18-year-olds, CAMs are here this afternoon, so I think it's important that we raise that. Can I just quickly ask, 60% of groups highlighted having a designated mental health worker within schools. What are you classing as a mental health worker? What qualifications would you be expecting them to have? Any ideas?
So obviously, like you mentioned earlier, it's quite a low paying position, where it's actually quite a valuable role to the consumers of that service. So you would expect maybe a university level education potentially, because at the end of the day, we're dealing with complex mental health problems, and on top of that, you're dealing with a young person, a child. So you need the proper qualifications, probably at a university level, to deal with that. And with being university level educated, you would expect, obviously, there is a cost to that. Yeah.
So you wouldn't be expect it just to be an add-on for a teacher. You'd be more looking for somebody with that specific role full time.
Yeah, I was just going to say, I think teachers at the moment are expected to be dealing with a lot of the mental health, which takes away from their job as a teacher. So I think having, although it would cost a bit more, having a, fully qualified mental health worker would then take the stress off the teachers and let them get back to what their job is, which is teaching.
Thank you. Right, and Lauren.
Thank you, and thank you all for coming in today. This report obviously has a lot of hard work and passion gone into it, and thank you for coming to present it to us today. So I went through the education system in Scotland and also a wee while ago, so I'd really love for you just to give me a little bit of understanding of how mental health is discussed in your classrooms. Do you have dedicated sessions on it? Anything like that?
Obviously I can only give you a limited perspective from my school, and I think that's the first thing, is that it's completely different. There's no set curriculum that you have to learn through the schools. My school, I'd say, was one of the better ones that taught about mental health, but I do know from other people in youth parliament that have been to schools where it was not talked about at all. For me, I think I got the same PowerPoint presentation that we got in year 7 up until year 11. That was, same words, same teacher, same ideas. So it was quite repetitive and didn't go very in depth. But I think the main issue is that there's nothing citywide. It's completely different in all schools. So, yeah.
I'd also just say that it's become quite a tick box kind of thing. Like, I think a lot of young people feel that within their schools, if they have PSHE lessons or citizenship and they learn about mental health and where they're told they can access it, it is very much trying to check it off a list just so they've done that lesson so that teachers can say they've done it. But I feel like a lot of the time, a lot of young people come out with no further knowledge of it, and I think that could definitely be improved.
I was asking with that, with a view of maybe a recommendation tomorrow to formalise that as part of the curriculum.
There's definitely a recommendation coming out, or two, in fact, I think, really, yes. Natalie and then Jemima.
So thank you for coming and for your presentation, and it's really positive to hear that you've been out to different groups and to the schools. How approachable have you found the schools? Obviously, looking at the numbers that have responded, considering the amount of young people in our schools, have you found that it's been difficult to be able to approach schools, and have they been receptive to you coming in, or is it has there been sort of clusters where sort of some schools have been better than others and some groups have been better than others?
Yeah, so we found that kind of independent youth groups in different areas of the city were more than welcoming to have us along, but that does come from kind of long-standing networks and relationships with our group. We do have kind of standing relationships with schools because of our election campaigns and the voting process. But we definitely found that going into smaller youth groups locally was more accessible to us, at least. But yeah, I think Sophia has more to say on that.
Yeah, on our online survey, there were only 7 schools that replied to it, and I believe it was sent out to all schools. All schools, yeah. We kind of find the same, not same, but similar things when we do our election process as well. There are some schools that are more receiving than others. But yeah, like Sunny said, it's definitely felt more warm and welcoming at the youth groups as opposed to the schools, just because I think they're so much more busy and they don't really have time for things that aren't mandatory. Yeah.
I can totally.
I also think it doesn't get spread down from whoever you send it to doesn't always get sent down, as John and I can vouch for the Alpha bequest. Yes, right. I've got Jemima, then Will, and then I'm going to have to call an end to this. Oh, Zoe, and then but the short questions, please, because we're well over time.
Okay, I think I'm going to. Yeah, I think we should think about a recommendation about schools' response to this, because actually it's really important. And I get your point about it's not mandatory, but it's really, really important. And a huge thank you for doing this work, 'cause it's an awful lot of work that you've done. And I think you've come up with some really important findings and recommendations. I wondered if you thought at all about, I've got two questions. If you thought at all about how the pandemic has made this worse or not made this worse, and if you've had feedback around that. And also the social media thing, and we've heard this for a while now. Do you have any thoughts about what we can do to tackle that? Where should we be putting the responsibility for that? Is it the social media companies? Is it the influencers? Who do we need to be saying, you know, get real, because actually it is having an impact on people's mental health? Thank you.
I think to start with, regarding the pandemic, I think since a lot of young people were obviously isolated because of the outbreak, coming out of that, I think a lot of people assume that it's only during the pandemic that people suffered with issues, but coming out of it, there is a lot of, aftermath of that with young people, and I think that's created a real strain on social workers and anyone in the health and wellbeing sector, and that's why I think people need a lot more support. And definitely, I think it's definitely about the aftermath of it as well as during it.
And then with the kind of social media side, it's obviously very difficult to bring accountability to the internet, whatever site it may be. But I think what our report stresses the most is that if proper education was in place and the proper services were in place for base level mental health education, we think that would kind of alleviate a lot of the issues. And then, maybe as time goes on, policies are discovered and written, kind of policing the internet might become a little bit more easier. But I think that's roughly our findings.
Thanks, Zoe. No, sorry, Will next. Sorry.
Following on from what you've just said, do you think with social media, it's all the media you consume? Social media's got slightly, my own past. It's about people putting their own content up, but a lot of what you view is actually put out by people to market, to push a political point, etc. Do you think maybe some education around, getting some healthy scepticism amongst people, just in the same way? I mean, if you did media studies, I don't know if they still teach that, but you say, oh, this newspaper's written for this purpose, this is that type of thing. That could be more of a general curriculum, rather than the kind of, oh, this is a, in the same way that you would educate or warn against people drug use or what have you, but actually that type of scepticism among young people to look. I don't know whether there's some sort of, is that something perhaps a gap that needs plugging maybe, I don't know.
Yeah, I think you learn a lot about like bias and that kind of thing in like history lessons, but I think people don't realise that thing is still apparent on your phones every single time you look at them. I'm doing my extended project on like how social media can influence people to think certain ways, and just looking at research on the algorithm, like it's such a smart tool, but it does feed you information that you already see and that you already like, so it kind of puts you in a box. And I think any sort of education on that and making sure that you're checking your sources and making sure you're looking at the real truth as opposed to a fake truth would be really, really useful, because I think people don't fully understand that almost every single thing that you look at on your phone has some sort of bias in some sort of way.
Thank you. Zoe.
Yeah, what Jemima was saying basically, and that with Sunny, that we can't really hold social media to account. It's been tried, we can keep trying, but it's not an easy process. And also the resilience, maybe, teaching resilience to young people. And we have Andrew Tate right now, don't we? Well, we did. Is he gone? I don't know. Is he gone? But he, such a massive influence, and maybe the education thing we can look into a little bit further.
Thank you. And I think from the social media point, it's also that future employers may well be trawling back to stuff that you put out when you were 14, 15 or whatever and saying, no, we aren't taking blogs into whatever profession you've always wanted to do. And, it's just, yeah, I think youngsters need to be aware, and older people, don't get me wrong, it's us as well. So, I think social media is one of those things that, if I tell you, I never ever used a computer until I became a counsellor in 2001, because midwifery at that time didn't let midwives use the computer. It was the auxiliaries that used the computer. So yes, it's been quite a learning 20 years really. Can I say a big thank you to you? It's really been useful to have your report and to know more about what you've been doing. Certainly it's good to have people that are passionate about this. And I think, yes, I think one of those recommendations is going to have to be, how do we make sure that we get more schools engaged? I mean, I can certainly remember that year that I was Lord Mayor having to do the count for the Youth Parliament elections, and every school had voted. Every school that had that age group in that, and so to hear now that there are some that aren't engaging is quite shocking, basically, because you can make such a difference to young people. So that's definitely going to have to be one of our recommendations as to how we as a council work on that as much as anything else. So thank you very much indeed. If you think of anything else that you wanted to tell us and you didn't, for goodness sake, get hold of Elliot and pass it on to us, all right? And we'll think about how we can stir things around a bit. I don't think we can solve the money problem, though. I'm really sorry about that. That is quite a difficult job for any council at the moment. So, but thanks very much indeed for coming in. And I don't know if any of you are standing this time again, but good luck anyway.
See you tomorrow.
All right, we'll see you tomorrow. Yeah.
Thank you very much for having us as well.
Thanks. Okay, folks, we're supposed to have had a quarter of an hour break, but in fact I'm going to reduce that and just give you time enough to go and have a comfort break or make yourself a quick cup of tea, and then we'll be back, all right? So if we say, can I be cheeky and say 10 to? Back, sorry.
Hi there, just to introduce myself again for anyone who's joined. So I'm Kamal Patel. I'm a public health registrar on the public health team in Plymouth, and with Sarah, we're on public mental health initiatives. So we're going to talk about a few things today. The 5 ways to wellbeing, mental health training throughout the city, a new service called Quell, and then finally on the suicide prevention initiatives. So to start with, public mental health is about focusing on whole population and also targeting that. So going back to Councillor McDonald's question, it's the whole population, but it's targeted to, I think it's on mute. Nope.
Somebody behind me. That's all right. Sorry. Yeah.
So and also targeting to high risk populations, whatever that cause of high risk, and it's about promotion of good mental health and well-being and the prevention of mental illness. And again, coming back to the concept I talked about earlier, that good mental health can be achieved when an individual or community has those resources that they need to meet their particular challenges at an individual or a community level. And so the focus of our approach in public mental health is to improve and maintain good mental health by reducing risk factors or challenges and promoting protective factors and resources in people. So I put this slide up, which is a kind of a schematic of the continuum of mental health need. And so across the top, you have the range of mental health. You have someone who might have a good mental health and positive well-being, all the way across to someone who is severely impacted by a mental health condition. And we all sit somewhere on that spectrum, and we all will change even daily where we are on that spectrum. And I think it's really important to comment that you could have a mental health diagnosis and even a severe one, but at that moment have good positive well-being. You can not have a diagnosis and at the moment have really significantly impacted by your mental well-being. So it really is a continuum. It's quite dynamic, but a diagnosis isn't everything, I think. And then across the schematic there, I put kind of the different levels of services, of mental health services that we have in Plymouth, and that's kind of matched across to that continuum of mental health. And just to show you where public mental health sits on that continuum, and we're at the promotion and prevention end, naturally. And then I've just put a little extra schematic. So that line represents a bell curve of need, and I think most people in a population are in that middle bit. I don't think my mouse is showing. Yeah, most people are in the middle, and there are fewer people in the extremes of any health condition, including mental health. And so really public mental health focuses on trying to shift or shift that curve across to the left, so that there are more people being supported in the community, having their own resilience, having their own community resilience. And that, if you do it at a population level, will have a big impact on that tail end that will need services. And so it really shows that the reason why we focus on population health is to try and reduce that need at that higher end, and a small change in population health can have a big impact on mental health need for people, and someone with a severe mental health condition needing services might, if they have resources and training that might help them to help themselves, help their mental health, actually have a reduced need at that far end. So the 5 ways to wellbeing, that's really our main communication tool in public mental health, to help people to understand and enhance their own wellbeing. And as I just said, it's for everybody across the whole mental health spectrum in order to as I said, improve their own mental health. And it's an evidence-based tool that says that these 5 things, that if we can each do them to a greater extent that we are able to, then that will improve our mental health. And those things are connecting, linking up with people around you, having a community, feeling supported by that community, contributing to that community, learning. Lifelong learning doesn't have to be formal education or anything, but just learning, being active, then doing things that you enjoy, noticing the world around you, and then giving, and contributing and feeling that kind of sense of worth, of giving back to your community. And this approach, the 5 ways to wellbeing, really underpins our Thrive Plymouth 10-year plan to improve mental health and reduce health inequalities. The next sort of step up is around mental health training. So we commission Live Well to provide mental health and wellbeing training, and there are a number of different training that they offer that I've listed there. And really this is about, again, trying to influence as many people as possible, going into workplaces, providing training, especially, again, with our workplace wellbeing, we try and target these approaches to more manual routine places of work, for example, because that's where we find the need is greatest, but it is open to a whole population level. And it builds capacity in the system. If there are more people who are able to talk about mental health, then you might find that you don't need as much to go into the services. You might be able to have a conversation with a colleague, for example, and that builds, people need the confidence to be able to have those conversations, because it's a difficult thing. People feel that they can't, and training tries to enable them to do that. And by doing that, it builds awareness and it reduces the stigma, again, that we've talked about in terms of people talking about their own mental health and not wanting to do that. So this is, next thing to talk about would be Quell. So this is a new service that's been commissioned in the whole Devon ICS area in response to the pandemic and the increased needs in mental health that we've seen in the pandemic. And this is a service that is fully digital. It's online via an app or on the website for all adults to have a free digital mental health support. And this is equivalent to the Couth offer that is already in place for children and young people across Devon. So we're currently in Q3 of a 2-year pilot of this programme. We're seeing small but increasing numbers of people use it, and we are working on ways of promoting that more widely. And it allows people to go online to assess their own mental health and set goals, to access forums which are moderated by medical professionals. Again, access articles which are moderated, and there's also a online counselling type offer which is purely via text, and you can have a text conversation with a qualified counsellor. And I think one of the key things about this is when we looked at the children and young people's offer, we found that some people prefer face-to-face, but some people prefer online. Some people prefer be able to access things out of hours, although it's not a proper full counselling face-to-face session. It is something that is available out of hours, and the stats show more people access this service out of hours than in hours. And also the counselling is much more of a dip in, dip out. So it's as required. You can have one session or you can have multiple sessions. You can, rather than having a formal kind of every week. And again, it's people prefer different things. That's what we find with the children and young people service. So obviously we're looking at evaluating the adult service as well, but just to show some themes from there.
Okay, yeah. Microphone on, sorry. So I just wanted to run through as well some of the suicide prevention initiatives that are happening locally, and how we're kind of working collectively across Plymouth, but also across Devon in delivering those. So we did have some funding from a prevention programme for One Devon, which was formerly the STP, obviously, to deliver a few services. One of those is post-vention support service and a specialist suicide bereavement support service that is commissioned across Devon, Torquay and Plymouth, and that is provided by Pete's Dragons. So this is a highly specialist service to provide support to those bereaved and impacted by suicide. And it's the idea, and what we try and do is get people linked in as soon as possible to this specialist service, because we know people who are bereaved and impacted by suicide are at increased risk of suicide themselves going forward. So to have that specialist support as soon as possible offered to them. Not everybody wants to take that up, but it's available to them whenever they want to. So that's one of the key services that we have. There's also funding which has now been picked up by the public health teams for real-time data analysis. So we have a whole-time analyst that works across the patch, funded by the 3 public health teams, to look just at our real-time data around sudden, potentially self-inflicted deaths that will either, tend to either be at the following inquest to be a drug or alcohol-related death, or a suicide or an undetermined intent. So we have somebody that looks at, and a system that looks at and monitors that with our police colleagues, where we monitor real-time data and try and the purpose of doing that really is to make sure that people are connected into the bereavement support where needed, that we identify any potential clusters or any potential interventions that are needed in real time. Okay. So there's that, and then we have a men's mental health promotion programme, which was funded by, is funded by ICB, which has been a little bit stymied by the pandemic in some of the intended delivery, but still is being delivered. And this focuses very much on supporting groups and supporting men around talking about their mental health and about promoting mental health in different ways. One of the things you may have seen in which we're going is around an organisation, local charity called Barbers Collaborative, based in Torbay, which is about training barbers to talk particularly with men and how they talk and how they can signpost and do that. That's one of the ones. And they're going to be doing some outreach into our universities and colleges and into our sports clubs to kind of get that message out in the coming 12 months. So there's some work there, which is ongoing. And then there is some funding from NHS England, which again funds a programme of activity across Devon, Plymouth and Torbay, where we work collaboratively with our colleagues in those other areas. And there's 5 areas really around that. One is around suicide safer communities, and this provides some grassroots community grants to local organisations to identify what communities think will make a difference around improving mental health and wellbeing and enabling people to cope and preventing suicide. So we've run the first year of grants in Plymouth, administered by POP for us in Plymouth, and a second year's worth of grants going forward, and that's replicated across Devon and Torbay. There's some skilling and targeted suicide awareness training, and what we've been focusing this on is around community awareness and resilience. And so through our training partners Live Well, we're focusing and offer 4 communities very much around community groups and people working with. We've focused on people working with people with drug and alcohol issues, criminal justice issues, homelessness, and also debt advice in the first round. So working with our organisations who deal with people, work and support people dealing with those issues, to understand it's all about improving people's understanding of issues and confidence to talk. And then there's an emotional resilience programme as well, which is being delivered. So that's very much around community provision. There's a strand which is around suicide safer primary care, and this is about developing a training offer for the whole of the primary care sector, so not just GPs and those working in GP practices, but also around pharmacists, dentists, optometrists, that kind of thing. So that's a developing programme where we're working with the Devon Training Hub, which provides training to clinicians and clinical primary care organisations, where again that's about upskilling, awareness, so that will be something that will be coming into in 2023-24 year. There is some funding going into Torbay-led research, so I don't know if you picked out on the charts that we saw before, but Torbay are the highest in terms of self-harm and suicide across the southwest, and you know we're high. So absolutely appropriate we focus some research there to try and understand exactly what are some of those issues there. And as I said, the focus for the research on people with lived experience and self-harm, the needs assessment, and some of the other research around suicide is going on in Torbay as our focus population for that. So the funding's looking at that. And then there's also a work stream where, again, we'll start this year on suicide safer communications and media. And that's really around, we've started to see some improvement where we've been working for years with our communications and media people, but it's around the appropriateness of how things like self-harm and suicide are reported, and how we make that a positive rather than a negative, how we follow the appropriate reporting codes and guidance, but also how we work with communications and media to make positive mental health and wellbeing stories come out rather than always a negative. And so there's a piece of work we're going to do across, as I said, Devon, Plymouth and Torbay on that coming forward. And these were all the result of a bid that the 3 public health teams on behalf of the local authorities made to NHS England to fund these programmes. So we've, and again, as I said, we had the money first off just as the pandemic broke. So we're kind of catching up really, but been delivering this for the last 3 years and will go forward. Okay, so that's our kind of presentation on that. I guess I suppose what we just want to emphasise is, like everything in terms of our health and wellbeing, there is a prevention promotion part to this, and what Kamal showed you with that graph is very much if we can deliver this at a population level, we can hope, the evidence says that you can prevent people needing the higher level of services. That's the gap that we are filling, if you like, or the space that we're filling. And what we commission for in the range of mental health services. So very much at that end. So we're very happy to take any questions.
Okay, team, I've got Sue, then Jemima. Oh, hang on. Right, Sue, Jemima, Lauren, Kathy, and Natalie. Right, Sue, let's start.
Thank you, Chair. I'm interested in Torbay because why is Torbay? And what is it about Torbay that's where mental health issues seem to be more prominent and more happening than in other comparable places? Is it because it's coastal? Is it because there's a huge divide between those very wealthy and those that are not? I don't know.
And neither do I. That is why we've actually funded and put some money into funding the research into the rates, and working with the local communities and people there to try and understand exactly why that is. Certainly, deprivation, as we know, is part of the problem, but that isn't the totality of the answer. We know that certainly around suicide. Suicide impacts all communities, not just deprived communities. And so that is why I suppose as a team we bid for and focus for some money to try and understand exactly why there is a marked difference between Devon, Plymouth and Torbay, and why Torbay is at that higher end. So hopefully working with the University of Exeter with the research and with the evaluation and the people with lived experience, we'll start to get some answers as to maybe, or some ideas and hypotheses that we can do some further work on.
Oh, thank you. I was curious.
Yeah.
Thank you. Jemima.
Thank you. So at the top of the last slide, you were talking about the Suicide Safer Communities that POP was distributing grants, and I'm just interested in what kind of things from the grassroots people are saying they think will help with prevention.
So we've got 5 programmes identified so far, and what the pots of money were to try and get people to collaborate around what it is that would seem to be helpful. 2 of those are around, if you like, art and craft and activity, really, and 3 of them I think around different activities and what is it that will bring people together, really, and looking at different ways of bringing people together as a primary focus, where the secondary focus is talking and talking about mental health and well-being, really. So 3 of those are doing that. One of them is around men in particular, and doing that, but also around what type of activities and therapies will, at that lowest level, if you like, what therapeutic content is there, and those very much came from the community. So things like art, craft, and stuff going from forward. I'm going to refer to Jane now and ask me to prompt me for the other 2 because they've gone out of my mind.
So one was around working with science and refugees.
Yeah. So one is around asylum seekers and refugees as a specific population and asking them what further things would help them around mental health and wellbeing.
And then the other one was kind of, it's developing like almost like a living room space for people to come together and talk, and there's kind of poetry, kind of people can get up and talk about their experience.
Do you want to come and join us
Yeah,
at the
sorry,
table?
Jane.
So
I was going to say,
everybody
rather than
can
me
hear?
repeat that, sorry, yeah. So,
This one. Yeah, so the other one was kind of around, it's like a living room space for people to come together, and it's a ticketed event, but it's free. We can share actually the next date if that's of interest to you all. We can share that date, and that one it's kind of an opportunity for people to do music or poetry and kind of share their experiences of mental health and talk. So yeah.
Sorry, I should have introduced Jane. So Jane Marley is one of our advanced practitioners who works on promoting mental health and wellbeing with us. Okay, so those are the current 5 projects. This year we're hoping to have some to shape the community grants towards further our asylum seeker and refugee and migrant populations, and also our LGBTQ plus population. There's 2 groups that we know that face increased risk that we really want them to tell us what would help them in terms of improving their mental health and wellbeing.
Right, Lauren.
Thank you. So my question is just on funding. So you mentioned quite a few pots in your presentation there, and just wondering the long-term viability of applying for pots on kind of a rolling basis, and also taking into consideration, I'm assuming, cuts coming to public sector. How are those going to impact you long-term and the deliverability of these programmes?
So that's a very good spot. So it's quite interesting that public health and the local authority, we have the statutory function to lead for suicide prevention, but very little, if any, money in our public health grant, as you will know, to actually fund that. Hence, we bid for money from the NHS system. And part of that is to cite the NHS, I suppose, on the prevention agenda, which is appropriate and stuff. So I guess it's incumbent on us to use the funding that we've got to prove the case, to provide the evidence, and build the business case for continued investment. And that is the challenge. You've absolutely picked up on it. So we have funding, it's time limited, but that's for us to build the evidence base around what works, demonstrate that, and then make the case back to the integrated care system to say this needs to be invested in.
Thank you. Kathy.
Can you tell me a little bit more about Quell, please? Am I right in thinking that you can self-refer? And if so, how do people know about the service?
So absolutely. So you can go onto the website, type in a anonymous username, a password, and put your postcode, first 3 digits, show that you're a Devon postcode, and you're in. And that allows you to access the range of services that I talked about. So I think that the challenge now, it's a new service, the challenge is to promote that out. We, as I said, we're in quarter 3, and that there are generally small numbers but growing. So one of our actions is around getting that, and also we talked about in promoting COOTH, which is the children and young persons one. That's quite well used by children and young people, but there's opportunities to link with the Youth Parliament who have been here to improve. People can't access it, they don't know it. So it is about talking to schools, talking to all our partners in the voluntary and community sector, primary care, to have that resource available so that people can be signposted easily and shown how easy it is to log on. There's no gatekeeping at all.
Do you have funding for that service to market the service?
Yeah. So we do, and that's included in the contract. So as I said, the contract is run for us by Devon County Council for the 3 local authorities and the ICB. We went in together. They're managing that contract. So part of that is a slow grow, if you like. So you turn on a service and you've got to then go and promote in different places. So the company that deliver that, Quell, are promoting that, and we're just now stepping up. Now they've got all the capacity in place. We're now stepping up as local public health teams in our promotion of that. And we've started that with our community and voluntary sector organisations who are also working in that space to say to people know about this. We're moving into some of the health services as well, like primary care, to make sure that they can all signpost people. And I should just say this was specifically commissioned in response to what the pandemic needs assessment showed us, which was increased levels of relatively low level anxiety and depression. And that is what, and this was filling a space between kind of self-care, 5 ways to wellbeing, looking after ourselves, and the talking therapies of Plymouth Options, for example. So this is between those two, there's a gap of, well, I might not be actually in need of this, but actually there's some things I feel I can do for myself. And that preference, as Kamal said, that we've seen in parts of the population for something that's completely anonymous, completely, you can determine yourself and an online service. So it was to fill that gap. It's funded for 2 years currently, and an evaluation is funded of that. So we funded an evaluation partner to evaluate the impact of that, and then a decision will be made following that as to onward commissioning or not.
Does the service give you the option of having face-to-face contact with people, or is it purely online?
Purely online service, and the counselling is through web chat and text.
Can I say, I think one of something coming out of this morning there needs to be, this afternoon now, thinking about how we as councillors are making sure all councillors know that is on. So I think that's something to think about for councillor page that we have. So that to me there. Right, now I've got Natalie, Zoe, and then Jemima, and then I'm moving on to the next agenda because we're slightly over it already. Okay, folks? Okay, Natalie.
Thank you. My question is about the 5 ways to wellbeing, and where you've talked about talking to businesses, employers about how to promote it. Have you got particular focus about where you're promoting it? Is it, later on there was some talk about Barber, the Barber project. Is a certain demographic or certain types of industries that you think may benefit more from that type of training, and what type of response are you getting from those people?
So we run a wellbeing at work network in the city through our commission service, health improvement service at Livewell. So any employers that invest in the sort of broadest sense their workers' wellbeing are able to have training, and we promote the 5 ways to wellbeing through that. So that's a very firm offer. But the 5 ways to wellbeing is a population-based intervention. It is for everybody. So we've focused initially around some of the workplaces, and Kamal said some of those routine and manual occupations where we know needs are higher. So to try and encourage, and I'll be honest, men often in those where they're more reticent to talk as well. So we've kind of had that as a focus first off to work about and think about those things. But the 5 ways to wellbeing is a population-based one. So you'll know that flower is the symbol of our wellbeing hubs. So actually, all of the staff in the wellbeing hubs and through the wellbeing hubs, it's that underlying communication way of which we know there are things we can do that lift our mood ourselves. I do them. We need to spread that word around, being, and understanding there are things that you can help yourself at the really lowest level in terms of promoting our well-being. So what I would say is our role with partners through that is to get that message out and keep promoting that, and we do that at different levels. So.
Thank you. Zoe.
I have just 2 points, sorry, Chair. The first one is with Quell, which sounds amazing, but is there an opportunity there to miss those that are in need? So if someone was, say for instance, spoke to triage at a doctor's surgery, doctor sends them a form over, or perhaps go to Quell, that someone who is actually in need then falls through the net, potentially? Is that possible? Because it's anonymous, isn't it?
Yes, it is anonymous. I'm not so I'm not sure what you're asking. So if they've been recommended to go to Quell because they've got a low level anxiety or depressive need, then that's that's what the service is there for, is appropriate. The clinical professionals that moderate that online service, so all the conversations that are had are there to pick up if somebody is in the wrong place, if you like. So even though it's an anonymous service, it's moderated by clinicians to pick up if somebody is expressing, for example, suicidal ideation, then obviously that would be picked up and they can be signposted to the appropriate place for them, because that isn't on that online. So does that help?
Yeah, it does.
Yeah. Okay.
That's what I meant, because sometimes you
Okay.
go to
Yeah.
the doctor's surgery
Yeah.
and they kind of push you off, don't they? So I just wanted to make sure that wouldn't happen. And also, so in a workplace with health and safety, is a minimum requirement to have a first aid box and a person to administer the first aid box or call for emergency services. There is mental health first aid, but that's not mandatory, is it, within the workplace? So is there something we can look at there, maybe?
Yeah, so you're right, it's not mandatory, it's not a mandatory health and safety requirement, but mental health first aid is one of the training offers that we promote. It's one of the things we offer, and there's a whole package that we offer to workplace wellbeing champions, which is one of the things that we promote, where they can be trained in mental health first aid, suicide awareness, all of those kind of things to do that. But it's not mandatory. No, you're right.
And we can check with Kim Brown as to what's on offer in PCC if that's
so I can
also
tell you all of our
going.
workplace wellbeing champions in the
Excellent.
local authority are fully trained in mental health first aid and suicide awareness.
Thanks, Sarah. Thanks for that. Right, Jemima.
It was going back to Quell. I just interested a little bit around the I know you said you didn't say soft launch, but whatever it was you said. Just around the targets and the reach of it at the moment. How many people are accessing it? How many people are you hoping will access it? What are the kind of KPIs around it, I suppose? Thank you.
So I can provide some more detail if that's helpful to sort of do that. But what we've worked on is where this has been provided in other places in the country. It's kind of generally had a reach to between 10 and 15% of the population. And that is, if you like, the very top level. I mean, obviously, there's an amount of capacity that the money we've invested buys, and we're not maximising that. We're not using all of that at the moment in terms of the sort of support that's provided through that, and the moderation. So our aim is to get up to using all of that we've invested in, and I suppose we're about 60% of the way there at the moment, and we need to go up. So I haven't got the exact figures in my mind, because we kind of monitoring that, but it's monitored on a 3-monthly basis. As I said, we're now just entering into Q3, so it's around kind of monitoring that and pushing that. And so I think in terms of what we've done in the launch with, first off, the provider has done most of that, and they've had to go out and meet and find the local other networks, because obviously they're a national provider. They are the same company that deliver Couth, so they've got some links already. And then we're now moving into the phase where we need to kind of really up the push out of this is an offer that's there. Obviously, we've always known that it's not going to be an offer for everybody, and we've already heard today, haven't we? And certainly Tony's very powerful message that face-to-face is really important for some people. But in this low-level space, and hence this isn't to replace any of the services that we are already commissioned in the system. This was in direct response to a gap that we felt that the pandemic had identified. Then this is what we're trying to see. How many people does this help support and go through? I would say what we've got back so far is people who have used the service recommend the service.
Thank you very much. Jemima?
I mean, far be it for me to suggest things that should go on the adult health.
No, I think we're technically thinking that you are a full member of this simply because you are here, and so you have the right to put things on by all means.
But I think it might be interesting to have that as an agenda item, maybe at the next adult health scrutiny, just where Quell is and how it's going in terms of what their targets are and who they're reaching.
Because certainly it'll have reached another quarter by then as well, won't it? So that would be quite useful. So a recommendation on a presentation Yeah, excellent, thank you. Okay, that's it. Now I've called the end of the questions there. So thank you both very much indeed. I don't know if you now get released. I'm not too sure whether you're. Are you back with us? You're back with us tomorrow, or is this?
I think that's the end of it. But obviously we can, you know, I mean,
We will be in touch if we have more questions for you.
I'm sure.
But Sarah, I just wanted to say, I know you're sneaking off and leaving the establishment fairly soon. Can I wish you a long and very happy retirement, and thank you for everything you've done, because certainly you've been one of those people, those go-to people within public health, and Kamal's got to have a big pair of shoes to follow, really. So I'm sorry.
Well, he's the man for the job. That's all I'm going to say. Thank you. Thank you for your kind wishes. I'm not going anywhere till the end of April, but thank you.
Right, folks, now shuffle around. So I think Dr. Mahoney's sat there playing with his phone. So I think we need to. Ah, well done. So I think at some point we need to be asking you if you've got any input into all of this. So just get your thinking cap on for later on, because obviously it'll be interesting to hear what your views are and about how we as a council need to go forward with some of these ideas. All right, thanks, John. Kate, Louise, and haven't we got Rob? Olivia and Rob? Yeah, come and join us, Rob. I think there should be a name tag for you somewhere there. Excellent. Excellent. Welcome, Olivia. Thank you very much for joining us. Can you hear us okay? Lovely.
Can you hear me?
We can hear you. That's
Great.
brilliant. The technology is working today. It wasn't the other day, so well done. Okay, we'll let everybody settle down. Now, I don't know in which order you want to go in. Is it Louise, you're going to start? Oh, don't worry, we're all having technical issues, so not a problem. If the guys, if Elliot can do any help good for you, let him know.
Microphone. Hello, everybody. I'm Louise Barnes, Chief Executive of Elder Tree. So just to start with, we just wanted to give a little introduction to the VCSE sector and how it supports people with dementia in the city. So the VCSE sector in Plymouth plays a really important role in supporting individuals living with dementia and their families, and it complements and enhances the statutory services. Both Memory Matters and Elder Tree provide dementia befriending and social activities to help reduce isolation and improve quality of life. We also provide information on available dementia services and advice on the challenges associated with dementia. We provide advocacy and work to help improve access to services and support dementia carers. Our two organisations work really closely together, which results in a really nicely joined up VCSE offer for dementia in the city. A recent development in this area has been the Older Persons Alliance, which Kate is developing with Maurice Watts from Live Well South West. This had its inaugural meeting in November last year, and the aim is to establish a sort of healthy ageing partnership forum across both the statutory and the VCSE sectors to co-produce initiatives, support other stakeholders and the wider work of the LCP, and also collectively address the challenges. Dementia support is obviously a really key part of this. As you can see from the slide, there are various alliances and forums that we hope will feed in and out of it. Kate and I are both really actively involved, both in the PDAA, the Plymouth Dementia Action Alliance. I sit on the LCP delivery group, and between us, we have involvement across all the other forums. So that's just to give you a little bit of an overview. Next slide, please. Thank you. So just a bit about Elder Tree Befriending for those of you that don't know us. We're a charity working in partnership with Plymouth City Council, Live Well South West, statutory and voluntary sectors and friends and families, and we're delivering an innovative, it's a good word, and cutting edge preventative service that alleviates loneliness and social isolation for the over 50s, and that obviously includes a lot of people living with dementia. We're currently supporting over 1,600 beneficiaries with the help of 155 amazing volunteers who we couldn't do what we do without. And we deliver 90 different social inclusion activities across the city each week in 50 different locations. We also support 97 of our most vulnerable and housebound beneficiaries with a one-to-one volunteer befriender in their homes each week. We deliver a whole range of weekly social inclusion activities in localities close to where people live, which we think is really important for building sort of community networks, but also alleviating the barrier of transport cost, which is obviously an increasing issue for people. I won't tell you everything we do because it's a very long list, but it's lunch clubs, supper clubs, IT groups, craft groups, dementia groups, active men's groups, choirs. The list goes on. It's always a good test of my memory. Physical activities are a really key part of what we do, and 58 of our activities are exercise-based, either seated and standing exercise, Tai Chi, Pilates, and every week more than 800 people exercise with us for at least an hour. And those activities are really heavily based on strength and balance and falls prevention. We do also deliver a very specific falls prevention programme as well in 6 different locations across Plymouth and the western locality. But that's a specific scheme that I won't go into too much detail. And we also deliver, very similar to what we do in the community, we deliver a social inclusion programme in 5 extra care schemes across the city as well. We are referred into service and we get referrals from everyone, GPs, University Hospital Trust, adult social care, older people's mental health, as well as other VCSE organisations, friends and family, you name it, we get referrals from everybody, and people, individuals themselves, they can refer to us. And it's true to say that we've been seeing a real increase in the number of referrals post-pandemic. We're averaging about 70 a month, which is quite a lot for a small charity. And a large proportion of those are for people with mental health and physical health issues. And it's fair to say that the complexity of those is really growing as well. Pre-pandemic, it was much more of a simple ask. It's getting much more complex. And definitely referrals to people with mental health issues and dementia are definitely on the increase. I'm sorry, I should have asked you for just to click for the next part of the slide. That was just a bit about a dementia offer there. As I wasn't doing it myself, I forgot that bit. Thank you. But I've summarised that. Next slide, please. Oh, no, sorry, not next slide, please. That's now. Sorry. I haven't got my glasses on. Could you go back a slide? Thank you. So we've seen an increase in 7% in dementia referrals in the last 6 months. So it's obviously on the increase. And we regularly, just to put it in context, we regularly get referrals from all of the Live Well teams that work with people with dementia. So Edgecombe Ward, the Dementia Advisory Service, Plymouth Dementia Pathway, but also referrals for dementia come from GPs, social prescribers most commonly, and also friends and family. So we're currently supporting 200 people living with dementia every week. Individuals living with dementia are welcome in any of our groups, so they come to all of our activities, but we do have a specific dementia offer for those requiring more specialist support. And these include 6 weekly dementia groups. They include reminiscence sessions. We have a dementia choir and also a specific men's sporting theme group, which is run in partnership with Argyle Community Trust. And many beneficiaries attend more than once a week. So we have 200 people, but they could be attending more than one thing each week. We also provide those housebound beneficiaries living with dementia one-to-ones in their homes, and that's currently 60 out of the 97 that we do across the charity. Carers are welcome in any of our activity groups, and they do attend quite a few, but we've been piloting a specific carer support group as well alongside one of our dementia groups, because it's becoming more and more apparent that carers of people living with dementia need a space. They need some sort of breathing space in their week away from the person they care for, and quite often they don't want to be away from that person, but they want to have a space nearby. So it's a sort of co-located group to give them a bit of a breathing space. And this has worked really, really well, and we're hoping to roll that out alongside our other dementia groups as well, because it's definitely something we're hearing more of in terms of requirement for support. Just a couple of other things before I pass over to Kate. We deliver 48 weeks of provision each year to ensure that there's a sort of consistent and regular ongoing offer of support. And we think that's really important just to keep that consistency. And in between groups, our project workers also keep in touch with people either on the phone or at home visits if it's appropriate and necessary, just to have that consistent eyes-on approach. It's also worth noting that we were one of the first organisations in the city to go back to face-to-face befriending and groups after the pandemic, because we realised how important it was for people in terms of social isolation and loneliness. And I think that's, was particularly the case with people with dementia and their carers. So yeah, we were very, very quick off the mark with that, and heaven forbid we go into pandemic again, but that will be a model that we will adopt if that's the case. Kate.
Next slide, please. Hi, I'm Kate. I'm from Memory Matters. It's the first time I've been in this room, isn't it lovely? Thanks for inviting me. Memory Matters has been running since 2010 and has been very present in the city since 2016. We support people living with dementia to thrive in everything that we do, and we're a very agile service, so we tend to shape our services based on what people with dementia and their carers tell us they need. Memory Matters links with all sorts of services all over the city and Plymouth and shares its learning and its evaluation to regularly inform local intelligence. We take referrals from Live Well, Derriford, GP, social prescribers, library services, VCSE sector and self-referrals, just to name but a few. And we understand that those key referral needs are really important, so we ensure that the Live Well Memory Service know who contact us, so that there's some shared data around there, so that they know that there's eyes on some of their patients too. We provide many services, mainly from our centre at Moments Cafe on New George Street. Moments Cafe was built and opened actually 6 years ago yesterday, and it was built using a social enterprise investment fund loan from Plymouth City Council way back in 2017, which we continue to pay back until next year, and then we'll be free. It was requested for us to do this by people with dementia. What they wanted was somewhere to go in and ask an advice and support that was very quick, off the hoof. They didn't have to make an appointment. And when we asked them what they wanted, they said, we want an information centre. We said, okay, where do you want it? And they said, the city centre. We said, great, those buildings are really expensive. When you go there, what is it you do when you go into town? And they said, we eat cake. So we opened a cafe, basically. In its 6th year now, we see on average 60,000 customers coming through the door every year, and it was designed for the public. The idea about that is that it is a sustainable way for us to run a building, because we are gaining income to enable us to do that. It is also a non-stigmatising place to eat, meet and ask for help in a space that isn't clinical. It is the first of its kind in its UK, and it was placed in the city centre because that's where people with said their bus pass will take them. It's one bus, and that's the easiest way for us to get there. The main part of our building, however, it is upstairs in the hub, and the advice and support that we provide upstairs. We run on somewhere in the region of 465 families we support a year. During the pandemic, this did not stop. We continued to do this via phone and by video. And we built a community dementia pathway and have created local community decision support tools to enable us to link in with every single service in the city. It's led by a very experienced nurse who actually only retired from the memory service pathway a couple of years ago. She now works for me. I stole her. And we provide a space for other local organisations to learn and to share their information too. It's a great place for us to be able to let people of the city know what's going on. We take referrals, as I said, from all over the city, especially from the hospitals. Admiral nurses as well send us to us, and also Live Well Memory Service send most of their patients to us. We do tend to work very closely with people to find them seeking solutions. We never send people away from our space with a job to do, because we know that being a carer is already a big job. So we tend to work alongside people to find those solutions with them. It is a drop-in service. People can literally just walk in off the street and ask for support and advice. All our services are clearly evaluated, and we're currently working with the Academic Health Science Network to make sure that our impact is impacting on the wider system, but also for people with dementia. Just before Christmas, we knew that the waiting list for a dementia diagnosis in the city was somewhere in the region of 600 people waiting, with a 12-month waiting list. What happens if you don't have a diagnosis is that you can't access dementia support worker service, you can't access benefits, and you can't access treatment. If you're waiting 12 months and you've already gone to your GP when things are unmanageable, that 12 months can be a very difficult journey, which is the gap that we plug. We have over 1,000 people as well visiting groups in our hub as well, with loads of different activities that we share our space. We are a bit of an unofficial wellbeing hub for the city. I hate to say it, but we are. We have mindful art groups, singing groups, model making, support groups. The Elder Tree run sessions there. The University of the Third Age come in. We have autism groups, and we also have health screening, AAA screening happens up there also. We also run specific dementia groups, 90 unique beneficiaries a week, attending 2 memory cafes a week, which is a space for people with their carers and their loved ones to come and meet others and share their experiences and have a little bit of fun and downtime. We run cognitive stimulation therapy groups, which is a psychosocial therapy cited in the NICE guidelines as the only non-pharmacological treatment for cognition. We run mild cognitive impairment groups for those who are not yet at a dementia stage, and a young onset dementia group. We have 25 people under the age of 65 that come along with their loved ones to our group for dementia. We also run free legal clinics for older people and health screening clinics. And we also use our experience to teach others. We're currently starting a programme of training around behaviour that might challenge us with care homes in the city, working alongside LiveWell to provide this on their behalf. And we also work very closely with Improving Lives to share some of their learning too. I've been mandated by the Plymouth Dementia Action Alliance to actively review how this alliance can be more effective in a whole system approach and how this can fit in with the wider work in the city, including engaging in systems leadership discussions. Next slide, please. It's coming.
So just a little bit about collaboration. Collaboration is a really key component of the VCSC sector, and Elder Tree and Memory Matters pride themselves on working really effectively with each other in order to achieve a greater impact on those living with dementia in the city, both at a strategic level but also on the ground. We realise that we have more of the capacity to be more flexible and adaptable than the statutory sector, which makes it much easier for us to collaborate in response to changing needs and circumstances. As Kate says, we do really consider ourselves to be agile and innovative, I still can't say it, in our approaches, which can lead to new and creative solutions. We have shared values and goals, which again is really helpful and makes collaboration much easier. And by working together, we believe we create a collective impact that is greater than the sum of its parts. And we feel that we can reach or achieve a greater reach and influence. Together, we share learning, we share resources, we share expertise, and we do cross-refer to each other when appropriate. As Kate said, on the ground, we deliver activity in partnership. We're currently delivering, Elder Tree is delivering a weekly session at Moments Cafe. So that's just an example of how we are working together. Next slide, please.
So I just want to bring some context to the impact that community organisations can have in this dementia space in a wider system. Over 1/3 of hospital admissions in 2021 were between 0 and 1 day. And these short stays are eliminated by the NHS could save in excess of £326 million. By aligning community organisations, this anticipatory support that we provide has the potential to reduce those hospital admissions. In the same period, almost 336,000 admissions costing £1 billion to the NHS were for chest infections, delirium, falls and UTIs, which can all be prevented if they're well managed in the community. One system case study projected it could save £2 million through improved community support just for people with dementia. Memory Matters takes anticipatory care very seriously, and we did some studies over the last year, and in a sample of just 7 sessions, that's 14 hours of group activity, the expected anticipatory care savings to the NHS were a minimum of £3,000 and a maximum of £11,000. This is calculated just by noticing anticipatory actions that we make. If somebody's got frequency of micturition, if they're a little bit more confused than they normally are, if they have safeguarding issues, if there are issues that they have reported some falls risks at home, and even something as simple as noticing constipation and stomach issues. The minimum amount of money is the best case scenario. That's a GP visit and some antibiotics. And our worst case scenario includes hospitalisation for UTIs, deliriums and chest infections. All of these early interventions take place within our services every day. This cost saving doesn't even take into account the complex case management that we're now having to take, the carer breakdown intervention that we take part in, and safeguarding issues that we manage consistently by our teams. Externally, visitors will look in and see just groups having a load of fun. The reality is that it's much more than this. Both the Elder Tree and Memory Matters look for signs of early ill-being, carer stress, and provide gentle guidance and react quickly when those conditions arise. This preventative approach in our community is absolutely vital. Both our organisations reduce hospital admissions by keeping well at home, engaging the community, and providing vital eyes-on approach. It supports active discharge by giving those carers a little bit of a break while they're taking part in activities, and to make sure that they get professional support to those low-level issues that we can manage locally. We also may manage to reduce loneliness and isolation to prevent their ill health. Next slide, please. We all understand that each system in the city has challenges. We have a pyramid of our current landscape on your screen, and the pressure is displayed here pre and post-pandemic. It demonstrates what happens to the VCSE sector when services built to manage those most in need become overwhelmed. Memory Matters are signposted to by many statutory services, and more so in the last 12 months than ever before. We're seeing a 19% increase in those asking for support alone. The Elder Tree, as you've already heard, have seen their referrals for people with dementia rise from 5% in 2022 to 12% in 2023. All VCSE sectors are feeling this across the country. This is not unique to Plymouth, and notably, we're seeing more and more complex cases too. Currently, in the last 12 months, 40% of those that have come in for advice and support are diagnostic delay and risk to self. 10% were signposted to a GP. 30% are complex case management, which is a 20% increase on the year before. 10% is carer breakdown, and 10% just for general advice. Memory Matters and the Elder Tree are really happy to continue this support in the third sector. The relationships locally are strong and supportive between us and statutory services, and both our teams know that there is no other option. Sometimes we can't turn people away, there isn't anywhere else. The question we often ask when people attend our services is, where would you have gone if you hadn't have come here? 15% say, I don't know. 35% said they'd go to my doctor, and a whopping 50% said they would have gone to A&E. There is an opportunity among our systems to build our Dementia Alliance into this system to provide some bidirectional intelligence into the wider system. That's a vast knowledge of people that are providing support in our city for dementia. We believe there are really valued partners in this system, and we have the ability to share that lived experience so that we can affect change at a much wider level. In Memory Matters, we use the term nothing about us without us to make sure that we're listening. We have the opportunity to share learning across to inform decision makers of decisions that they're making so that they're hearing those people. But ultimately, we need to continue to develop effective and well-resourced systems for people with dementia in the city. We urge you in this review to look at the current system to ensure that they remain effective and review vital services that are currently under-resourced yet provide marked impact on other systems. That's all we've got. Thank you. If you've got any questions.
I'm going to move us on and hear the rest, because we've still got to hear from Olivia and Rob before we start doing some questioning. So I'm going to wait and hear. But it's good to know that you've got a social model rather than a medical model, and that's always useful. Thank you. Right, Rob, are you going to go first or Olivia?
It'll be Olivia's going to kick off, and then I'll finish off.
Thank you, Olivia. We look forward to hearing from you.
Thank you, and apologies that I can't be with you in person today, but my diary has conspired against me. So Rob and I are going to try and do a double act with one in the room and one on screen. And so I will start, and I think Elliot has the presentation, if he's able to bring it up.
Yep, it's coming up. We're just 2 secs, all right?
Thank you. And it's always a hard act to follow our wonderful colleagues in Elder Tree and Memory Matters, who we also signpost to on a regular basis. So just really listening to what they say was quite poignant, and I think hopefully we'll follow with some more details around the mental health offer as well.
I think, can I just also throw in my 2 pence worth there? Can you just remind me how much funding you get through the statutory sector to memory matters?
£0. Nothing.
I just think it's really important to point that out.
Great. Thank you for that. So my name is Olivia Craig. I'm the Chief Executive Officer of Devon Mind. We're a mental health charity who operate across Devon, but our headquarters, if you like, are in Plymouth, and we've been here since 1982. We're currently co-located across 2 hubs in the city, one at the Manamead House and one in Ernest English House. And Devon Mind are also the services lead for the Devon Mental Health Alliance. Rob, do you want to introduce yourself and then I shall crack on?
Yeah, hi everyone. Rob Smith, Chief Executive of Improving Lives Plymouth, previously known as the Guild, or many variations of Guild in the title, since 1907. I'll talk a little bit more about ILP and the breadth of services we deliver later on, but we're going to focus on the Devon Mental Health Alliance, Mental Health Alliance, of which I'm currently the chair, and as Olivia said, she's one of the core members and leading on service interventions.
Thanks, Rob. Elliot, if we could have the next slide, that'd be great. Thank you. So when I looked at the topic of discussion today around the role of the voluntary sector, I think for us, the biggest transformation in the history of Devon Mind, and potentially within the mental health services in Devon, which obviously including Plymouth, has been the development of the Community Mental Health Framework Transformation Programme. And that's all around looking at how we have a much greater person-centred, holistic approach to supporting people with the greatest needs, complex needs, severe mental illness in our community in a different way than we've done before. So back in January 2021, 6 voluntary and community sector organisations came together to have those conversations initially around what would an alliance look like. It didn't come out of the blue because we had our eye on different parts of the country where the community mental health framework was already being rolled out as part of some of implementer sites, in particular our near neighbours in Somerset. And we looked at how the NHS was commissioning and working really, really closely with voluntary sector alliances to deliver as an equal partnership on an aspiration to have better mental health services for people with the greatest needs in our community. So we came together in January. It was an intense, probably 6-7 months when we met monthly, sometimes fortnightly, thrashed out our views, set down our values, came up with a charter, really got to know each other and what our aspirations for Devon might be. So I'm not going to read out everything's on the slide, but these are kind of the highlights of why we felt that the Alliance was going to have an important impact in Devon over the coming years. And most of all, and I think it's really important to highlight, that we were passionate about change, and change for the people that we all supported on a daily basis. And obviously our colleagues in Elder Tree Befriending and Memory Matters this will resonate with them completely, that for a very, very long time, by the time that people came to our door for support, they had been around a system that traumatized and re-traumatized them, kept them waiting, moved them onto a waiting list, and with no fault of any individual services, but with the fault of how complex and cumbersome the NHS had become at that point in time. So people were moved from potentially one waiting list to another, depending on what diagnosis they had. They may be moved off those waiting lists. They may not have been eligible for support. They might have been too ill, inverted commas, for primary care services, but not ill enough for secondary mental health services. So by the time they came through the door of all of these organisations and many more in Plymouth and Devon, we were dealing with people who really were at the end of the road. And as voluntary sector organisations with smaller budgets, we had a huge amount of unpicking to do and rebuilding to do of people who had been around the system that had not met their needs. So the NHS recognised this about 3 or 4 years ago when this developed the sustainability and transformation plans around changing that. Elliot, if you're happy to go on to the next slide, that'd be great. Thank you.
He's just doing a quick run from one end to the other.
Oh, bless them. I could have shared it here. And I think anybody within probably the volunteering community sector will recognise lots of these values and principles. And this is what underpins the Devon Mental Health Alliance. And we use that, the analogy that we are a backbone for services within the NHS, but also we do not pitch ourselves as the VCSE mental health services. We pitch ourselves as a voice for the VCSE and also facilitators, builders, creators, and we consistently link out to our wider colleagues in the voluntary and community sector as well. But it's really key. Obviously, I won't go through all of these, and I presume the slides may be shared afterwards with everybody in attendance. So I'm obviously happy for that to happen. Again, for us, really important. I'm not so sure it's happened to the degree we would want it to happen in our sector, but lived experience at the core, considering are we really delivering services that have been designed by people who use them or have used them, their families and their carers. We are not quite there yet. That's a piece of work that needs to be funded, invested in, and we need significant roles within the statutory services also to really lead on that, because there is no point in spending millions developing and delivering services that people don't necessarily want or don't necessarily meet their need. It's also really important to state that the Alliance was never around being shiny and new and really going to come in on a horse and save everybody and cure mental ill health. It was always around not reinventing the wheel and providing a platform to work with what's already there, in particular grassroots organisations doing a fantastic job, but whom have not yet been able to link up with that wider offer and may not have funding and need support in terms of, we do really good work, but how can we cover our rent for the year? And really importantly, thinking about no wrong front door. We'll mention this at the end, but a real ambition to demedicalise the stress and recognise that people's lives are complicated and complex, and they have histories of trauma. There are lots of wider determinants: housing, money, domestic abuse, sexual violence. All of these things impact on people's mental health. So we need to consider all of these going forward. Next slide, please, Elliot. So how the Alliance works in principle. So the Alliance, Devon Mental Health Alliance, set up with the 6 organisations. We then tendered for the Community Mental Health Framework contract to set up a voluntary sector alliance to deliver on this piece of work. This began in around July. We were successful and we were awarded the contract to begin on the 1st of February 2022. And how we've developed is we're working across 4 footprint areas. The 6 members of the Alliance have different responsibilities. Devon Mind and Step One Charity in Devon are responsible for overseeing the delivery of our recovery practitioner offer, whereas our other partners, CoLab, Shekinah, Improving Lives, Plymouth, are really key in the development of that community outreach and community development offer. Rethink, our other partners, lead on co-production because that's something that they've delivered on really well nationally. The aim of what makes the Alliance different, I suppose, than working in partnership previously or just signposting is that we have said we want to be equal partners and we will work hand in glove with you, but you must see us as an equal partner. So we're not another arm of the NHS, and our colleagues within the statutory services have heard us say that more than once. And that's absolutely completely respected and recognised. But that also within this alliance, multi-agency teams and those newly formed primary care networks are absolutely crucial to getting this right. So our recovery practitioners and our community development workers sit in those multi-agency team meetings. In fact, in some areas, such as West Devon, our locality manager for the Alliance often chairs those meetings. So that's a fantastic way of supporting people. You just don't have clinicians in the room and you just don't have other agencies from statutory services, but we have our voluntary sector partners. So you have somebody who might be from the local walking group, you have somebody from the Alliance, you might have somebody from the local CVS in that area, sit around and work out how we can best join up to support somebody to have better outcomes. Really key, no wrong front door, those shared outcomes. We're not asking, shared outcomes, particularly for us, was that we're not asking people to tell their story over and over again, which is what's happened in the older system. really importantly, it's around creating a bridge with the wider VCSE. So how can we support people through the Alliance to get to a stage where they can stay well for longer by connecting them into what exists in their communities? And some examples we've had recently where we've supported people to attend fishing lessons and then take up fishing, or to attend yoga classes. So not that, you're finished with me, so I'm moving you on, but our piece of work is coming to an end, but I'm going to work with you to handhold you into something else within which you will find your own community. We also think it's really important, just because Devon Mind and other organisations have mental health in their title, it doesn't mean that it's not the business of everyone in the voluntary and community sector, and particularly grassroots organisations. We've supported through an innovation fund, small pots of money to organisations such as the Recovery and Education Empowerment Group in Plymouth, Moon Dogs, Volunteering for Health, and Nutrition Organisation, small local gyms. I think Rob can probably talk to you about that. So supporting the wider grassroots organisations to quite often just to get their website built, or to pay their rent, or to fund a part-time worker for a year, so that they can be a place where people can stay well for longer. I think it's really important we talk about being flexible and adaptive. If there's anything that the VCSE does well, it's we can turn in a sixpence, and I think that's something that we've been really proud of in terms of the Alliance. Thank you, Elliot. Next one. Right, Rob, it's over to you for the last 2 slides.
Thanks, Olivia. Just a little bit more context in terms of my role and the different hats that I'm wearing here. So I'm chairing the Devon Mental Health Alliance, as Olivia's been highlighting. But also, I've now been invited to sit on the Mental Health Provider Collaborative Exec Board. So that's sitting on for Devon, for sitting alongside Devon Partnership Trust and Live Well. So at a strategic level, we are treated as the third leg of that mental health provider collaborative. The structure that we have around the Alliance is that there's an Alliance leadership team across the whole of Devon, which includes chief execs of each of those participating organisations, but it also has a representative from Live Well, which would be Sarah Mitchell, from DPT. There'll be, I think there's probably 3 directors: Director of Strategy, Director of Services, and the Deputy Chief Operating Officer. We've got a direct link into the Chief Exec of Devon Partnership Trust, who act on behalf of the Provider Collaborative in commissioning us. And they've really bought into, as a collective, of engaging with us to challenge the system, to develop services, not to become part of the system, but not in a way in which we're subsumed by the system, in a way in which we maintain what's unique about the voluntary sector. And we actually challenge the way that people are supported and worked with, particularly around giving the voice of lived experience and taking that or that demedicalized approach, not being led by diagnosis, looking at people in terms of their holistic support needs. And that's a challenge for us in terms of moving forward. Lots of discussions with professionals, protecting their turf in terms of whatever their doctorate is in. I probably won't go too far down that route, but it leads to some very interesting conversations, because there are a lot of very senior professionals within the system who absolutely recognise what I'm talking about there in terms of moving away from that diagnosis-led approach and seeing people holistically and offering people support from the type of services that we're typically strong at delivering in the wider voluntary sector. So locally, we have commissioned, as well as those organisations Olivia mentioned, we're doing a piece of work with Marbles Lost and Found, or a local CIC. There's the Plymouth Recovery Education Group, Moon Dogs, who are a kayaking group, a Pantheon Gym, where we're doing a little bit of work around functional fitness in the parks based on military fitness. That's something that we've co-produced with Alison Battersby, who's one of the lead psychiatrists in Live Well, and Dr. James Borer. So we can also offer a big training offer to the wider sector as well, in terms of the capacity we've got within the Alliance, and we're just about to appoint our own psychologist on behalf of the Alliance as well, who'll be able to support us in terms of evidencing and need, and in terms of evidence and the impact that we're having. one of the things I just wanted to take the opportunity to talk about today is we're taking referrals through the mental health system. So the work of our recovery practitioners goes through the GPs, goes through to the primary mental health teams. But that can't be the only front door. We've got to have a front door in front of going to see a GP. And we're developing the wider Plymouth Mental Health Network, or re-establishing the mental health network, which can be made up of any individuals that are interested, or any organisations, public, statutory or private sector, to work very similar to the Trauma Informed Network, and how that works across the city as reflective practice, particularly looking at lived experience and feeding back to the wider system about what is and what isn't working. So to be able to speak its truth to power and challenge the system. And I think that's one of the biggest roles that we've got to play. The Alliance has got to manage that balance between being a really good partner in terms of the wider statutory system, but also be a challenge to that system. One of the things we've been able to do over the last year is mobilise really quickly. We've got over 30 recovery practitioners working across Devon now. We were the challenge, and what people thought we wouldn't be able to do, is to be able to recruit in terms of the staffing challenges that are faced across the health and social care system. But we've been able to demonstrate we can grow our own staff, whether they're previously volunteers, whether they're people who have actually been in the wider statutory system, but welcome working in a different culture and a different environment. And we understand there are significant challenges moving forward in terms of statutory provision, and we definitely think we can play a role in terms of any challenges there to redirect resources into our system, so we can recruit and grow a complementary workforce that doesn't have to go down that professional qualification pathway in terms of developing their skills. I'm acutely aware of time. The only other thing I've just been asked to speak about is veterans. And as some of you will know, Improving Lives Plymouth is sits on the Armed Forces Covenant Partnership. We also deliver the Veterans and Family Hub at Ernest English House, with Help for Heroes, with Royal British Legion, with SAFA, all pulling out face-to-face services with only physical drop-in service for veterans in the city. So that's open Monday to Friday, 9 to 5, and we have co-located alongside ourselves Operation Courage, which is the commissioned service for veterans' mental health across the southwest, I think delivered by Avon and Wiltshire NHS Mental Health Trust. So they co-locate alongside us. People can access all the services, veterans can access all the services through the Alliance, all through the other services that Improving Lives offer. We've got about 13 different major projects that we deliver at present. We've just undertaken the piece of work with Pantheon Gym, which I mentioned, but all the work that we undertake through the Veterans Hub is grant funding through fundraising and grant applications to independent trusts. So there's no funding that comes through the system locally to support veterans, and as far as I'm aware, there isn't really a defined strategy around veterans' mental health that's owned locally and delivered locally, and that's something that we really want to move forward on. I'll probably better shut up now, and because we are significantly over. So, oh yeah, just one briefly, with my other hat on, I'm also chair of the Emerging Wellbeing Hub Partnership. So we've got the Wellbeing Hubs in Plymouth. We've got a core partnership of 5 Wellbeing Hubs, or 6 if you include Ernest English House, because that means ILP have got 2. And we want to talk with a whole range of other partners who join us as a Wellbeing Hub network. So the idea is that anybody could walk off the street into any one of those Wellbeing Hubs, and if needs be, access support or be informed how they can access support around mental health services. So that's key on our agenda moving forward.
Okay, thank you very much indeed for the 4 of you for that race through what your services do. So, questions? Right, I've got Kathy first, then Will.
Thank you. You're all voluntary organisations, and I'm just wondering how you get your funding, and whether, particularly with the elder tree, people have to pay subscriptions to do the various activities?
Yeah, we are commissioned by Plymouth City Council, so we do get about 60% of our funding from them. And we also have smaller contracts with Live Well South West and NHS Devon, and then through various other bids, the lottery, etc. We do ask for a £2 contribution for any of our activities. If anyone can't pay that, then obviously we'll waive the fee, but we do ask for that contribution as well to help with the costs.
Will?
With your like the elder tree and your memory matters, obviously there's the person with the dementia, but there's quite a lot. Obviously, you've got the carers as well. And there's quite a lot of knowledge with carers. Obviously, unfortunately, people don't really recover from dementia, but the carers, I'd like you to be a parent, but the carers, they've got quite a lot of knowledge. How do you sort of collect their knowledge, if you like, so that knowledge isn't lost when somebody stops being a carer, and help advocate for better? Is there do you have group? Is that part of your activities?
Yeah, so there's a few carers groups. Improving Lives run a carers group as well, who they run their carers group at moments, and they have the carers in one room, and they have those with living with dementia in another room. The Elder Tree also has carers groups around people with dementia, and so do we. What we tend to do with our group to collect that information is during those memory cafe sessions that we've got, carers sit together, they share their experiences and they share their learning. And also what we do is we have a carer that sits on our board of directors and somebody with dementia, so that we can then guide using their knowledge as well. But you're absolutely right, carers have a wealth of knowledge, primarily around how to navigate a very complicated system, which is we harness very clearly.
Could I just follow on? As Kate mentioned, Improving Lives run Caring for Carers, which is the open to any adult carer across the city aged over 18. And we've got a multitude of different carer support groups for people with different conditions and different circumstances. But then we all feed up to the Carer Strategic Partnership Board, and then we try and use the lived experience of that into the board to develop the strategy for the city. So I'm hoping we're making the right inroads in terms of making the best use of carers' voices.
Thank you. Zoe?
So just two things. First thing is moments. We've met a few times, haven't we? And lots of my residents go to moments and they use the Mindful Art Club specifically. But I also just wanted to kind of thank you for that, because the warm space, the buy one, gift a meal kind of thing that you do is just incredible. But my question is, the Wellbeing Hub partnership that you were talking about, and anyone can walk in off the street, or that's what you want to get to. What do you need for that? What does it look like? And kind of how long would it take to achieve? Because obviously there's so many people that could benefit from that.
Yeah, well, the Wellbeing Hub network was established just before the pandemic. So you've got Improving Lives at Manamead, you've got Colebrook, you've got the Four Greens Community Trust, you've got the Reece Centre run by Bananas at Plympton, and you've got the Jan Cutting Centre run by the Wolseley Trust. So for the last year, I've been leading on designing a new hub's governance framework for how we all work together. So you get the same quality service offer that you, in terms of walking in off the street to any of those organisations, and so you can access from there any services delivered by all of those organisations, and there should be a comprehensive knowledge about the wider health and wellbeing services across the city. We're in discussions with the YMCA at Honick Knoll, with Shekinah with their new property at Stonehouse Creek. With Age UK, who've also got a specialist wellbeing hub. I'll be extending an approach to Kate and various other organisations that can join us to extend that network. The idea is that people will see the wellbeing hub sign, and it will become, backed with a small marketing budget, it will become known in the city that wherever you see that sign, you can walk in and get that level of support, or be directed to and not just passively directive, actually supported to access a service. Then we also see a third tier of satellite information hubs. That could be in libraries, could be in corner shops, they could be in barbers, where there's an information point where, again, that would direct people to one of the core hubs. We're developing a website at present. We'll have a full-time worker between all the hubs who will coordinate all of this activity, and each hub's also got a hub advisor working with the community locally to support the community to reach into the hubs and use the facilities and the services that we've got there.
That's amazing, and thank you. It's so passionate. I love it. Thank you.
And of course, it's the other things that you run as well with Century Solutions and all of that lot that brings other people in, because obviously they're going to end up, well, they're not end up, they will have their requirements as well. So it's getting all of those together, isn't it? I think one recommendation comes out of this today, this session, is that we all need to make sure that we come over and support you, Kate, over there, and make sure we have our cake and our food to keep the system
I do
going.
every Saturday morning.
So that's good. Any other questions, Natalie?
Thank you, Chair. Yes, just to declare an interest, I sit on the board for Reese Wellbeing Hub. Regard to that. My question is regarding Elder Tree. Obviously, the referrals come in. How long can somebody attend for? And also, as part of that, you said actually you try and link people to the nearest place they are. My experience is different from that, from the conversation I had. You know, do people have to wait longer to actually get into somewhere that actually is near and therefore would be supporting them in terms of isolation by being closer to their home?
So to answer the first question, they can stay as long as they like. Most people do until they can no longer attend for whatever reason. So yeah, we have people with us for years. So we are in 50 different locations across the city, and obviously we have a range of activities in each place. We try not to have waiting lists, and we obviously try to, if people want to be near to where they live, and most do, then we try to put them into a group near to where they live, but sometimes those groups do get full. And so then obviously capacity is an issue, and we either say you can travel to a group in another place, or you can be on a waiting list for a group in your locality. Obviously the idea would be to have as many groups as possible in each locality, but that's not going to happen. So yeah, where possible, we'll signpost to somewhere that they, if that specific group is full, we'll signpost them to somewhere that is easy for them to get to. And as I say, we try not to have waiting lists, but just with the growing number of referrals we're receiving, it does happen.
Just briefly on the Memory Matters, you said about the cafe. Is that the only means of the self-fund? You're self-funded through the cafe. Is there other funding that you gain?
So the cafe, the cafe itself just runs the downstairs. That's how the money is. So cafes, by the way, don't make a lot of money, especially now. So the cafe itself downstairs is almost self-sustaining. The advice and support hub that we give, we have to fundraise for. So we have to raise every single penny ourselves for that, and we do that through a variety of different fundraising. And some of the groups that we run are, some of them are lottery funded, and they're for a finite period of time. But we do aim to have a sustainability profile for all of them. But yeah, our advice and service isn't funded at all.
You're doing an amazing job then, considering what you're doing. Yeah, what you're offering.
Any other questions? No. I've got some good news for you, panel. The speaker that we're having coming next is actually going to come back tomorrow morning, because they were coming anyway tomorrow morning, so that bit will be there. So you'll be glad to know you will at least be getting your lunch in a minute. Anything else anybody wants to clarify at all? No. Okay. Can I thank Olivia and the three in the room here for coming along and sharing the information with us. It's been really, really beneficial this morning to be able to put things into perspective as to what's happening. This afternoon we're going to hear from Live Well and some of the services that are provided there. So it's given us food for thought to be able to question them in more details, and we've got somebody from Veterans coming tomorrow as well, so that will be really useful to put that into perspective. So thank you very much indeed. I think all our brains are a little bit addled, so I think we probably need to raise our blood sugars. And so I will say that we need to be back here for a prompt 2 o'clock start, but you get an extra 5 minutes, folks. That's got to be a sheer miracle. So thank you to everybody, and thanks to Jake and to Elliot for getting the system going for us. So we'll take a break now, folks. Okay, see you in a bit. Thank you. Bye. Okay, folks, welcome back, and welcome to everybody that's come for this afternoon session. Thank you. The first title is Emotional Health and Wellbeing Overview, and that's Emma and Claire. The floor is yours.
Thank you, Chair. We wanted to first of all introduce ourselves so you know who you've got on the presenting this afternoon. So I'm Emma Crowther. I'm one of the Strategic Commissioning Managers for Plymouth City Council, responsible for commissioning services for children, young people and broader wellbeing.
Hello, I'm Claire Hetherington. I'm the Principal Educational Psychologist for Plymouth City Council, and I'm responsible for the Educational Psychology Service, but also the SEND support services in schools.
Good afternoon, everybody. I'm Anita Dykes. I am the Directorate Manager for CAM services within Live Well South West.
Good afternoon, everybody. My name's Tracy Clasby. I'm Assistant Director at Live Well South West with a responsibility for children, young people and family services.
Thank you. Good afternoon. I'm Louise Arrow and I'm Head of Mental Health Commissioning at Devon ICB.
Thank you, and we wanted to take you through our slide pack. We've done it in one slide pack because it generally that's how we approach emotional health and mental health support for children and young people in the city as a system. So we didn't want to chunk this up too much. We do genuinely all work very closely together and very collaboratively. So that's how we wanted to present to you this afternoon. So if you're happy, Chair, shall I take us through? I've got to drive the slides as well, so this could be interesting. So on the agenda this afternoon, we wanted to walk you through the following areas. So an overview of emotional health and wellbeing for children in the city, the services that we have, the demands and the needs that we're seeing and the challenges we're facing, but also some of the opportunities. There's a specific section on CAMS, and colleagues will talk you through data, including on weights and response to need there. We also want to bring you up to speed on some of the wider system initiatives for children and young people that are happening locally, sub-regionally and regionally and nationally. And then finally, we wanted to go through a bit on how we manage transitions for children with emotional health and wellbeing needs. So for us in the city, and like I say, we do work in a systems leadership way in this space, we have a number of shared key drivers that inform our work for children and young people with emotional health and wellbeing needs. So one of these is A Bright Future, which is our children and young people's plan for the city. This is our partnership plan. And one of the key strands and priorities in there is healthy and happy, ensuring that children are both physically and emotionally well and able to live fulfilling and happy childhoods, leading to healthy and happy adult lives. We also work very closely with the requirements of the NHS long-term plan, which has significant focus on emotional health and mental health for children in there, and significant targets in relation to that as well. Very important in the city is the inclusion agenda, ensuring that all our children and young people are able to attend school, attend education and training, and are included and welcomed and able to take part. We also, as everybody knows, are a trauma-informed city and working towards embedding that, and that really drives through our work in this agenda. And increasingly, a framework that we're using in the city is the I Thrive framework, which we'll come on to in more detail later on. That allows us to have a graduated response to understanding children's needs and putting services in place around them. So I'm going to hand over to Tracy and Louise now.
So we thought it would be useful to look at during the pandemic what we were seeing through the needs of our young people within the city. So we were seeing a rise in young people with anxiety and stress, concerns around family relationships and suicidal thoughts. During lockdown, we identified that young people were suffering with poor sleep, loneliness and isolation. And now we've come to out of lockdown, out the other side, and we've got a combination of all the above. We have seen an increase in eating disorders and disordered eating, and that's been seen nationally. And we've also seen a rise in children coming into care in the local authority, which our services has been supporting the system around those young people.
Yeah, thank you. And just to add, sorry, on that previous one before we move on to the national demand, is to say that the modelling that was done during the COVID pandemic recognised that for mental health, and I'm talking children and adults, but particularly in the context of children, is that we know the impact of the pandemic for mental health is now. So obviously during the pandemic, it was obviously the physical health and the hospital response, but we knew the impact would come through, which is now what we're starting to see. Which leads us quite beautifully, thank you, Emma, into the slide around the national demand, just to put into context in relation to referrals for mental health. So we do know that over the last 8 years, between 2012 and 2020, it's been the fastest growing health speciality in terms of demand that we've seen. During the COVID pandemic, which picks up on the points I was referencing earlier, it was a bit of an uneven pattern of referrals. And it was really different. So what we did start to see as a system was 53% fewer referrals nationally. This was data, but also reflected locally. That did start to increase and recover in November 2020, and then as schools reopened and all of the easing of some of those restrictions happened, what we started to see between March and July was a spike in the referrals. And now we are most definitely back to high levels of referral, and there is a picture later on in your slide deck that kind of reflects that picture nationally for those who prefer a pictorial representation. Thanks, Emma. Yeah. Great. So just
EHWB?
emotional health and well-being. Yeah, so it's a really important part of how we're approaching it. So whilst there is mental health, and we all have mental health, it's kind of a really important part to kind of reflect that for some children and young people, they will need a very specialist mental health response because they're mentally ill. And for some children and young people, it's a response to their emotional distress, to try and make sure that we're meeting all of those needs. And moving away, I think you heard it earlier on this morning, in terms of with that medicalisation of distress being a mental illness. Yeah. Just a bit into the context and picking up on the fact that what we did see during the pandemic was this significant increase, both in demand and acuity for, thank you very much, eating disorders and disordered eating. So across adults and children, we saw a 90% increase in hospital admissions. So that means that for people who were physically unwell, so obviously for an eating disorder or disordered eating, it's a combination of a physical and a mental health aspect. So for children, you'll see specifically there nationally, this was the increase that you can see across, and you can see the increase in the 17 to 19-year-olds coming across. Okay. And then the next slide, for those who may prefer a slight pictorial representation, you can see the pattern of referrals that was received nationally, and you can see the spike. So you can see the drop that I was referring to, and we need to remember that aligns to the other national restrictions that were going on at the time, as well in terms of people were locked down, weren't they? So kind of referrals, perhaps from primary care and into schools was different, and you can then see the steady increase. And when you align that to when the schools locked down and other restrictions eased, you'll see the pattern over top on that. And the next slide, just for context, is just around prevalence. So again, reflecting on what I was saying in terms of that increase of demand, and that children's mental health has been one of the fastest growing specialities in the health system. There is some data in relation to prevalence. I just want to note now at this point, you'll see that that prevalence data very much references to boys and girls, males and females, and I appreciate that not all children and young people will identify as a male or female, but the prevalence data and the local demographics we are collecting starts to reflect that difference, but that's the data at the moment that we've currently got. So I just wanted to make sure that that was recognised through. So as you will see there, and I appreciate, I'm not sure it's the first time you might have seen the slides, so just giving you some time to read onto them. What you'll see is that in the younger 7 to 10 age range, boys are the ones who are presenting with more needs, and that changes as they get older, so girls become the highest prevalence. And what you'll see there is the biggest increases in that 17 to 19-year-old bracket. And so essentially the key message you might have heard before is that prevalence is 1 in 10. We are now seeing it's a 1 in 6 prevalence for children and young people. Okay, I don't, Tracy, anything you want to add on to the prevalence, or you?
No, I think you've covered it.
Yeah, okay. And just a point, just to remind, is that 50% of mental illness is diagnosed by the time children are 14 years old. Okay, so we have some early indicators in children's of the longevity for mental illness.
So all of our services that we're providing is based around the iThrive. So I think historically it was very much segmented when young people and families needed to access support. But what we've been trying to do within the way that we deliver services now is to be able to access early support. You may need to get more help or getting help, and it gives people much easier access, and we try to do it at a low level first. And once they've been through the low level, they're able to get additional help. And what we've just started to do, and we'll show you on a different slide, is map where we're getting access into our services around each of those quadrants, and that enables us to move resources and develop services around the areas of the iThrive where young people are needing to access. So it links in with that early so the iThrive is around the access, getting more help up to risk support. But if they need to access services, it's not a cut off between. It's the young person's in the centre and they're able to access it wherever's best for them, rather than one service or another.
So this one, so in terms of the iThrive model, which is based on an evidence based framework, basically. Sorry, I couldn't think of my words then. So what in a pre-COVID, and I think it's really important to say that the framework that we had and these percentages here are pre-COVID. So in the research and the evidence that was produced, is that what it was showing is that 30% of our children and young people will require getting advice, which basically means a meaningful one-off contact that enables them either at their choice to self-manage, or actually we don't want any more support, I just want to self-manage, so they need that really good quality advice and guidance. 60% will benefit from a getting help offer. So I'm going to use the word time limited, but I don't mean that you can only have 6 sessions and then you're done. I'm meaning that as in we recognise actually through a time limited piece, goal-based, focused outcome, that children are able to either self-manage or recover. And I think it's really important that we recognise that not all children will recover. Some will need to use ongoing strategies throughout to manage their difficulties, and that will ebb and flow as they move on and experience life. And then what ideally we should be seeing is that less children and the smaller percentage of need is shown within the getting more help, which is a much more extensive specialist mental health support wrapped around with multi-agency around them. And for risk support, it's very much focused on children, young people who, for a number of reasons, may not be able to engage in the treatment offer available to them for various reasons in their lives. The evidence or the offer isn't just quite working for them. So actually they need something different, but there's no evidence to go, we need to do this. We need to work differently as a collective to identify what support we need to wrap around them. And the key thing on risk support is that we're enabling them to keep safe. And that's a really important part to recognise. And the key parts, as Tracy was saying, for the I Thrive is very much their needs led. And some of you may be more familiar with the old language of tiers. So actually, which kind of indicates you to go through tiers 1 to get to 2 to 3, kind of implying you need to get iller to get to where you need to feel you need to be. That's not what I Thrive is around. It's a really important reason why it's a circle. And the child's at the middle, and your needs dictate where and how you access support. You don't have to get, which young people telling us, I feel like I have to make myself really ill to get the support I need, and that isn't what it's around.
Just to add on from what Louise was saying, I think it's really important around enabling, and Louise has probably covered it really, but it's about enabling that early help and early access. So when young people feel they need to start accessing services, they're able to get it early, so they don't feel that they have to wait until they get into crisis before they're able to access a service. And I think it's, and you'll see in some of the data that are in another slide. I think it's showing that actually young people are accessing that really early help and advice to start with, which is it's really positive, because that's what the base of the model is on.
So that leads us nicely into what we have in place. So you've had an overview of some of the needs, and we're going to take you through now the services that we have in place to support our young people.
Thank you, and apologies. You need really good eyesight to be able to read the content on that slide. I'm so sorry. It looked really big when I made the slide. And I think in context, I appreciate we had to move the agenda because of time. So some of the things that I would have spoken about here, I would have picked up in the previous slot to set some context for this. So hopefully we can work through that together. So I'm not quite sure what you actually can read of that, but what it's reflecting is that, and very much reflecting on the I Thrive model, is that actually service provision for young people around their mental health and emotional health and well-being needs to be across our system and across all of our providers and our organisations. So primary care have a really important part to play in terms of supporting and identifying children and young people. We know that often that's the first point of contact for some families. Some of these slides we're going to come back to later on in terms of system initiatives, so I'm going to gloss over some. Obviously, we have CAMS as a very important part of the integrated contracts that we have with Liverpool South West. We also have mental health support teams in schools, which again will come on later. And I think some of you probably are aware of what mental health support teams are. That's a really key part of that getting advice and getting help offer. And what you'll see on those slides, you'll see that we've broken down roughly to where the needs-based groupings align. We also have the South West Provider Collaborative, which I'm going to just pass over to Tracy.
So the South West Provider Collaborative is a collaborative of provider organisations across the South West region. Historically, from about 7 years ago, they were managing the low secure and community forensic pathway, and on the 31st of October in 2021, they took on the adult eating disorder and the children's tier 4. So Plymouth in Plymouth is one of the units that sit as part of that wider South West Provider Collaborative. So there's four units across the region, and we'll go on in a little bit later in the slides around how that's benefited our young people with some investments and some initiatives.
Thank you. And then just to carrying on with the provision that we've also got for Plymouth young people, we do have a Devon health-based place of safety. So our provider is Live Well.
So many of you may know, so as an organisation up at Plymouth, we've got on an add-on to the existing building, which is a place of safety, so 136 suite, a health-based 136 suite for any young person across the whole of Devon, so that's Plymouth, Devon and Torbay. If they're detained on a 136 or a 135 of the Mental Health Act, they're able to access that unit, which is independent from the inpatient unit, to have their Mental Health Act assessment and then the decision about where their further care needs to be provided. And I think that's really shown that since that's been open, none of our young people have ended up in police cells, which is really, really important. And we monitor those, every young person that comes through the place of safety. We review their cases with the team across the system to see whether there was anything we could have done better, any learning, working well with the police to see whether there's anything we can do to, if we've got a young person who comes in recurrently, is there something we can do as a system to put things in place to stop them getting to a point where they have to put them on that 136 to enable them to be safe. So it's been a really, I think it's been a really positive provision for our local children.
Thank you. And obviously, a key part of our providers a provision moving on is with our voluntary sector organisations. So they deliver youth and counselling offers, and I'm not going to talk too much about those because they're coming later on, but just to kind of reflect, our voluntary sector are a key part of our integrated offer to children and young people. Obviously, our local authority colleagues are a key part of our provision and support as well. And just want to pick up, sorry, just go back onto the voluntary sector organisation. We do also have a provision commission called Pete's Dragons, which provides suicide, postvention or bereavement support for children, young people, adults and their families. And that is for, I know your focus in this position is on children, young people, for any child or young person who is either being directly bereaved by a suicide, either confirmed or suspected, and either recent or historical. And equally, it's around not just having been directly bereaved, if they're just feeling affected by a suicide, for example, perhaps of a loss of a friend or someone in the neighbourhood, in their school, whoever and however they feel they need to reach out and seek support, then that's the commission that we've, that's the provision we've commissioned across the system. And very last, just moving on as well, finally, the district general hospitals, in this case Derriford, are actually part of our pathway of support because they need to be there to provide the physical health needs of any of our children and young people who present. And lastly, I think you heard earlier on from public health colleagues, very much focused on the, if I get the iThrive model, that centre, that thriving element, which is around that prevention and early prevention aspects. And what you'll see when hopefully you've got more time to look at the slides and perhaps bring them closer to you, because of the size of them, you'll see that what you'll see there is a spread across all of the iThrive quadrants. So we're really starting to build up and map against the iThrive, so we can really make sure we're targeting provision where our needs for our young people are.
So we're going to go into a bit more detail now on the range of services, but hopefully from what you've seen so far, you've seen there are services in place to respond to all levels of iThrive. And how we know if these are working, we do draw information, trends, themes, young person's feedback, and feedback from partners up through our emotional health and wellbeing steering group in the city, which is really well attended, including our school partners and VCSE organisations. We constantly look at the data that we're getting, as well as that qualitative feedback. And we feed that into a governance group, a specific healthy and happy governance group, which supports our work, and it links us as well to some of the wider regional and sub-regional work with our ICB colleagues. And I think a reflection over the last 5 years, our culture has really changed in this area of work. We talk about our children now. There's much less of a sense of this is a social care child, this is a CAMS child. We try, when we get into those really difficult situations with very distressed children, to really genuinely work collaboratively together in the interest of the child. So that's been a really positive development. And we've all been involved at various stages of that, and with those very difficult meetings. So we're going to move on now. Claire's going to take us through some of the work that happens in our schools.
So when we think of an educational context, we're looking at children with emotional health and well-being, but we're also looking at them within a special educational needs framework. So we're thinking about an emotional health and well-being difficulty that might cause a barrier for that child to access education and to make progress. On this slide, you'll see some DFE data, which gives us an idea of the extent of what we refer to as social, emotional, mental health difficulties. That is one of the 4 key areas of special educational need, which were redefined in the Education Act of 2015 as a priority area that should be a new focus in its own right. Obviously that was pre-COVID, but since then we've looked far more closely over time at how this area impacts on other aspects of learning. We're looking at a holistic perspective for children, so we're looking at how they relate to others as well as how they achieve, and how they're able to engage with the educational system as a whole. In terms of the level of need, we have a framework which we call a graduated approach, which mirrors the I Thrive framework. And you'll see there that we refer to a number of 18.9% of children with special educational needs as having an education, health and care plan, which is a statutory plan. Those are for children with the highest level of need. The SEN support figure, where social, emotional, mental health is described as the primary need, is the area which is where we're looking at an advice at an earlier stage, an early help framework. So those figures refer to where children have social, emotional, mental health as a primary need. That's not to say, of course, that it doesn't come into other areas of special educational need, or that it doesn't exist in its own right, and it may not be reflective in a child's or young person's attainment, but emotionally they may be really struggling to attend. So as far as the local authority strategy is concerned, we have two main strands, which is the inclusion strategy and the SEND strategy, and both of those draw upon the graduated approach. And there's a focus on looking at the overlap that we need to understand levels of need and improve engagement to close the gap in terms of children's academic achievement. And the three areas that we look at are a whole school approach, which is absolutely crucial in terms of affecting the culture that we have in terms of the environment that children grow up in. And then looking particularly at vulnerable groups. So they might be, for example, children who've been through the care system or who have an allocated social worker. And then we have identified complex casework systems where we need to have very specific individual plans long term for some children and young people. So moving on to the next slide. The Educational Psychology Service bridges the gap between education and mental health in schools, and the team work as applied psychologists within the educational setting. So we don't just work with emotional health and well-being, we also work with other aspects of special educational need. But our age range is not just in schools, it's aged 0 to 25, so we're working very much in the early years with regard to looking at early intervention and infant mental health support, but also post-16 with colleges and with young people, very much trying to focus on preventing young people from becoming NEET. Each Plymouth school has a link educational psychologist. It's really important to have an anchor in terms of triage for planning and support within the school context. And that educational psychologist works with the designated person within the school, which is usually the special educational needs coordinator, to provide a synergy to bring together a professional group to support that school in its endeavours to create the right environment for emotional health and well-being, whether that be at a whole school, group or individual child level. The Educational Psychology Service is a free service from the local authority. It's a core service, and so it does have to be prioritised and delivered carefully so as to meet the right level of need at the right time. And therefore, in school settings, we work closely through a termly planning meeting with school staff to prioritise and decide which strands of the professional groups around the school will pick up which pieces of work. But we also have an early helpline so that parents can contact us if they need to. They don't have to necessarily wait until a key person in the school says, oh, you can be referred. We're always prepared to talk through the system and to pick up concerns from parents and carers and young people themselves. So you've gathered from what we've been saying that a key element of this is multi-agency support and the importance of understanding each other's roles and making that accessible to key staff who work with children and families, as well as those children and families themselves. And so in schools we have link workers from CAMS, mental health support teams and education welfare. And at our termly planning and consultation meeting with schools, we often have these representatives from these groups present at the planning meeting, or they have fed in key information into that planning framework to enable the prioritisation process and review. That process allows an ongoing review because it's termly. We also work within other contexts that have an impact on access to education and learning. So the virtual school, which is the provision for previously looked after and children with an allocated social worker, has educational psychologists and links to other mental health professionals as part of its provision framework. And we've also issued joint guidance with colleagues in health around particular areas of need for vulnerable groups. So an example of that would be the guidance that we've put together and which we're using on emotionally based school avoidance. Again, bridging that gap between inclusion and special educational needs and health. We also operate traded services in order to try and broaden the offer, and a number of different psychological services are available to schools and settings for that, and this provides a framework where really early help can be embedded in schools should they choose to take up the training or the consultation on offer through those mechanisms. And you'll see I've given some examples there. We do have a traded arm ourselves, but also Plymouth Learning Partnership have a multi-agency support team, and Psychology Associates do a lot of work with previously looked after children with attachment needs. And I'm going to hand over now to talk a little bit more.
Claire, before you finish, can I just ask you to explain what traded services are? Because
Yes.
this is being broadcast and there's probably people out there that don't think of that. And I think you also mentioned NEAT.
Yes, yeah.
Can you explain what that is as
well,
please?
NEAT is not in education, employment or training. So in other words, a young person who is not accessing any of those things on leaving school and therefore could be in a vulnerable position. Traded services are services which can be available through subscription. In other words, they're not they're not a free core offer, but they are available through a subscription in order to pay for the staff provision to meet those needs.
One of our commission services that supports Plymouth schools is Progeny, which is delivered by The Zone, which is obviously a key VCSE organisation in the city. And they have two main aims, really a whole school approach around equipping the whole school community, so anyone involved in and around schools, including governors, parents, teachers and young people themselves, to really understand emotional health and wellbeing, the impact that can have on children's lives, and how to respond as kindly and appropriately as they can. There's also work through Progeny directly with young people to support their own emotional health and well-being and resilience. So I put on the slide there some of the examples from the provider activity in 2022. So it's some of the numbers there are quite large. So workshops for children and young people, work with parents and carers, significant numbers of staff trained in mental health, first aid, additional bespoke training. So it's a really good workforce development offer in the widest possible sense in our schools.
So then we've got our mental health and support teams. So currently we've got 22, so we've got 2 teams across the city, and we in reach into 22 of the pilot and secondary schools. And this is around supporting young people with mild to moderate mental health issues. And it's actually trying to get in to see young people and support young people during education before they get to a point where they need a secondary care mental health service. So it's on so currently it's a pilot, and it's on the back of the green paper from 2017. And it's got 3 main core functions around delivering an evidence-based intervention for mild to moderate mental health issues. All of our clinical staff within these teams do a specific training to deliver these evidence-based interventions. They're able to support the mental health leads in each school, and also liaising with external specialist services to support the children, young people and their families getting support at the right time. And the team have done quite a lot of work around getting some feedback from families and schools and teachers around how supportive this has been. And I think, and I should have included it in the slides really, we've had some really, really good feedback from the families and the young people around how this specific team have supported them. So yeah, that's where we are with that at the moment.
So we also have our online offer, which is delivered by Kooth, and is available for any child age 11 to 18 in the city, and is a national organisation, so there's a wider link up there. And there's a range of services available via that route, and it's really important for us because it's an out of hours offer. So children can access that at any time, day or night, and it includes live chat, it includes peer support, as well as tips and guidance for young people. And you'll see, so this is data from a 2-year period from January 2021 to December 22, but you'll see some of the numbers there in terms of the logins. It's used significantly in Plymouth, with quite a high proportion actually of our young people from ethnic minorities choose to access services that way. And it's easy to think that an online offer deals with quite low level need, but actually what we can see is that young people's sort of first self-reporting into that website, 66% judge themselves a bit more severe in terms of their needs, with anxiety and self-harm the most prevalent issues for them. But we know that that service is well used, and it does connect up to our other services. So schools promote it as well, and it is proven to be a really useful way of our young people accessing support. And the other service that we have in place is, a tiny slide again, I do apologise, is delivered by Young Devon, another commission service for us, again for secondary age pupils, and offers one-to-one counselling and group support, either via schools, so 20 schools and some of our special schools, or also in community venues as well. The breakdown there in terms of some of the demographics, so the majority of our young people accessing that service are girls, and the majority of the referrals, when we look at them, are coming in from the west and the north of the city. We know in terms of waiting lists, 43 young people are currently waiting an appointment for the community part of the service, and the schools hold their own waiting lists for the schools-based part of the service, but that's very carefully monitored. Again, we've got some data from the last 12 months here in terms of the amount of counselling sessions, single sessions of therapy and wellbeing conversations that are delivered for our young people. And the feedback, again, as Tracy said, with the mental health support teams in schools, positive feedback, 91% reported being satisfied with the service, and 80% felt that their mental health had been improved by engaging with the service. That brings us to the end of that section. So we've bombarded you a bit there. So we thought you might welcome an opportunity for questions.
Okay, thanks very much indeed for that. As you say, a lot of detail in there. One thing that I'm picking up, you're saying you've got 22 pilot primary and secondary schools on the mental health support teams. That's obviously a small portion of the number of schools in Plymouth. How did you choose them, or did they self-nominate, or how did you come across them?
This was a combination of the numbers of referrals to our CAM services already, and it also was self-selection. So schools wanted to be involved in the pilot project. All schools were given all schools across Plymouth were given the opportunity to take part in the pilot. Some were more enthusiastic than others, and I think we wanted to capitalise on those for the mental health support team pilots because we absolutely wanted to make this work. There's lots of research that sits around the mental health support teams from Exeter University around how effective they are being, and each individual practitioner, emotional health and wellbeing practitioner, takes part in audit and research, as does the school. So the school gives feedback, as Tracy's alluded to, and each individual practitioner and each individual child is given the opportunity to feed back into that research, but it was a self-selection in the majority.
And where did the funding come from for that?
The NHS. So the funding for mental health support teams is really essentially to us from NHS EI. And so as equally is the number of allocations into the Devon system. So we can't, so the reason why there's two is because actually we get given regionally as a Devon ICS an allocation of teams which we then need to kind of identify and prioritise across our footprint as to where they rest. So there is some indications at recent events that potentially some additional funding will be released from central government in relation to identifying some more mental health support teams, but as yet I don't have any more detail around that.
So the ICS basically has funded it.
Yeah, ICB.
That's
Yes.
what I needed to get.
Sorry, yes. I thought at the start, yes.
Exactly. No, it wasn't some Mandarin up in Whitehall. It's come from the ICS, Devon ICS. Right, thank you.
But the money has come from centrally in government down to the
Jemima.
Thank you. I've just got a couple of questions. How does Couth pick up on someone who might be needing some kind of access to some higher level support?
So we don't have a formal arrangement with them, but Couth are absolutely aware of our local need and our local first response services. So we haven't got to a point where they would call us immediately and let us know there is a young person there, because the majority of Couth work is anonymous. But essentially what they would do is that they would absolutely direct that young person to access formal response services if they identified a need. Clearly, they also would safeguard that young person. If somebody was not anonymous and they were able to identify that young person, then they do have a mechanism to call 999 for that person and keep that young person safe.
So they just have to say to the young person, I think you need to access X, Y, or Z service.
Yeah, absolutely. And that comes from a CAMS background of a talking therapy. People have to want to engage. However, if there is an identified risk in that situation where a young person is at immediate risk of danger, either to themselves or others, then Couth would act on that.
And the admissions for eating disorders, I can't remember the dates now, but it's gone up 90%. Okay, so that seems like extraordinary to me. Is that happening nationally as well?
So not only nationally but internationally. So as a response to COVID, we think there is research being undertaken around this field, but we think that the lockdown and restrictions meant that young people had their social isolation took them to their rooms, and so eating disorders became a way of controlling their life. But the research into that is just being developed now, but it certainly is not just a national, a regional picture. We've definitely seen that. Nationally, it's definitely been seen, but internationally, some work from America has shown the same picture.
Do you know if there's anything happening nationally, at least anyway, to try to come up, because we need a plan to sort this?
So yeah, I've got some update around eating disorder locally and regionally. Our system development's a bit further on, so I can talk now if you want, or we can leave it till then. I don't mind. Is that all right?
Sorry, just to add to that, there is also, I think nationally, there is much more emphasis on the early prevention of eating disorders and getting in early with young people. The difficulty is that that wasn't possible during our COVID pandemic. So that's why we've seen young people getting to a need of having significant physical health compromise. But the investment, the scrutiny and the research in that area is actually nationally coming through.
Lauren?
Thank you. A few points of just seeking clarification on my part. On slide 14, promoting a whole skill approach around trauma-informed training, I am just wondering, so what's the progress on this? How many people have been trained? What's the goals in terms of coverage per school? And is that training going to be ongoing and refreshed on an ongoing basis?
Can I just ask, when you say slide 14, because I think your numbers are different to ours. Sorry.
It's under the support for schools header on your slide.
Yes, so, sorry, could you repeat the question?
So just on the training, I'm just wondering what progress you've made on that. So how many people are being trained? What are your goals in terms of coverage per school?
Yeah, so the trauma-informed training for school senior leads, that was in 2 phases. The first phase, there were, out of the total number of 96 schools in Plymouth, there were representatives from 77 of those schools who attended, with a total number of 168 attendees. The phase 2, which is the level 5 diploma, there were 3 cohorts of 20 people on each cohort, so far 60 people have attended for that diploma, and they represented 59 out of 96 schools, which is 61%. There is a phase 3, which is going to be around whole school support, and that is currently being prepared. This training was commissioned by Schools Forum from Trauma Informed Schools UK specialist providers. So it'll be very much not just about the training, as I'm sure you're probably thinking. It will be about what is the impact in those schools on the development of their whole school approach to support emotional health and well-being. Now, running alongside that, there is mental health leads training, which is a separate strand, which is looking at mental health more widely than just a trauma focus. And that has been picked up as well by approximately 60% of schools I've got from our figures that on the chart so far.
Magic, thank you. And then moving on, how long people tend to be on the waiting list? And I think that was in reference to waiting to see where am I? Sorry, there's so much information. It's all really brilliant. I'm just getting a little bit lost in the slides. So it's the last slide before we stop for questions. So 43 young people are currently awaiting an appointment via community referrals. How long are they spending on that waiting list in average?
So it varies per young person. So there's a triage conversation to get an assessment of their needs. So some young people will be seen quicker. So it varies between sort of 3 or 4 and 6, 7 weeks normally, but it will vary depending on the level of need and also the availability of therapists and the sort of venues to see them in. So it does vary.
Magic, thank you. And then one last one for me. Back to eating disorders, we heard about the impact of COVID. We also heard from Youth Parliament earlier about the impact of social media, and I'm just wondering if that's also another mitigating factor in that particular realm. Is that the case from your end?
I think there's a definite recognised need between social media and mental health of young people, absolutely. The impact of social media on the perfect person and how young people, particularly young females, view that is definitely a piece of research that is being undertaken. If you want an opinion, I think my opinion is that it absolutely does have an effect, but we'll wait for the research to back that up. But I'm absolutely sure it will show that there is some mitigation.
Natalie and then Zoe.
Thank you. A couple of things. Firstly, you said about Progeny being a whole school support system, and can you tell me whether or not all schools are using it? Again, alluding to what Lauren was saying earlier about Youth Parliament, we're certainly hearing from the Youth Parliament that the support for emotional well-being within the schools does not appear to be across all schools in the area. It's certainly coming up as one of their key findings in their recent research. So are all schools buying into this and in terms of actually working with it?
So that service is commissioned by Public Health, and I haven't got that information, but I will get that and feed that in, absolutely. And also what's being done, if it's not all the schools in the city, what's being done to bring those schools that aren't engaging in that into that work.
Yeah, that leads me to the other side of it, where you said about the additional training, the mental health leads training. Only 60% of the schools, are actually engaging in it. And likewise, where you said before about the different pilots, that actually there's a sense that actually not all schools are engaging in things that actually should be a real priority. Because at the end of the day, if we can't get our young people's well-being right, then the rest falls down. It's a building block, isn't it? So, it's something that really needs to be looked at and stressed how important this is for all schools, not just for some.
And I suppose, do they not engage because they haven't got the finance to engage, or is this a free service in inverted commas?
So Progeny is funded by the local authority, so yes, it is a free service.
There's no excuse really, is there then? Okay, Zoe.
Natalie covered pretty much what I wanted to say, but the mental health lead in schools, can that be anybody? Is there a specific role or education required?
The schools themselves decide who they put forward as the mental health lead, but it is usually a senior teacher with responsibility for inclusion or special educational needs. That is our evidence in terms of the people who've attended the training.
And another question is for CAMS. So CAMS is predominantly for under 18s, is that correct? So what happens if someone's on the waiting list and they cross over? So we normally would have a discussion around what our waiting list looks like, and what the needs of that young person. So all our young people go through our early help offer. So it depends what the onward offer for that would be. Depends what their need would be. It would depend on the reciprocal waiting list for our adult services. It's a very customised discussion around that, the needs of that young person.
So it's very hard to say that's what we do in all cases, because for some young people it's absolutely appropriate for us to take them onto our waiting list if they're 17 and a half. For other young people, it wouldn't be. We would say to them, is there something that we can do in the meantime around our early help offer, and then put them onto the adult waiting list, but it is very much a very individual discussion.
Thank you.
Jemima?
I think my question's for you, Claire. Can every child who schools think could use the help of an educational psychologist get to see one in a timely way?
So if we use the graduated approach, we try to offer a consultation service for every child, which will enable us to decide whether that child actually needs to see the educational psychologist. And we use that approach with parents too, because we find that many parents would like their child to see an educational psychologist, and it isn't always necessary that they have that specialist assessment. It can be picked up through psychological approaches used within the school or by other professionals. So I would say that we offer consultation regarding every child, but we don't see every child where there's a request that we do an individual assessment, because we need to prioritise the children who have the highest level need.
So is every child that you identify is of the highest need seeing some? I'll ask it the other way around. What's the longest a child in Plymouth would be waiting, that you've gone through that triage process, thought yes, they do need our input? What's the longest they're waiting at the moment?
Well, they should have contact with an educational psychologist usually that term, at least a conversation individually. Depending on the need, it might be that we have a joint meeting with the parent and the special educational coordinator, special educational needs coordinator within the school. At the moment, we have to balance the work between the statutory assessments, which I mentioned earlier, and those have to be delivered within a certain timeline. So once that is requested officially, the educational psychologist has to complete their assessment and submit their statutory advice within a 6-week timescale.
Zoe, and then we're going to move on after that.
Yeah, so if the school provision, if a child, so for example, I have a constituent whose one child goes to school and the other child refuses to go to school and is homeschooled, what is there for them? I mean, I know that this is one that has come to me as we've brought it up, but there are many that kind of go under the radar there. What happens with them?
So there are probably a number of different scenarios associated with children who don't attend school for various reasons, and we have different routes of support depending on what the reason is that they're not attending. It's picked up through the inclusion and attendance service, who have regular meetings with school, and they gather data on the number of children who are, for example, missing school more than 50% of the time, which are classified as children missing out on education. And those children have to be carefully monitored and plans put in place with the school in order to support them to return. And the Education Welfare Service has statutory duties related to that, with potential legal enforcement. But obviously, if there is a mental health difficulty that's causing a young person to miss school, then that needs to be looked at in terms of the graduated approach to inclusion and what is the right type of support. So the emotionally based school avoidance framework that we've devised jointly with CAMS, for example, provides templates for carefully planned meetings with the family and the young person to look at the psychology of why the young person is unable to attend. And there is a plan put in place which is about supporting a phased return to school or alternative provision. Sometimes that is at an SEN support level, which is at getting help, or getting more help, which is at a more specialist level. And you might have, for example, an educational psychologist directly involved in that team around the child, which we would call it. But you'd also likely have mental health professionals from CAMS involved in supporting that child. And if absence from school due to emotion-based school avoidance has happened over a long period and is entrenched, then we would look at whether that young person needed a different type of provision other than their mainstream school. This would be in conjunction with the parents and the school, and they might ask for specialist alternative provision, of which we have some alternative provision which is jointly funded through health to support that. But it is a graduated response according to the level of need of the young person.
Parents and young people can also self-refer, so can use COOth, can self-refer into the Young Devon Community Offer, and also self-refer into the CAMS Early Help Offer as well. So they don't, while that support that Claire's describing should wrap around them, they can also take that step themselves as well.
Yeah, so that, yeah, absolutely. But my concern is how long do they have to go before someone picks up? There might be an issue here. So 50% of the time, how much is 100% that you take 50% from is kind of my worry. How long does this child, is she out of school before someone says, well, maybe there's an issue somewhere, because they're probably not going to self-refer. So how would we know that?
So this would be picked up by the Education Welfare Service on their regular visits with schools, and they have, every school has a register where they keep, I'm sure you're aware, where they keep detailed attendance for every student, and they would, with the Education Welfare Service, have certain thresholds where they would report children as missing education. I'm not part of that service, so I don't have the exact detail on that, but we could find out and come back to you on the process.
Okay, thanks. Right, moving on. Anita, are you leading now about CAMS? You're going to do it between you. Great stuff. Thank you. The floor is yours.
Having said its name, I'm going to do the first one. So I just wanted to kind of put into context there in terms of Live Well South West against some national benchmarking in terms of CAMS. And I think it's really important to recognise there that across all of the indicators, Live Well South West CAMS are absolutely beating all the national indicators, which is really great. So what we're seeing is more and more children in Plymouth are being seen by the CAMS service, which is a reflection of that no wrong door, the implementation of Thrive, the getting advice, all of the models that you've heard about before. And more children will be seen more times, and we've got greater workforce than the national average. So I think it's a real celebration story to sell. And I just wanted to kind of put it into context for you all.
I should have printed mine off a little bit larger or something next time. So if you look at the top left-hand chart of your screen, so this will show the referrals that have been into the service over the last 4 years. So the first bar is pre-COVID, and the last bar is this year that we're in now. But we're not quite at a full year effect. So it has dipped a little bit over the last couple of years through COVID, and it is slightly down this year, but we are anticipating that as we go into April and go over the next 12 months, that those referrals will go up. The pie chart on the right-hand side is the last quarter of young people that we've seen, and we wanted to demonstrate how we're seeing young people within the I Thrive quadrant. So this is something new that we've been able to pull out of our system that we've been working on with our business intelligence team, to be able to, where we're developing our Thrive model, where there's no wrong door, is easier for young people to access at very early, at the early age stage of needing some support around their emotional health and well-being. This is able to demonstrate where we're seeing a larger cohort of young people accessing our services right at that beginning, which is, we're really, really pleased to see, because that's the reason that we're able to, you know, you don't need to any longer access your GP to refer to CAMHS. You can do it, you as a young person, you can do it, you can refer yourself. Parents and carers and family can refer young people. So it's just showing that we're able to increase the access. So the next graph on the bottom is our crisis assessments in hospital. So these are our assessments that we see for young people that are in our acute hospital. So this is not tier 4 or place of safety assessments. This is accessing into our acute hospitals. So as you can see that those referrals have increased, and they are starting to drop this month. So if you, we need to be able to make sure that we see any young person within our acute hospital within 24 hours. We're just actually doing some work as a system in with the ICS around looking at actually being more specific around when our young people access our service. So at the moment, we have a children's psychiatric liaison team based up at our university hospitals, Plymouth, and they run from 8 till 8, 7 days a week. So that's been increased. The time that they're, the length of accessing the service has been increased. Actually, it runs till 10, excuse me, not 8 in the evening. So that's been extended. And we're just looking at the moment around what time young people are accessing the service, what time are we getting the referrals, whether we need to extend those services over a 24-hour. What we need to be mindful of is that we want to make the best use of the funding available and what makes most sense to young people when they're accessing the system. What we don't want to do is say, yes, we need a 24-hour service when actually the demand's not there and we need to pull some provision out of other areas of service to access that. So we're doing a piece of work around what actually is that demand and how can we support that. The next graph underneath is around our urgent community assessments. And although it says 5 to 10 days, we've pulled this out of some other data. So the graph that you're seeing is actually around 5 days. So this is where we see a young person, as it says on the graph, around 5 days. In the middle of the year, there wasn't many referrals, and this links to our commissioning and our development of our home treatment crisis team. So as part of the long-term plan, and Louise will describe it a bit further in detail, we've had some investment in the organisation around improving access around crisis. So, and one of the functions around that access within the long-term plan is a home treatment. So we've got additional funding within the organisation. What has been a struggle is recruitment. And we've been able to secure, so we've gone out for recruitment a number of times for mental health practitioners. So this can be nurses or allied professionals. Unfortunately, we weren't able to recruit in a timely way. So what we've been able to do is secure some agency staff. And not on an ad hoc basis. We've secured agency staff for a long term. So we know that if we've got a post out today, by the time you advertise the post, you go through the recruitment process. If they're working somewhere else, they've probably, if they're already in the NHS, they've probably got to give 1 to 2 months notice, which is quite a significant time from interview to actually getting somebody in a job. So what we've done is took the decision to, where we've been able to get some additional staff through an agency, we've booked them for what we call a long-term placement. So they're booked for 3 to 6 months. So we make sure that we get some continuity of care. They're able to gel much more with the team, work much more closely with our consultants, and work much more closely with our acute colleagues. So we're not quite there within meeting it within the 5 days, but I think we certainly are on a trajectory to be reviewing all our young people within the crisis pathway within 5 days. Thanks, Emma. So this is our early help referrals. So this is our access into, so the first two slides, and we've put both in because, so the top graph you'll see is that where our young people access our service. And as we said earlier, I think historically, young people had to access CAMS through their GP. We know this was an issue with our young people and their families because that's something that was fed back to us quite a lot historically. And around the I Thrive model, it's about getting that easy access, no wrong door. We don't want young people and their families having to go to a GP to fill out a piece of paper to say my son needs to be able to access or get some support for their emotional health and well-being. So young people are able to refer themselves into the service now. In fact, we've got a phone line where families and clinicians or teachers or professionals or anybody the young person knows are able to access our service to be able to gain some support for that young person. So we're monitored that around our 18 weeks. So that is 18 weeks to referral to treatment. And as you can see, within the last 3 months, we've been hitting that. What we have done is done some investment around our early help support. So we've had some investments through via the Devon ICS around some mental health investment standard money and mental health service development fund. So we've put quite a significant amount of investment in our early help, so our early quadrants, which enables us to see our young people much, much quicker. And the second row down is our young people that we're seeing within 6 weeks. So we wanted to show the progression of where I would say after a number of years now developing we've developed a pathway and the ability for young people to access our services in a timely way. So eating disorder. So this is our urgent eating disorder referrals. So we need to be able to see this is within 20. Is this within 7 days? Sorry, I couldn't quite see the graph. And you'll notice that our performance has dropped a little bit over the last couple of months. So I wanted to provide some assurance actually. So in December, we had 5 referrals that came in on the 20th of December. And with Christmas and with New Year and the bank holidays, so that extended some of those times. We've had some families that had requested for the assessment just to be a little bit further on because they didn't necessarily want to come in between Christmas and New Year. And also just about all of our eating disorder team had COVID. So we had a really, the team were doing really, really well, lots of work with the families, getting to a position where we were hitting those 5 days and those couple of things have deteriorated the position. But we monitor it on an absolute regular basis. Any young person that isn't seen within those 5 days, we look at those cases individually and we accept what we call an exception report. So from the team, we would want to know, if Jane wasn't seen within time, then we'd want to know why not, when were they last seen, what was the outcome, and so we're really specific around why those young people haven't been seen. So
Tracy, can I just say your slide actually says seen within 4 weeks. That's what your slide is saying, not
sorry.
5 days.
Yeah, it is 4 weeks. I apologise. We've got a couple of measured and I couldn't quite see it from there. So it is within 4 weeks.
So yeah, just to come in, so the national standards that we've got are for routine referrals in eating disorders 4 weeks, and with urgent it's within 7 days. Obviously emergency end is 24 hours.
And we thought it would be helpful to put our ASC assessments. So our autism assessments within Plymouth, the pathway is split between 2 providers. So we've got the CDC, which is our university hospitals colleagues, that provide the assessments. If we've got a young person in the system that needs an assessment that has also got a mental health issue, they'll be seen by our neurodiverse pathway. And we thought it would be helpful to see where we are at the moment. We have got some additional resource now within that team that we've put in within the last month, and we're working very closely with the ICS around our neurodiverse game changer. So that's sort of where we are at the minute. Do you want to go to the next slide? Sorry. Do you want to do this bit?
So our secondary intervention, apologies. So our secondary intervention will be for those young people who go through, so as we said before, all our young people go through the early help pathway, and they will be assessed as having some immediate needs and get in the iThrive framework around signposting and getting help, and they would be dealt with at that first assessment appointment. For some young people who are complex, who require multifaceted support, they would require maybe psychotherapy, CBT, family therapy, or any or all of those combinations. They would go into wait for our secondary interventions. All those young people, we also have a digital offer, so we've tried, it's very challenging in our secondary intervention, I'll be absolutely honest. This is where we are looking at our very specialised therapy staff. There certainly isn't a cupboard full of them, and they are very difficult to recruit to. We've done a number of initiatives around supporting the education through funding from Health Education England in supporting our secondary intervention services like psychotherapy. We support, it's a very long time that they're in education, so potentially they could be in education for 4 years, and we would support them through that time in the hope that at the end of those 4 years that they would join us in a substantive role. So there are a number of Health Education England initiatives that support us in doing that. We also have a digital solution, Silver Cloud, which has been really supportive as an intervention in its own right. It's guided self-support, it isn't self-help. And practitioners still need to be remaining involved with young people. But young people have fed back to us that Silver Cloud really does support them and in a way that they want to be supported. It isn't the same for everybody, but it is offered if it is suitable for the young person, and the feedback that we've received so far has been excellent. If a young person is waiting for a secondary intervention, then they are called every 3 months to make sure that hasn't changed, that they don't require any additional support. As Tracy alluded to earlier, we have an early help line where a duty line where anybody can call for additional support and to understand if there's anything else that they can do in that position to help them. And also we have our 24-hour, 7-day-a-week crisis service, which links with our adult first response service and provides young people with an immediate response to any crisis, risk or need that they may have. It is challenging, it certainly is challenging for recruitment, but we are working on how we develop those. We've invested in our early help services, but we have acknowledged that investment in our secondary therapy is absolutely something that we are concentrating on. From an outcomes point of view, it is important that we understand that what we're doing is being effective. So we can have all the investment in the world, but we need to make sure that we're investing in the right place and making sure that our investment is having the desired effect that we want for young people. We have something called paired outcomes, where we would look at the starting point of a young person before their therapy or before their intervention, and their outcome at the end of that intervention. There is some national work on moving towards goal-based outcomes, and some of you may be familiar with the care programme approach. That is changing to something called dialogue, which is very much goal-based. and for the young person themselves to identify what is the goal of their treatment and what is their goal at the end. What do they want to achieve to make a difference to their lives? That may be going back to school, it may be that they want to start engaging with their friends, it may be that they don't want to access social media as much. There could be lots of reasons why young people want to access their services, but it's important that we take the outcomes, and there's much more of a national and international focus on outcomes and outcome frameworks for young people. Then there isn't huge amounts, but most of them are goal based, and dialogue I think will be a really good position. We obviously gain friends and family feedback, and I don't know if you want to.
So currently through the NHS we do I'm sure a number of people have had an FFT test, so it's our friends and family. We're currently just changing over the organisationally changing over the provider that runs that survey for us, and we're very much working with our teams to actually get much better feedback. So we do get quite a lot of feedback, and we do get quite a lot of positive feedback, but it's a bit sporadic in where we get it. So all of our team managers at the moment are working with their teams and their young people, and we've asked to go out and ask families and young people within their service when would be best to get some feedback around the services that are provided, because actually the friends and family was very much driven through the NHS from an acute perspective, but actually it's really important that we get this feedback. So we're hoping that the new provider that we're just starting last week actually to support this with us will give us much more ability. So they've got things like QR codes that children and their parents and carers can scan in waiting rooms, or we've got some business cards with a QR code that they'll have their number of their team that they're working with. So it's much easier to get that feedback, as well as a paper and a self-addressed envelope if people want it that way. Following the survey that Healthwatch did back in 2022, I meet with Healthwatch on a quarterly basis now. So there was quite a lot of feedback around CAMHS over the last 2 years. I think it went back to 2021. So we have looked at that feedback internally, and what myself and Tony agreed that we would meet on a regular basis, and if anything came in the meantime, that we would act on it there and then, because it's, when you're looking back sort of 18 months, it's really difficult to identify if somebody put that in anonymously. It's very, very difficult to speak to that young person or that family, and that's been really, really helpful. So I meet with Tony from Healthwatch on a quarterly basis now to pick up any feedback that we've had around any of our services.
And in a similar vein, so myself and Tracy attended a Parent Carer Voice session. Parent Carer Voice, for those of you who are not familiar, are a parent organisation for Plymouth, and it is in other areas, where parents with a particular need around SEN will come together and provide support to each other. So I went to the Parent Carer Voice session on preparing for adulthood recently, and you'll hear further on in our discussions when we talk about the 16 to 25 pathway. I went to ascertain their views and to get their involvement and talk about some co-production in that pathway, because although I thought I knew what I was going to hear, it was actually, we had good and bad. There were particular situations that we could have helped with immediately, and that's what we certainly did when we went to a parent carer session, where we were sat next to parents who gave us scenarios, and we went away and dealt with those scenarios immediately, which I think really it means that interaction becomes meaningful. It's almost a bit late, 6-7 months down the line, for parents to complain. We need to get in early and try and resolve the issues so that they don't have any need to complain, and then the complaint is actioned immediately. So Parent Carer Voice was a very interesting session, and parents are very vocal around the needs of their young person. And so going to listen to them is enlightening and actually really, really important for that co-production voice. Similarly, I went to speak to Young Safeguarders, and they were a brilliant group, and I really enjoyed it, and I'm going to go back. I did have to put my flak jacket on and my big girl pants, but it was really great to listen to them. And they had very good views and very valid views around the services that they have, but they've invited me back to go and talk to them, and I'm really looking forward to it.
Workforce. Probably over the last 3 years, we've had a significant amount of investment into our children and young people mental health services, which is amazing, really, because it's enabled us to develop things like home treatment. We've been able to develop our eating disorder pathways. We've been able to enhance our children's liaison psychiatry service. It has made a significant difference. What is the challenge, however, is that this is national funding that's coming down, and I think it's safe to say that, you know, Plymouth sits here and we're part of the ICS, and the investment has also gone into Cornwall. It's also gone into Somerset. So recruitment is a challenge. We have done some different things where we've done recruitment development posts where the post might be a senior practitioner, but we would recruit them in a more junior role, do some training and competencies and development. So it gives that member of staff not only the ability to do the development, but it also supports our recruitment. As Anita said earlier, we've worked with our local universities where we've got staff doing their psychotherapy training. So they need to be able to be in an organisation while they're doing their 4-year training, which means that they will see our young people while they're doing their training. They get their supervision from their course. And, you know, we have some posts, and it would be nice to think that after that time, they'd like to stay in our organisation. So we are looking over and above, and can we do anything else? So Anita went to Wales on a recruitment fair, so we're just trying to sort of think outside the box of what we can do to recruit staff, but it is challenging. And currently our vacancy rate is 12.3%, which is sort of in line with the rest of the organisation, really. We've got a couple of spots within our teams that have got vacancies, but like I said earlier, what we're doing is we're putting some long-term, so our early help pathway, for instance, have got a number of vacancies, but we've got some really, really good agency staff, and we've got them in for a long time, so it enables that development, enables them to be part of the team. So that's what we've done to try and mitigate some of the risk. Thank you. Any questions?
Thanks very much indeed. Just a couple of things from me. We're talking a lot about the older children, 11 plus. What about the littlies? You know, they can't just pick up a phone when they're 5 years old and say, I've got an eating disorder or whatever. So how easy is it for parents to self-refer in? We're saying about youngsters, but how easy is it for parents?
Again, it's as easy as picking up the phone. So every Monday to Friday, 9 to 5, we have a duty worker whose sole responsibility is to provide advice and guidance and help support with referrals. We have an online referral system, so if it's 10 o'clock at night and somebody wants to make a referral, they can go on to Live Well Southwest, go on to the CAMHS referral and send that form. We also have an email address where, again, if you were to call up and say, how do you make a referral, we would give you an email address, so you didn't even have to fill in the form. So I think we are still in a position where we need to advertise that, if I'm absolutely honest, and we've got a campaign that we're working on so that we can get that information out to schools, to parents. I don't know if some of you saw the lovely ICB information leaflet that went out about maintaining your health. We're thinking of doing something similar around mental health for young people so that parents know where to go for help. I think there still is that layover that you have to go to your GP. And I think that that's definitely there. But we've talked to our parents and our families and asked them what they want, and they've said no wrong door. So we want to be able to pick up the phone and not have to tell our story 2 or 3 times. We want to be able to get some advice. It isn't always appropriate for somebody to come to a tier, to a tier 2.5, 3 service. When we've heard about all of the emotional support and health and wellbeing support that's available in the system, but I still, if I'm absolutely honest, think that there is an advertising campaign that we need to do to families to let them know exactly what's out there and when.
So Emma, something to add to POD, Plymouth Online Directory?
Absolutely, and also I was itching to get in there because of our Family Hub programme as that emerges. And so our first family hubs, our phase 1 family hubs, will open in Plymouth by the end of June this year. And we're working very closely with LiveWell anyway as one of our key partners in that. And that will be intrinsic to that offer, is making sure that we have those safe spaces, those safe opportunities, and those services wrapped around families. Also, as part of the Family Hub work, there's going to be the development of a parent carer panel that will help to drive forward again some of our system change and hear from parents and carers. So there's lots of places we will continue to do better to link all these services into, make them as visible as possible. And key to that as well will be the digital offer. So we need to build on POD. When we went out to talk to parents about the development of family hubs, they were saying to me, I want to see on my phone, I want to be able to see that there's cooking classes in the west of the city, or there's emotional support here, and I can click and I can get to it. So, and obviously that's not for everybody, but we need to make sure that our ability to reach families is as tip top as it can be.
And I think also because councillors get inquiries from left, right and centre, it's something that we need to be making sure that the councillors' pages have this information, because if you sit on the health scrutiny, you might possibly know. If you sit on education scrutiny, you might possibly know, but there's a whole lot of other committees that, audit and governance, would they know? I think so. It's making sure that this information is there at fingertips. The other thing is, we had the Youth Parliament in this morning, and they were raising about the mental health, I call them a professional or whatever. And of course, if you have a senior teacher, a Senko or whatever in school, there is always the chance that they're occupied on something else. So it's really, how do we make schools more resilient, so that if there's something crops up, it can be dealt with, rather than the child ending up, or young person going home at the end of the day in much more of a pickle than what they came to school at. So I think it's, how do we make schools more resilient in that respect?
So that's where the progeny work comes in, that whole school community. It's also where the trauma-informed schools work comes in, and making sure, as you've picked up earlier, all schools are absolutely engaged with that. So we're trying to create those opportunities, those places where practitioners can get together and feel confident, because these are really difficult conversations, really frightening conversations at times. And also for parents to feel confident in having these conversations with their children as well. So some of it is as much about equipping the people around the child as the child. So we're sort of trying to work on all those different levels, really. But you're absolutely right. And we want to we talked the other week, Tracy, didn't we, about having the information so people fall over it, that you can't avoid it, really. It's so easy to find and easy to access that support. There's so much information out there, but it's difficult to get to the right information for Plymouth families, and it's how do we draw that together.
It's all sorts of things, isn't it? I mean, single parent families, how does that parent deal with the opposite sex child? Completely, it's sometimes very much a mystery, isn't it, for them? So yeah, I think make it easier. I've got Jemima and then Zoe and then Natalie.
Thank you. I've got a couple of things. You touched on the fact we had Youth Parliament here this morning, and they've done. Have you seen their report that they've done? And have you spoken to them? Because you said you've seen the Young Safeguarders, so I would definitely suggest you should speak to them, because they've done a brilliant bit of work, and they've got an awful lot to say about how they think the systems could be improved.
It's on my list. I've been in post about just over 12 and a half, 13 months now, 14 months maybe. my background is I was matron for children's services at Derriford, and I am absolutely, I love going out to speak to young people. The majority of my time is spent data and working and bids and money and things, but the highlight of my time is to go out and speak to young people, so I absolutely will be in contact with them.
Oh, my second question is, I can't remember.
I come back to you then.
Come back to me, please.
Yeah, Zoe.
She's just done that, and I've done exactly the same thing. Sorry. So yeah, just a couple of things. So obviously we can't get a doctor's appointment these days anyway. So that putting things out online is absolutely vital, I think, because you just probably would push it off if you're not dying, when you're not in serious pain. And mental health, I guess, for lots of people is something that they'll put back, especially like with children, because it's your responsibility to look after your children. And the other thing I wanted to say. So people perceive that it's your responsibility to look after your children, sorry. And the other thing I wanted to say, was I brought up earlier, was I was walking around one of the schools with a head teacher, and a child was walking around. This is a 12-year-old child walking around the school, able to do so, not being, told off or chastised in any way. When we came across another member of staff who was SEN, the head teacher said, "Well, so-and-so's walking around," and they said, "Yeah, we're aware, Mum's on her way." Now, at what point do we say that, perhaps this isn't the best, whoever deals with him normally is with somebody else, because there's 1 to 3 students. So there definitely needs to, in my view, be a lot more involved in the SEND.
Not too sure if there's a question there or an observation. Right. No, it's okay. That's all right. I was just waiting for the punchline. I was waiting for the punchline and it didn't come. Natalie.
Thank you. Just a couple of things. Firstly, you talked about funding for the early helpline. Obviously, there's concern with that if it's funding that is a short term or a set piece of time, or is this ongoing? What next if that funding finishes?
Do you mean the early help pathway, or so all of our funding that we've had within children's? We'll go on to some pilots in a minute, which is non-recurrent, but everything else is recurrent. So everything that we've built in since, correct me if I'm wrong, Louise, 2019-20, and then the following year, and then this year, and going into next year. So all of those, this is what we're going to do. It's all now funded recurrently, so it's all permanent staff. Where we've got vacancies and we've got agency in, those posts are permanently, so we can keep going with that until we get somebody in substantively.
Might be slightly cheaper once you've not got agency.
Yeah, there is a bit of discrepancy, but
that's good to hear, because obviously my concern was you might be, managing to cut the numbers now, but then, suddenly there's no money, then obviously it's only a short term, sort of thing. So that's lovely. Thank you for that. The other one was about autistic spectrum conditions, and you said about there being a 25 weeks for wait. We obviously had wonderful news about CAMS reducing and the waiting list reducing. Someone's on the autistic spectrum. Parents are sort of trying to cope with a child or young person with ASC. 25 weeks, obviously, is that an average, or is that a 25 week? That is your maximum that they're waiting, and what plans are in place to try and reduce that? Because that's half a year practically, isn't it? We're back as same as it's like waiting lists, etc. used to be. How long things going to be?
Absolutely. So that 25 weeks is the longest wait currently, and is on a reducing trajectory. So we monitor that. We monitor it obviously through our regular performance internally, but we also take that to our neurodiversity steering group through the ICB. So we also take it there as a comparison and a learning event to how we're managing to reduce against a national picture that is increasing. So just to be aware of that, we are so the 25-week wait isn't a wait where they do nothing. So in that 25-week wait, you may wait for your assessment appointment, But during that time, you will have school observation. You will have, so we send out what's called a Connors questionnaires and ADOS questionnaires. So there's lots of things that families will be doing in that 25 weeks. We don't wait for appointment 25 to then give you all these things. We try and get everything done so that when you get to your eventual assessment appointment, that everything is ready. So there's developmental history that needs to be taken. There's all sorts of things that come with an ASC background. So you're absolutely right, 25 weeks is too long, but it isn't in vain, and we try to make the best use of the waiting time. We have put additional investment into that team to try and reduce that wait. And we are also doing what's called the neurodiversity game changer, which is looking at the whole process of assessment and why young people are being assessed and why are they on a waiting list. We are just about, you'll hear a bit more about the pilots in a second, but we've got a couple of pilots from the ICB that look at pre-waiting list a support and need-based assessment. So are they waiting for an assessment because they have a need, and can we address that need before they get to their assessment? So usually it's around sleep, behaviour, eating, disordered eating, sensory issues. So all of these things we want to address, and this is one of the pilots, before they get to their assessment. And so we can reduce that drive and need for assessment because we've dealt with the need. We've also got some additional funding to look at our post-assessment support, and we're developing a pilot around enhancing the support available once somebody's got a diagnosis.
So we're trying to reduce that reliance on the assessment. The diagnosis is the key that unlocks something for children. And I think you need to describe really well that sense of how can we respond both sides of that, but reduce that bit in the middle that actually doesn't necessarily deliver a lot for families.
Louise, put you on the spot here. Do we get the same per head in Plymouth as East Devon get for the funding, or are we sort of not getting a fair share?
So I can provide some information around that, but my last look at you are getting your fair share.
That's all right, then we'll let you go later on when you finish this.
But I can provide some information
if
if that
kept you
was
hostage otherwise.
But it's something we're also looking at constantly, and also looking as we move forward into how we kind of look at that from a children and adults perspective as well, to make sure the needs of the drivers.
Jemima, have you remembered your question?
I have, thank you. I think it's about the reputation of CAMS, because if I knock on people's doors, which I do a lot, if CAMS comes up, and I'm not criticising the service, I'm telling you the real life feedback. If it ever comes up, it's always in a negative way, and I think I worry slightly that might. I think that the narrative is there's no point because you won't get an appointment. It'll take forever. Do you know what I mean? And the things that you talked about telling families more, and I do think there is something to be done around changing the reputation of CAMS and the pathway to CAMS and what it offers and how you can actually get the help you need if you can. So yeah, I don't know if we think of some kind of recommendation around it, but I think it needs a kind of wholesale revamp that actually, because I do think, and I said earlier in another session, obviously when people complain, that does tend to be the dominant narrative about things. People don't tend to shout about if they've had a good experience in this arena anyway. So I do think there's some work to be done there, only because I am worried that some people might just say there's no point, even like going back to the GP, getting a GP appointment. Most people I know don't even bother now. And it might not be that that's the case everywhere, but there is this narrative, which is based in fact, that it's hard, so you just don't bother. So I do think there's something that needs to be done there. I don't know if you agree with that, but I feel like it's quite important.
So I absolutely agree with you. I think, I've either worked in CAMS or been supporting CAMS for a number of years, and I absolutely, hand on my heart, think we're in the best position in the city that we've been for a long time. And I think within our wider ICS system. I think we're in a really, really good position. Nationally, we're in a very good position. And I do think we need to do some real, revamp is a really good expression, because when you talk to families, and we've all been in that position where there's no point because I can't get access. I've spoken to GPs about something else, and they'll bring up CAMS, and I'll be like, I don't need to come and see you. If they ring your receptionist to say, you know, my child's struggling with anxiety, tell them not to book an appointment with you. Just tell them to ring this number and we'll see them. And it is about, one, educating the whole system, the professional system, whether that's education, primary care, acute hospitals or wherever, but also being able to say to families, you know, it was difficult to get in at one point, it was challenging, and we do have challenges within the service. I wouldn't sit here and say we don't, but it is so much better. We work so closely with Emma and her team and Louise and her team, and it just feels very different. So I would absolutely agree that is something we need to do.
I'm just conscious we've got 2 more items yet, and we're over time. So quickly, yeah, because Lauren's going to ask a question.
Only because I was in, for another reason, I was in a GP surgery. I'd got there 8 o'clock in the morning to try to get an appointment for a member of my family. And there was a woman behind me who was absolutely distraught because she couldn't get a GP appointment to get her 15-year-old son some mental health support. Now, I didn't know that they didn't need to even, I could have said to her, you don't need to do that. So I think, you know, there's definitely something that needs to be done to get that message out in a wider way. Thank you, Mary.
Lauren.
It's been covered, so we're grand, we can move on.
Now, that makes a change. Okay, thanks very much indeed. We'll move on to the next session, please.
Just to add one other thing, that with the Family Hub programme, one of the big pots of money that comes attached to that relates to adult mental health, and thinking families and the impacts of adult mental health on being able to care sort of resiliently with and for your children. So again, we will be joining all that up. We can't look at the children in isolation of the families, so we'll be doing that as well. So bit of a blurred slide. It's only one slide for this session, with some other bits behind it. So Louise.
Yeah, thank you. So I just wanted to, and there will need to be some updates to that slide, so I do apologise. Just in terms of some of the long-term plan for going forward from 23-24 going forward. So the key drivers that are in the long-term plan, just to highlight. So eating disorders remains a very key driver in the long-term plan to ensure that 95% of children and young people are seen within the 4-week and 1-week waiting standard. Ongoingly would always be the need to ensure all of our plans align to absolutely reflect that integration, which the whole changing the Health and Care Act in July this year is really formalising and supporting, and I'll be able to talk to you through more about that tomorrow. Continuing, and absolutely quite rightly, is the fact that we need to make sure that we are increasing the numbers of children and young people who are able to access services. I think what's key to note in the long-term plan, it has to be NHS funded services. So whilst we may have a range of provision that's funded from across our system, the only numbers that count are those where there's an NHS funding element to them. And that's the way the long-term plan has been written into that. So we've got an increasing target against that, and really importantly to say, to give you a position for Plymouth, you're absolutely smashing your access target, is the only way I can say that. But I think also to note that the access target is only currently moving towards 36% of children accessing a service, so there is still a number of children who funding are not necessarily being able to access the service they need to. 0-25 is maintaining, we'll pick up a little bit more of that later. Mental health support teams, I think that's the one to note. So obviously, as I said before, that's essentially allocated funding position and teams allocated to us. So we have achieved what we've been given and that rollout. And as I said, there's more going forward. So mental health support teams is not part of the long-term plan going forward, but something that we're still progressing and wanting to ensure that we continue and develop. And once we get some more clarity as to whether or not there will be any more allocations available to us to apply for, because we do need to go through an expressions of interest process, what we are looking to do is kind of going, if the teams are what we have, and given that we've got progeny and all the other aspects in it, how can we maximise that workforce and that offer to enable all the schools across Plymouth to access what's needed to. I'm going to look at my piece of paper because my eyes are failing. And in terms of what's ongoing is to ensure that children and young people are able to access a crisis response. There are some changes to some of the functions that have been listed there. So what's going forward from 23-24 is that for children 24/7, they should be able to access a single point of contact 24/7. So at the moment, we've got the phone lines as Tracy and Anita referenced. The requirement is also that they'll be able to access 24/7 a crisis assessment, but we do need to do that within the context of understanding what the demand is, when is the right time to make sure we're maximising our use of resources. There has been a slight change, just to kind of draw attention to, is that in terms of a brief response, that is not required to be 24/7, that's extended hours. And intensive home treatment teams, again, extended hours, not necessarily 24/7. So I will do an update post this meeting. Apologies, the operating plan and the long-term plan is landing with us and we're currently responding to it. And I'll be able to give more of an update once that's finalised through to relevant people.
So I was just going to add a couple more bits. So around eating disorder. So as part of the Southwest Provider Collaborative, there has been some. So there's been a recent agreement around doing a business case around a specialist eating disorder within region. So a little bit of background. We don't have one local. So when I say locally, can you hear so behind me? Sorry, it wasn't me. Within the Southwest region, we don't have a specialist eating disorder unit at the moment for children. This is so any young person that needs to access a specialist eating disorder has to go out of area, which is not nobody's feel comfortable with a young person going hundreds of miles away. So as part of the Southwest Provider Collaborative, we're just looking at now a business case as to the options around having when I say local, I mean Southwest eating disorder unit. So that is quite a significant development. So obviously that's to go ahead with the business case, and everything is involved in that. There is some non-recurrent money for investments that's coming down through the provider collaborative. So this is on top of the ICS. So we've put some investments in we've got an additional DBT therapist within the community. We've got some funding for a social worker. We've got organisationally, we've put some funding in for the system. We've got a member of staff that now's just started around our children and young people, our complex needs integration post. So we felt that as a system, we need somebody to be able to work everywhere. And they might be employed by us, but actually it's Helen Little has come into post. She's already out meeting schools to see what they need. We just felt we needed some capacity to go out and meet young people and work with those complex cases and work with education. What is it we need as a system to support some of our really complex young people, and to be able to support them by thinking outside of the box rather than, well, I do this, you do this, and you do this. So we've also got some additional funding that we're just working up a project. So we'll be, and this is coming down through some money through the ICS, and also some additional money through the Southwest Provider Collaborative, to have a team of, they're called key workers, and they're very similar to youth worker type role around supporting young people and families that are on long waiting lists for ASD. Or ASC, sorry. So that'll be for Plymouth, Devon and Torbay. It's quite a big area, and we need to look at how we're going to deliver it. But there's certainly more in the system, and it's a pilot around. So does this support our young people? Does this support our families? What help can we give them? How can we support them to navigate through the system while they're waiting for an assessment, and whether they come out with a diagnosis or not. So there's quite a lot of joint investment, I would say, across the system. Not all of it is recurrent, but it certainly gives us a bit of space and opportunity to look at things just a bit more outside of the box. Can we do this to see whether this makes the difference for our families and young people? Oh, and also we've got some investment from the provider. Thank you, Emma. We've got some investment for one of our VCSE providers. At the moment, they're doing an in-reach into our local acute hospitals across Devon. It's across, is it? Yeah, across Devon. So to be able to access some of this non-recurrent money, we put in a bid on behalf of the ICS system, and we've been able to extend that for another year. So that's really positive as well, to expend the service. So that's just a bit extra to what's on there. Thank you.
I can't read that slide, so I don't know if it says anything about looked after children in there specifically, in terms of system initiatives, whether there's initiatives around specific pathways for our looked after children and how they can access the mental health care that they need.
So we do have a specific pathway for our looked after children of the city, and both from a mental health and a physical health perspective. And we did identify the additional demand within the system last year. We've put an additional nursing post in our looked after children to increase the capacity, rather than putting it in one of our other systems. And there is some work in the ICB, isn't there, around looked after children? Do you want to?
Yeah, just to pick up on that slide, just to kind of context, sorry, and you're right, it's not very clear, so I do apologise, I don't know why it looks so fuzzy. So they are the key drivers within NHS long-term plan priorities that kind of guide the work of the ICB going forward. So they're the key drivers into that. So obviously, yes, children care experience are really critical and an really important part of the vulnerabilities that we know children are experiencing. Need kind of that something different and something unique to meet their needs. And I've completely lost my train of thought.
I've got one more thing to add, if that's okay, while Louise goes back to her train of thought. So we've also, over the last 12 months as a system, so this is not just from an ICS point of view, we've now got a Children and Young People Long-Term Plan Board, and I just thought it's really important to highlight this. So Michelle Thomas is LiveWell's Chief Exec, and she's the Senior Responsible Officer for Children's. So she chairs this meeting, and it's actually a really, really good meeting, because what we do is bring the whole system together across Devon, whether that's local authority. So Emma's always there at the meeting with us, and it's very much a system. So we can make sure that we've not only got the mental health long-term plans, but we're also looking at what's going on in education, what's going on our local authorities, how we're supporting our brighter futures, how we're working with the women and children's bit of the ICS. So actually we're capturing children as a population, not just a group of children that have a specific diagnosis. And I think my personal view is I think that's made a really, really big difference around the more joined up working for our specifically for our children in Plymouth, but also for our young people across Devon.
But I think it's generally making sure that comes down and trickles down to everybody, and stops that silo working, isn't it? And it's making sure that right down to the practitioner on the very bottom level, that they know that it's no longer. Yeah. Do you mind? We've obviously got a second question.
Sorry, I've got two very quick questions actually. You talked about the eating disorder unit, and you said weed. Who's weed?
So it's the provider collaborative.
Oh, right, okay.
Sorry, I forgot to press the button. So the provider collaborative. So the Southwest Provider Collaborative, and LiveWell are part of that organisation. We do very much link up with. So although when I say we, as in the provider collaborative, are doing that, there's also an eating disorder event in couple of weeks across Devon, and we make sure that that locally we're involved, from a system we're involved, and also we make sure that that provider collaborative is involved, because else we run the risk of bits of work going here and here across the system. So it's the South West Provider Collaborative that are doing the business case around the opportunities around having a specialist eating disorder unit for young people within the South West region.
And the person you mentioned, Helen Little, what did you say her new role was again?
So she's a children and young people complex needs integration lead. Sorry about it was a long title and we couldn't quite work out the best way to describe it, but she's to work across the system, and she's going to post for 12 months. So she's worked in the children's system within Plymouth before she came to us, so she does know the system.
Yeah, and I just think she might be an interesting person maybe to go to education scrutiny at some point in the year, just to talk about her work and what difference her role is making. Thank you.
She's already filled a full notebook from conversations with everybody, and she's really key to us because every crisis we've had we learn from, but we haven't yet had the capacity to be able to turn that into the things that we need in the way that we would like. So Helen is our breathing space to be able to feed all those things. If only we had what parents tell us, what young people tell us, and to help us formulate those plans for how we're really going to innovate in that space. How we overcome things like, is it an Ofsted registered thing? Is it a CQC? All those barriers and blocks that we can run into so easily. So she's got quite a lot to do, hasn't she? Yeah.
And I suppose it's also how do we make sure that that academies know all of this that's happening. I mean, because obviously there's no senior school that's still a maintained school, so it's making sure how do you get that information out to them, that if challenged they can't say they didn't know about it, because that's the other thing, isn't it? It can get lost within that system. And I suppose my plea for if we end up having a regional eating disorder unit is it's in the middle of the blasted region, not perched at one end or t'other, so that it becomes very difficult for everybody. Bristol's a long way from Plymouth, and likewise so is the Isles of Scilly, I suppose, really. But we need something that is fairly central, although that might have implications for certain children not being able to go there because of the geography being. So I don't think you'll ever have one unit. There is always going to have to be that exception, isn't there? So, but yes, makes it in the middle.
And I think what we have, and I suppose this is a bit more about reassurance. So absolutely agree. The bottom of Cornwall is a long way from Somerset, and Bristol's a long way from Plymouth and Cornwall. I think what we have been doing, which is actually different than we've done over the years within Plym-Bridge. So we've certainly done some. I suppose the best way to describe it is around a bit of share care between our acute colleagues. So we've had some young people that have been in our acute hospital that needed to be in a specialist eating disorder unit, and we've been able between Plym-Bridge and the local authority, between Plym-Bridge and our acute colleagues and what we're able to provide in the community, we've been able to mould the provision and actually bring those young people over to our Tier 4 unit, even if it meant the fact that they've got to go back over to Derriford every day for NG feeding, but actually they're able to get that mental health support. And you do have to weigh up around the needs of our young people that are in the unit. How does that affect what we're able to deliver them? But also, we know it's not right that these young people are sat on acute hospital. So we've done that with a few young people over the past few months.
NG feeding is
nasal gastric
exactly.
Feeding. Sorry.
Thank you very much, Lee. There's a few of us know it, but there are some that might not. Okay, so that's Louise. You just want to finish off on the specialist?
Yeah, just in terms of eating disorder, I think Tracy referenced it. So one of the things as well. So whilst the South West Provider Collaborative are doing that piece around that specialist eating disorder, what I think as well that Tracy references the next couple of weeks, 16th of March, I think it is, we're holding a eating disorder summit, which is again bringing together providers, commissioners, strategic leaders, whatever you want to call us all into a space where we're looking at kind of what do we need to be doing differently locally, because actually the eating disorder unit is an end point, and where children and young people who need that should be able to access it, but actually what do we need to be doing differently locally that enables the early identification of the children and young people, and actually enabling them to stay home, however they define their home as being. So it joins those two bits up in a really exciting way, which is I think we haven't quite worked together in this way before, and it's quite exciting.
I think it is always quite interesting as to whether when little child Miggins, because I always use Miggins and Mr. and Mrs. Miggins, but when child Miggins starts to develop some concerns about eating, when does it actually become a disorder, and when is it just child showing their independence and not liking a particular food? And that for me is something that all parents should know. When is the point that you think, we've got a problem here, we need to get this resolved?
We are seeing much more of that disordered eating, even around challenges with food when somebody's got obsessive compulsive disorder. You know, there are lots and lots of different challenges at the moment, so I'd absolutely agree. And I think it's really vital around the system coming together to look at it holistically, because what we don't want to think is, oh, well, if we've got an eating disorder unit, that's fixed. The last thing we want is young people in a specialist unit. We need to be able to get in early, like the I Thrive, to stop young people getting to that really high end level of need.
And just like there's teenagers that went through COVID and have their concerns now, you have those youngsters that didn't go to nursery school to learn socialisation and all of those things that are going into school, and hiccups are happening now that we need to get resolved, don't we? So well, then that's the last question, and I'm moving us on to the final session.
Apologise. Obviously, we're talking about children, but there's a parent, and the parents are they're the ones trying to find help for their children. They're the ones noticing issues or concerns at school. I mean, what obviously if parents is there education for parents to understand their child's condition more, and what the treatments and things coming down the road are, so they can understand. Sometimes you meet, like Jemima said earlier, parents very anxious. At the end, they're tethered with worry because you can read things online, but like all these things, you sort of self-diagnose, and it's very stressful for parents, and that's not good for them trying to help a child overcome a mental health issue, if that's what the issues are. So what kind of is there an education program for parents? That's a question.
Two things really. So I think it really is important that we give parents the information around our early help duty worker, because that's the first port of call. What do I need? What am I looking for? Am I worried about an eating disorder in my young person? They can absolutely have that professional discussion with a mental health practitioner to say, what do I do? So that is absolutely imperative. Very thankfully, we've been given a pot of money from the ICB. It's non-recurrent, but it is a pot of money to look at. Thank you. To look at parent and sibling support, because we recognise that parents absolutely need support in that environment. We need to come up with a way of spending that money that doesn't take away from the eating disorders workforce. So we have this money, we need to provide support, but I don't want to take very specialist eating disorders workers to do that. And so we'll look at working with some of our voluntary organisations in providing a space for parents to go and meet other parents, to talk to a peer support worker, to talk to a professional or semi-professional person and say, look, I'm worried about my young person, what do I do? So we're just in the start of that process and looking at how we can provide that support to not only to parents, because siblings really do get when you talk to a family that are living with an eating disorder, very often the sibling is sidelined and becomes less of the focus of the family. And so it's very important that our support also looks at support of siblings.
Thank you. No, we've got 11 to 25. No, sorry, 16 to 25, not 11 to.
So the 16 to 25 pathway is really comes from the long-term plan vision of improving the lives of children and young people up to the age of 25. We know that children don't suddenly reach maturity at 18 years old, and there isn't a switch that suddenly clicks on that says that at 18 you can be responsible for yourself. In a family, it is a progression from 13, 11, 10, depending on the needs of the child. And parents are supporting young people up to 24, 25 now, especially in the times of austerity. So our mental health support for 16 to 25s is really about bridging that gap between our CAM service and another service. And the reason I've said that is because it isn't always to our adult mental health service. We don't want to fulfill the needs of young people by them becoming career patients. We want to avoid them going into adult mental health services as much as possible. So it's about, this pathway really is about scoping and understanding what support young people want, very similar to what we've done with our emotional health and wellbeing support for our under 18s. We're going to take that up to 25. It is in its infancy. We've just started it with investment from the ICB. We are suffering from a recruitment issue, again, into that pathway. But we are working very closely with our adult colleagues in making sure that we have support into our primary care networks. So one of the things that our 16 to 25 workers are doing are going out to primary care networks and specifically holding groups for young people aged 16 to 25 who have specific needs around their mental health, and avoiding them going into pathways of meeting the 50-year-old career patient that's got an emerging personality disorder that can be quite influential. So we're keeping them as a cohort and trying, the whole purpose of this pathway really is to avoid them going into adult mental health services and making sure that we provide the support, signposting, hand holding that these young people need that go towards their adulthood. And one of the things that we got from the Preparing for Adulthood conference that I went to last week was that this needs to be a graduated response, and that young people need to determine how that response is to them, and that they need to be able to access it how and when they need it, not necessarily on a waiting list kind of forum. It is a very small pilot, and we are the funding for the posts are substantive, so it's an ongoing thing. But recruitment is challenging, and we are just really developing our strategy for 16 to 25s and deciding whether it should sit within our CAM service, sit within our adult mental health service, or actually should it sit outside of both and be an independent service. It is more about bringing those two services together than providing a service themselves, because we have about 1,700 16 to 25-year-olds that need support, and they can't individually provide that support for each person. But it's about our 16 to 25 pathway coming alongside practitioners and helping them transitions, because I think transitions is a very tricky period for most young people when they transition not only to adult mental health services or to adulthood, but also they have ongoing needs around their mental health. And we have young people who've described to us that it felt like a cliff edge, and we want to change that so that our 16 to 25 service provides that bridge that enables somebody to move smoothly between our adult service and whatever service they need. I would like us to see a diminishing number of young people going to our adult mental health services, and much more support in our primary care networks for our young people. Once the young people reach adulthood, what we see is that sense of wanting to expand into the world of enjoying their life and not being held back by their CAM services and their mental health. So that's something that we need to capitalise on, most definitely. We've been out to the parent care voice. My next plan is to go out to 16 to 25-year-old young people and ask what they want, and also to we did a survey with our participation partner at the time, from Bernardo's Hype, and they gave us some really good feedback about what 16 to 25-year-old young people want. But I want to get to those young people that have gone through a service to be able to give us some feedback about what it was like for them.
Thank you. That's really quite useful to know, because I think that's always been one of our worries on health scrutiny, is that transition over. And as you say, there will be some youngsters that will not need continuing support, whereas there are others that are definitely going to need. And you know, it jumps out at you already, isn't it? So it is making that an individualised package. Tracy, do you want to come in before I ask Reston for question?
Thank you, Chair. I was just also going to say we're doing some work around SEND as well. So we're also, while we touch on transition, so we're also looking around how our transitions in the much wider context from children's mental health, not children's social care, to adult. And one of the actions we've done around our for the city around our SEND is around our transitions, and that's one of the things that we've picked up to be able to take forward, because as an organisation, Live Well provide, as you know, the adult mental health, but also around how do we make sure that our young people transition from our paediatric specialist nurses into our long-term conditions. There's not many, but they're very complex, and we need to make sure we capture that. So there is a bit of a wider piece of work going around, not just the children in our emotional health and wellbeing services transitioning out, but I just wanted to capture that, and I'd forgotten to put it on the slide.
No problem. Right, I've got Lauren first, then Will.
Thank you. So I just wanted to pick up on transitions, but perhaps of a slightly different type. So between the ages of 16 to 25, your life is kind of like transforming quite radically. You're often going off to uni, doing education, training. What help is there? I'm just wondering about people potentially getting lost in a system when they're moving from one area to the other. How do we manage that sort of transition in terms of location-based transitions?
Do you mean if somebody's coming into?
Yes,
so,
or leaving.
So
and then
if somebody's going out or coming in, so we would refer. So say one of our young people was moving to Devon, for instance, so we would refer. There would be a transition of care. So the care provider at the area where they're living would transfer the care over to the area that they were moving into, and it would be about sharing care plans, making sure that there's a clear process of around where they would access those services. So they're not like, oh, well, we'll discharge you now because you're going to go and live in Norfolk. It's around making sure we transfer the care from one provider to another.
Right, and then my next question, I feel like the words recruitment and retention are like haunting my dreams in every part of the council, and I can make an educated guess as to why that might be difficult for you, but I'd really love to hear what you think the main barriers in that field are for you and your service.
I think there's just not the people out there. I think if I'm really honest, I mean, we've done lots of development posts which have been really good. We've seen lots of areas where we've done development opportunities if somebody hasn't quite, but I think in general, so if you think about, so when I was a sort of a ward manager 10 years ago, if you put out a non-registered post, you'd probably have 50 applicants. If we put out a non-registered post now, you might get 8 to 10. I just think the numbers of people applying are not there where they used to be.
And is that because people aren't going through the training, or they've moved into other sectors?
I'm at a bit of a guess. I think it's an employees market at the moment. I think there's so much, you know, we're talking about the investment we've had within Plymouth, well, that's everywhere, and I think there's potentially more posts within health than there is people to fill those posts. If I had to put an educated case against it.
Thank you.
Thank you. Will and then Sue.
I'm not sure whether the people you would pick up, but obviously there's a lot of students in the city. We've both got University of Plymouth, with the Art College in the town centre, and there's Marjohn's out in my ward. Obviously you've got people within this 16 to 25 coming in. Obviously it's a time of change, people are moving away from those sort of support networks. And obviously people change, you know, as you get older, as you age, you know, these things can become worse or not. And you might have people who've had mental health problems as a teenager, fresh start at university. People do that fresh start thing, don't they? And it doesn't always create a fresh start for people. So is there, if somebody came here as a student, obviously be 18, wouldn't they? Would they be straight to adult services, or is there kind of a, I don't know, a work to kind of, because there might be people who, like you said, people move, Lauren said about people moving out, you know, when they're off to university, there might be people moving in who've been experiencing child service, and then there's this adult services that's a contrast. So.
I suppose that also brings us to what is there at the universities within, and the, you know, we've got now 3 universities, haven't we, within Plymouth and City College. How does that sort of play into all of this?
There's quite a lot in that, and I hope to pick up on the strands of what you said. So I think, I know tomorrow you're going to be hearing around the community mental health framework from Sarah Mitchell. I can't remember who she's presenting with, and I think that will kind of answer some of your questions around, so that kind of the 16 to 25, because what we know is part of the community mental health framework is that importance of young adults, and one of the things that's underpinning our approach, so I'm going to use the children, adults, but our approach to supporting 16 to 25, it has to be underpinned by the brain science that's telling us how brains develop, and what a 16-year-old in a different context has different needs. They may be responding much differently to and need a more of an adult type response to another 19-year-old who may need a much more child response. So we're doing a piece of work at the system that's starting to unpick what is it that we need. So do we need a bespoke 16-25 offer? Do we actually, what we need is practitioners in our 0 to 18 pathways able to respond and meet the needs of the young people, and similarly in the adult side. So the community mental health framework that you'll hear about tomorrow starts to really hone down onto those young adults, and that really draws through the work of the university students, because you're absolutely right, they're in our footprint, and therefore we have a responsibility to support them. But that equally does come with a lot of challenges, because they have a term time and they will then go home, and then an appointment might be offered to them, but they're actually back up in Brighton, for example. As well as you say, the fact of the university. So if we kind of think about that Thrive model, it's how, as a system, are we all working together to support? So I know all the universities do have a offer to their students, and obviously there's some work that we need to do. So our adult mental health services sit alongside that and work to kind of really finesse those pathways as they currently are. But the community mental health framework is really looking at how do we turn that on its head and improve those pathways, making sure that we're getting that support as soon as possible, preventing the need for that specialist mental health response that we really don't want people to have unless they need it. And that's what we need to start recognising. I think you heard this morning, I believe, from Sarah Lees regarding Quell. So again, that's one of the offers that we've done to support the 18 to 25s. So actually what we're getting them is a seamless platform and online offer. Through the procurement that we led, it's the same provider, so actually that does actually aid the transitions and the information across. But what we need to make sure we're underpinning our pathway development on is the brain science that tells us how brains develop and what children, young people, adults need within that.
And children or young people, can they elect to perhaps stay connected to your service rather than leave at 18? Or you might have ones that want to say good riddance and move on to somebody new. Can they? Is there plans that people can elect to say, oh, you know, I'm familiar with this worker or this person I've been working this particular, I'm not particularly familiar, but anyway, you know what I mean, stay with something they're familiar with whilst everything else in their life changes? Or can they say, oh look, I've had enough of you, I want to go somewhere else? Well, people do, don't they, you know?
And I think that's a really good question. I think young people who want to, so we are a 0 to 18 service. So if we keep people in our service longer than over the age of 18, then we potentially put the young people that need to come into the service at risk. So we need to make sure that we've got that flow through. I think the purpose of the 16 to 25 service is that bridging position. We wouldn't necessarily keep them in our service because it's not appropriate. There's all sorts of legal ramifications of how you treat young people in a 0 to 18 service, and people can't quite make a decision that they want to stay in our service because we wouldn't lose anybody. Everybody would want to stay. Of course they would. But I think what we do with our 16 to 25 service is that we take people very slowly. So we do absolutely keep people post 18 in our services if it's not appropriate to move them on, if they're in the middle of a therapy session, if they're in the middle of a planned progression, then we absolutely would keep them. But if they've come to the end of that time, but they are, and I have to be honest, it isn't usually the young person that's reluctant, it is usually the parents that are reluctant to move them into adult services. What we do with our 16 to 25 is that we take that slowly for them. So we would meet with them. Hannah is an absolute fantastic practitioner. She would meet in with that family, and she would gradually move them through to the most appropriate service in a way that is suitable for the young person. The other thing that we would do is that, and I've lost my train of thought now. Is catching it's you. So the other thing that Hannah would do is that she will make sure that the young person is happy with what they are doing. But she's also developing a parent support for transition to make sure. Oh, that's it. I remember what we were going to do. We traditionally have started transition at about 17 and a half. And that's too late. So what we are doing is preparing that transition much more earlier so that we meet the expectations of young people, that they don't reach their 18th birthday and, oh, by the way, next week you're off. We do that at 17 and a half now so that we've got 6 months, but our plan is to take that down to definitely to 17 and possibly to 16 for some young people. And for those with an ascend agenda, then we may even do that earlier because we know that they're going to require some support post 18.
Thank you. Sue?
Chair, I was going to, Will's probably answered most of what I was going to say, which was about giving the young people the same opportunities as those without difficulties within their lives. And if they wanted to go to university, what provision do we as an authority make?
I think certainly from looked after children's point of view, there's a great deal of support, isn't there, for youngsters that want to move on, and I think that's the most important. Emma, do you want to come in?
Yeah, absolutely. So significant amount of support via the virtual school, bursaries for our young people to go to university, etc., and support there. There's also through our Care Journeys strategic partnership with Bernardo's, which is a long-term partnership that absolutely aims to change the metric that our young people who have been care experience. I always struggle to describe this, but they should have at least as good as opportunities for employment, education and training as their peers. They shouldn't be disadvantaged by the fact they've been in the care of the local authority. So a big focus is on how do we make sure those opportunities exist for children in care throughout their childhoods and beyond as well. So, and that's underpinned by the voice of care experienced young people and practical tools, approaches, changes to policy for those children to make sure we get that right, because it's really important. Our new Director of Children's Services keeps saying to me, no child left behind, and that's absolutely the principle.
And of course, they haven't got the bank of mum and dad like our own children have. So I think, yes, it is important that they know that that's there. And John, sort of, I know Charlotte came in for part of the meeting, and that was really great. So presumably there is a good dialogue between Charlotte and yourself over children that are transitioning between one children's services and adult services. You're having dialogues, or it's within conversations.
than it might have been a number of years ago. I mean, that's fair to say, isn't it? It was sort of more of a cut-off point at one point, wasn't it?
And I know also within the transitions around services within Level, we also have a transition meeting. So we've got the adult teams and the children's teams working together as like a bit of a multidisciplinary team, really, to look at the young people to see what their needs is, and then think about what is, you know, with them involved and their families, but it's around making sure that the transition is to the right service rather than, I think historically it's fair to say that, oh, well, you've been, you know, transferred to that, and then that service goes, no, you're not for me, and then well, where do I go? So there is much more on a, I think they meet on a monthly basis, is it? That they meet on a regular monthly basis, and then if it's not quite right for the community mental health framework teams, so what other options are around in the city, and it's around supporting that young person and their family.
And I think actually there's an overlap, presumably, probably a quite small overlap, with clients who've got physical and other behavioural problems who transfer from children's to adults, and that's a whole different ball game. But a lot of work is going into that to make sure that the care is appropriate, because what's appropriate at 18 won't be at 21 or 24 necessarily, for all sorts of reasons. But there is an overlap. Some of your client base would be in both caseworks, wouldn't they?
Louise, last word.
Oh, wow. Crikey, that feels a pressure. I just wanted to kind of highlight in terms of the transition. So mentioning, kind of going back to the eating disorder, the fact that what we're starting to do now is actually have a needs-led, joined-up conversation between children and adults in one space. So we're not doing what's the children's pathway versus what's the adult's pathway, is what's our pathway. And I think that will also kind of move that place that the transition is actually the young person's journey. Not actually, it's 18, what we're going to do, where are they going to go? And I think that's and by really taking a needs-based approach with the community mental health framework, the I Thrive, all of that joining together, I think we'll start to see that real needs will drive the pathway, not the age drive the pathway.
Yeah, I think that is very important, isn't it? I mean, those of us that have had children of our own, we know full well when the time is right to let them go off to see the doctor themselves, or go. I mean, I've still got a 40-year-old that doesn't like going to the dentist by herself, but you know, and I think you sort of have that conversation, and it's got to be the same with any young person, hasn't it? And certainly, I think talking to the Youth Parliament team that came to see us today, I think it's really essential that all this information is shared with them so that they understand, and they can make sure that they're working with young people as well. It's really important, isn't it? Right, I'm going to say a big thank you to all of you for coming today, and then just ask the gang here just to stay for 5 minutes, just so that we can make sure that we've captured all the bits and pieces, all right, before I release them. All right, so thank you. John, it's up to you. If you want to stay, you're very welcome, because you know, you're part of all of this. But if you don't want to stay, if you think you've heard enough, you may disappear by all means. Lovely. It won't be long, I tell you. I think everybody's had a full day.